इथं पण हां
Check.
हॅलो ते 9 वाजता लाईव्ह करायचं शार्प. Good morning everyone. I welcome you all for this third live ENDOSURG surgical endoscopy live demonstration workshop, which will be live telecasted from MGM Medical College Hospital or Chhatrapati Sambhajinagar in association with Association of Surgeons of India. ASI is taking a lot of efforts to promote endoscopy among surgical fraternity. They have many programs for that, and one of that effort is this live surgical endoscopy workshop. This is third year we are doing it, and I welcome you all for this third live workshop, and we have almost more than 40 cases lined up to be demonstrated. I'm sure you will all have a feast of live cases, and it will be a good learning experience for all of us. So with these few words, I welcome you all, and again thanks all office bearers of ASI and my colleagues who have accepted our invitation as a faculty for this live workshop, and also big thanks to all the participants online. They are the one who are making it a grand success. So stay tuned and enjoy. Thank you so much. So the first case, Dr. Mandar Doibade, he will be starting a case of patient presented with acid peptic reflux symptoms. So the diagnostic endoscopy will be done by Dr. Mandar Doibade. Over to you, Mandar.
Hello? Hello, am I audible? Yes, sir.
Good morning everyone. I welcome you all to the third ENDOSURG 2025 endoscopy for the surgeons here at MGM Medical College and Hospital, Chhatrapati Sambhajinagar. We will be starting with our first case for the day. 39 years old male came with complaints of burning in chest and upper abdomen since last 20 days, complaint of vomiting post meal since 20 days, and complaint of generalized weakness since 20 days. Patient has taken H. pylori kit for 14 days. Previous vaginoscopy was suggestive of linear ulcers at lower end of esophagus, multiple erosions as fundus, and large hiatus hernia with grade D esophagitis with fundal gastritis. Plan is for vaginoscopy evaluation.
So good morning
to Dr. Mandar, sir.
Yeah, good morning everybody. So before I begin with the first case of today, I would like to congratulate Dr. Praveen Suryavanshi sir, Dr. Musande sir, and entire staff of MGM for successful organization of this third ENDOSURG conference. It's a conference for surgeons, and at the same time I would like to thank them for inviting me for this. So without wasting any more time, I'll start with the procedure. So this, you have all heard the history. So I'll be starting with a plain diagnostic upper GI. We are using Olympus 170 system. So patient is in left lateral decubitus position, and patient has been given a little bit of sedation with propofol anesthesia. So before we start with the procedure, a few points about the position of the scope. As you can see here, this is the small wheel So this small wheel which moves the, with which we can do right left movements of the scope, we generally lock that small wheel while we are intubating the oral cavity, so that even if the patient is a little awake, he will not move the scope with his tongue. So my scope is walking over the tongue. This is the posterior third of the tongue. You can see the uvula. Once you go beyond the uvula, you will start seeing the epiglottis, and these are the vocal cords. If the patient is awake, we can ask the patient to make sound A or E, so that we can visualize the vocal cord and we can assess the vocal cord movements also. After that, we go into the pyriform fossa. Here we ask the patient to swallow if the patient is awake, and then we insert the scope in the esophagus. So now I have gone into the esophageal lumen. Hope it is visible to all. Endovision is seen to all. So this is the upper esophageal lumen. As we go further down, you start seeing the mediastinal pulsations, which tells us that we are in the mid esophagus. When we go further down, we come at the lower esophagus. So this line is called Z line. This can be made more prominent if the our scope has a chromoendoscopy. This scope has so I'll convert to NBI vision, so that the gastroesophageal junction becomes more prominent. You can see here, this greenish part is the esophageal mucosa, and the salmon color or reddish is the gastric mucosa, and the line between the two is called the Z line. After that, we have to enter into the stomach. Since the patient has a GERD, this is more patulous G junction. After that, we enter into the stomach. Once we go into the stomach, then the scope has to be passed across the greater curvature. See the greater curvature, and then you go into the antrum. Once you go beyond this rugosity which you can see is in the body of the stomach portion. Once you go into the antrum, that rugosity disappears and you see a straight mucosa. If there are peristaltic activities, you wait for the peristalsis to disappear, and then you will start seeing the pylorus. Once you see the pylorus, the scope should be passed through the pylorus. Once you go across the pylorus, you will go into the first part of the duodenum, like this. Now, here you have to unlock the small wheel, and you have to turn the scope on the right side. You turn the small wheel also to the right, and then what is called as shortening of the scope. So during shortening, now the scope, while going across the stomach, the scope was along the greater curvature. That scope will come along the lesser curvature, and that is called shortening of the scope. Sometimes it will slip out like this. That's not a problem. You can go again. And like this, you will enter into the distal duodenum. Normally, if you are doing only a plain diagnostic upper GI, this can be your summit. You need not go beyond this level. But if the patient has something like malabsorption or thing like that, then sometimes you have to go further beyond, maybe up to the proximal jejunum. That time you can follow those curvatures and you can progress the scope to some extent. But for a normal like this, now I think I have gone into the fourth part of the duodenum, and if I try to go beyond this, then I might enter into the jejunum. Sometimes in thin individuals who are short, you can go up to the proximal jejunum. But in a normal routine upper GI, you are not supposed to go so distally. Even if you reach the second part of duodenum, that is good enough. Once we have examined the duodenum, slowly you have to withdraw the scope like this. This is the ampulla of Vetter. In this patient, you can see it very prominently, but it is not the case in every patient. You may not see the ampulla so clearly in all the patients. Slowly you withdraw the scope, see the first part of the duodenum, and then you come back into the stomach. Once you come back into the stomach, then see where your incisura is, and here you have to do what is called a J maneuver, and then the scope will go into the fundus. If you can appreciate, it is a widely patulous hiatus, because the patient has a large hiatus hernia. So for describing hiatus hernia endoscopically, we use what is called as Hill's grading. So this is somewhere Hill's grade 4 hiatus hernia. You can see clearly the Z line from the stomach side also. You see both parts, both sides of the fundus like this. Now assess the hiatus again and then straighten the scope. If you see any inflammatory changes, you can take biopsies from the antrum for doing what is called as rapid urease test or RUT, for looking for presence of H. pylori infection. And once you complete your, here also you can put NBI so that the mucosa becomes more prominent and subtle changes will be seen more prominently. Even things like early gastric cancer can be picked up if you use this NBI examination. If there is any mucus, you can clear that mucus by giving some water jet. Like here some mucus is seen. Pani hai kya? Water, 50 cc. So some mucus is seen. So I'll just clear that mucus by using a water jet. Normally you get a water jet with this, with a simple tap of foot, you can clear that muck or mucus. Or otherwise you can use a syringe to inject water or yeah, like this. So all the mucus was cleared and there is definitely no ulcer, very minimal inflammation. So I think this is the end of gastric examination. Now I'll bring the scope out. So before bringing the scope out of the stomach, you make sure that you suck out all the air in the stomach so that the patient doesn't get discomfort after the procedure. Once you suck out everything, come back into the esophagus. So examination you do while withdrawal of the scope. When you are going inside, your first aim is to reach the second part of the duodenum. Even if you find things like small polyps or ulcers in the esophagus, you don't waste more time examining that while going inside. Once you complete your examination till D2, when you are coming out, then you do all the examination part. I'll come back again at the esophagus. Here you can see a patulous GE junction because the patient has a large hiatus hernia. Again I'll put NBI and I'll assess the lower esophagus for presence of GERD. As you can clearly see, the Z line is little ragged, and now this GERD is also described using a LA classification. So here, according to LA, this is somewhere between LA grade 1 to 2. Since there are no suspicious areas, I am not going to take any biopsy. If you find Barrett's esophagitis and if you suspect presence of dysplasia, then you should take biopsy from it. Here somewhat suspicious area of Barrett's is seen, but according to classification, this should extend beyond 1 centimeter. So this we cannot call clearly classical Barrett's, and clearly there are no signs of dysplasia in this, so I am not going to take biopsy. So this completes the examination. I will slowly withdraw. I will suck out all the air from the esophagus also. You see, you look for presence of things like varices, submucous tumors. Many patients you will find with submucous lipomas or leiomyomas. If you find any of this, then make sure that you examine them properly. And if you find anything,
so second case,
you should take biopsy. You should be very generous. Your threshold should be very low. If you find anything out of ordinary, you should take biopsies. So this is a classical inlet patch. Can you appreciate that? So you see gastric mucosa high up in the proximal part of the esophagus, and this is called as inlet patch. Most of the times this will not cause any symptoms to the patient. Rarely patient can have burning sensation in the throat.
Yeah.
So now I'll come back, I'll again come in the oral cavity, I'll look for the vocal cord movement. Now since the patient is little more awake, I can assess the vocal cord. Yeah, they look normal.
ब्लड ट्रान्सफ्यूजन दिले
Okay.
अॅनिमियाची हिस्ट्री आहे का बेसिकली प्लमर विन्सन सिंड्रोम आहे का काय
So that's it. So that's complete the examination. Thank you. If there are any questions, I'll be happy to answer.
म्हणजे पहिले अॅनिमिया होता
Moving on to the second case, it's a 30-year-old female, ERCP done for choledocholectasis in February 2025. Operate case of lap cholecystectomy in April 2025. No fresh complaints at present. Patient LFT is within normal limits. Previous ERCP was suggested of evidence of stone of 7.1 mm in mid CBD. Suggested of choledocholectasis. CBD clearance and stenting was done. UAG abdominis suggested of post-cholecystectomy status with CBD stent inserted. Now plan is for ERC with CBD stent lumen with stenting.
Grade B GERD.
Over to Dr. Praveen Suryavanshi, sir.
Yes. So good morning, everyone. Again, welcome you all for this third live ENDOSURG endoscopy workshop. And I thank Dr. Mantar for an excellent start today morning with his first case of diagnostic endoscopy. So continuing with that, this is now we have this therapeutic endoscope. This is a side viewing duodenoscope. So whenever I always keep telling all my trainees that whenever if you really want to proceed to the therapeutic endoscopy, while doing diagnostic endoscopy, we must learn the right techniques, right maneuvers to complete the endoscopy. We should not just push your scope because some lumen is visible. Because on diagnostic gastroscopy, where the camera is at the tip of the endoscope, you can see lumen clearly and you can pass or progress your endoscope. But for this duodenoscope, the camera is on the, if you can appreciate, it is on the side of the scope. It is not at the tip. So you don't get to see the lumen nicely to progress or to push your scope. So you have to reach duodenum with the right maneuver. So to master that art of reaching duodenum with the side viewing scope is you must be master with the standard maneuvers that needs to do to reach duodenum. So that's why I keep insisting right from the beginning of your endoscopy training, concentrate on the right maneuvers. With those maneuvers, you should reach duodenum, not just pushing with trial and error. Again, I keep telling that, otherwise Ryle's tube also can reach stomach and duodenum without seeing inside if you keep pushing it. So that should not be the purpose. You should negotiate each and every curves or the organ with maneuver, with intention, not accidentally. So that's why from the beginning, concentrate on the right maneuver. Again, so what is the, see now you will appreciate here, I will not able to see any lumen, still I will reach duodenum without seeing lumen. So that is because of we have to do the maneuver without looking at the lumen. See now I am passing through the esophagus. I am not able to see esophageal lumen. I am able to see the wall of the esophagus, but at 40 centimeter, I know there are going to be a esophageal junction. So I do maneuver I will turn my scope anti-clockwise. See, I have entered into the stomach without seeing the lumen. Okay. Once I have entered without inflating much gas, again I have to do the clockwise rotation of the scope with big wheel up, and I have to keep pushing the scope against the greater curvature to reach the pylorus. So now you will appreciate I have reached the pylorus here, and once I have reached the pylorus, I have to do big wheel low and push. I have reached into the first part of the duodenum. Again, then rotate the scope clockwise to reach the second part of the duodenum. See, if you have appreciated without pushing the scope from the first part, I have reached the second part just with this maneuver of clockwise rotation with big wheel up. Now I am straightening the scope and I have reached the deep into the second part of the duodenum. Now you can appreciate here there is a previously placed stent, which is a 10 French 10 centimeter single pigtail. Open. So always catch. Try to hold the free end of the stent. Don't try to hold anywhere in between, because then in that case the stent will not get straightened up and it may injure this narrowest portion, especially at the cricopharynx. Now you must keep seeing this stent at the on the screen under CM screen to make sure that it is coming out without any obstruction. So once stent is out, so what we do, our practice is that if the previous ERCP was a simple, solitary stone without, much manure, if you could remove those stones, then we just remove the stent within 6 weeks, 6 weeks to 12 weeks of ERCP. If there were multiple stones, or we had to fragment the stone by any EHL or the mechanical lithotripsy, or patient has presented 6 months after the primary ERCP, then we always do swapping of the corn bile duct after taking out the stent. So these are the indications where you should not just take out the stent, because after that patient may land up in the cholangitis and jaundice. So if there is a previous stricture, CBD stricture, or now you can see we enter into the corn bile duct, inject. Okay. You can see this nice cholangiogram. So you must, keep reading each and every cholangiogram to train yourself. Just don't concentrate at the common bile duct and common hepatic duct. Intrahepatic biliary radicals patterns, there are different variations. You must keep observing in each and every case. For this case, it may not be relevant, but you can train your eyes to understand them, to identify them, those variations or anomalies, so that now you can see that there is trifurcation of the biliary this tree in this patient. Okay. So these are very common findings. So unless you train yourself, you will not able to appreciate it. So you go. This may help you during intraoperative cholangiogram whenever you are in problem doing some difficult gallbladder case or doing some difficult, or you are injured common hepatic duct doing cholecystectomy. So in that case, defining this complete biliary anatomy is very, very important. So keep reading whenever you get possibility, opportunity to understand these biliary anomalies, either on the CT scan, on MRCPs, or on the cholangiogram. So whenever you get, try to read out everything so that you are well versed with all the variations and you can identify them at the right time. So now there is no any significant filling defect. Whatever all these small defects you are seeing, that is because of the air. So very circulated, small, multiple, floating, these defects, these are the air bubbles. So this patient had multiple, in fact, multiple small stones. So whenever, these are multiple small stones, gallbladder also had multiple small stones. So in that case, we prefer to, do swapping after taking out the stent. I request all the viewers online, they can, in chatbot, they can post their questions so that we can answer them. So again, go at the highest possible level in the common hepatic duct, inflate the balloon and bring it down. And whenever you are at the ampulla, just turn the scope. Can you appreciate? One stone has come out actually. See now. See, in fact, there are two stones. So this is what happened. So this stone must have slipped during the surgery. Inject. Inflate. That's all. Thank you. So this is importance of doing this check or balloon swapping after taking out the stent. So this is our routine practice that if there are multiple stones, multiple small stones or multiple small stones in gallbladder with wide neck, or we have to do multiple maneuvers like mechanical lithotripsy or EHL, then in that case we do balloon swapping after taking out the stent, and these are the benefits. You can appreciate there was a small residual stone which we could extract. Otherwise, this patient would land up in the obstructive jaundice and maybe sepsis. Thank you so much.
Hello,
Next.
Praveen.
Yes.
Good morning, Dr. Makarand here.
Yes, good morning, Makarand.
Wonderful demonstration.
Yeah,
that I
thank
have
you.
seen. In which cases we should suspect the slippage of the stone in the common bile duct while doing the laparoscopic cholecystectomy?
See, again, routinely, as I mentioned, if there are multiple small stones in the common bile duct and cystic duct is dilated wide, and if it's patent, if you find the cystic duct was patent, so then you can suspect that some stone might get slipped into the common bile duct during surgery. Okay. So that is one more indication. Another is, suppose there are multiple stones in the common bile duct at the primary ERCP.
Yes.
So sometimes some fragments, some chips, they remain behind.
Okay.
And you are not always sure that every is completely clear. So you take last chance to swipe out if anything is there. So that way, in those cases also, we do balloon swapping after taking out the stent. But if there was a simple single stone and we have cleared common bile duct, again gallbladder, there was another single stone which was not very multiple large stone, or the cystic duct was it was not patent, dilated. Then again, before taking decision of taking out the stent, we always do sonography, and in suspected cases LFT.
Yes.
If LFT is deranged, or if there is suspicion of a stone on sonography, then definitely irrespective of whatever previous ERCP findings are there, you should do balloon swapping after taking out the stent.
Yes, yes. Thank you very much.
Yeah.
Wonderful demonstration.
Thank you. Thank you, everyone.
Good morning, sir.
Yeah.
Srijayan here. I am watching. Wonderful demonstration. Thank
Oh,
you, sir.
thank
for
you.
the
Thank you,
opportunity.
Srija. You are the guest which has come from the longest distance for this workshop. Thank you so much for joining us.
Thank you, sir. Thank you for the opportunity.
Thank you. Next case. चलो तो
Hello, 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 hello. Hello. Yeah, moving on to the next case. A 35-year-old female came with complaints of difficulty in swallowing since 5 months. History of burning type of pain in the epigastric region aggravating post-meals. History of vomiting post-meals. Patient's blood invasions were within normal limits. Now plan is for diagnostic OGD. Over to you, sir. Advay, sir.
Hello, am I audible there?
Yes, yes.
So at the outset, I would like to congratulate.
Please increase the volume. Volume is much less.
Volume. Hello. So at the outset, I would like to congratulate Dr. Praveen Suryavanshi sir, Dr. Musande sir for organizing such a grand event. So we have already heard the history of this patient. She has dysphagia. Mandar has efficiently demonstrated a diagnostic upper GI. So we will just progress. So I am following the median raphe over the tongue.
There is no picture of endoscopic picture, please. Yes, now we have got it.
So now I am in the pyriform fossa.
Yes.
And I will like to negotiate through this. We are suspecting some web, as I was told. So gently we will negotiate across the pyriform fossa.
Yes.
I can feel some resistance here, but yes.
Yes, yes.
Can you appreciate the
Yes, yes, yes.
narrowing in the just post-cricoid region?
Is there any web or stricture?
Yeah, there is a web. Can you see here?
Yes, 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 yes. Nicely seen.
See, here
Yes, yes.
you can see the web.
Yes, yes.
Now my plan would be to dilate this web.
Okay.
Archana is going to assist me.
Yes.
I am using guide wire, zebra guide wire. Cap wire takayla.
Such type of waves are common in Plummer-Vinson
Yeah,
syndrome.
it is very common in Plummer-Vinson syndrome.
Yes.
Where the patient has anemia and this. It is a nutritional phenomenon. Of course, it is a precancerous lesion.
Yes, yes.
So this patient should be kept in surveillance.
What type of anesthesia given?
We are giving propofol anesthesia, TIVA, rather than total intravenous anesthesia with propofol.
Okay.
I am not worried about the patient because MGM's competent anesthetic
Yes,
team
yes.
is handling it. So we are waiting for the wire.
Many endoscopies try to dilate this wave with the scope only. Is it?
It is not advisable, sir.
Yes, yes.
If you forcefully try to enter,
Yes.
and especially if the patient is awake.
Ah,
So see this type of erosions you can create,
yes.
and then there might be a risk of perforation.
Yes, yes.
So I know many people do it with the scope itself,
Yes.
but I would not prefer it because it is quite a blunt procedure, and dilating such a web which is quite easy, which
Yes,
many surgeons can take up,
Yes.
who are efficient in doing a diagnostic upper GI scopy.
Is it advisable to go for stricturotomy and then dilatation rather than going dilatation only?
Stricturotomy, sir, you cannot see a clear-cut
though there is a web and the scope, and this is for the first time
Yes.
the patient is undergoing dilatation, so I would straight away go for routine Variceal dilatation rather than stricturotomy. Of course, if it recurs frequently, then
Okay.
I would go for stricturotomy, because here the space is very less,
Yes.
and
Yes.
doing a stricturotomy would be a problem. So you can see under vision, my
Yes.
guide wire is nicely going across the stricture,
Yes. Yes.
and
Wonderful.
if we have Siam, can you get the Siam picture? See, we are deep into the stomach with the guide wire. We have
Yes.
crossed the dome of the diaphragm.
Yes. Yes.
So I am happy with the placement of the guide wire. So now I will gradually railroad the scope and try to maintain the position of the guide wire here, and I will ask my assistant to, once the scope is out, to hold the guide wire for me in place. Guide wire पक्की पकड़, हाँ टाइट पकड़ायची. एक मिनिट ओढू नका.
One practical suggestion can I give?
Yeah, yes sir.
I am doing endoscopy since last 15 years, upper GI and colonoscopies.
Yes sir.
In such case, only taking biopsy from the edge of that web will give release because it will be the scope will be very easily able to we will pass. Balloons are very costly. Balloon is at least I think 25,000.
I would suggest a Variceal dilator. It is a one-time investment,
Okay.
and it will last you for maybe, I think an endoscopist will have to buy it once in his lifetime.
Yes. Yes.
And it is quite easy, very easy procedure.
Yes.
Motor
Yes.
gear. So this is a one-time investment. So I would prefer to do a dilatation over just taking a biopsy.
Okay. Okay.
माझ्याकडे द्या. इकडे. Am I still audible?
Yes. Yes.
Because that mic's cushion has fallen off. So can you see the Siam?
No. Siam. Yes. Now we are able to see the Siam.
So now gradually I am railroading and keeping a slight tension on the guide wire. My
Yes.
dilator will slide over the guide wire, and I have crossed up to the stomach. Since I know that the stricture is above, so I need not to push the entire dilator
Yes.
into the stomach. Then again I will railroad and remove this dilator over the guide wire. Ask my assistant to hold the guide wire. Guide wire पकड़ा इथे. Tight पकड़ा.
Hello.
Praveen.
Makaran. See, this indication for the cutting the stricture with the energy source
Yes.
is you must do it in very selected cases.
Okay.
For that, first thing that it has to be fibrotic stricture.
Yes.
Take a tight fibrotic strictures.
Yes.
And another important thing, it should be a very short segment stricture.
Yes. Yes.
If these are the long stricture, then really it's not possible, and it should not be done also.
Yes. That is not useful also.
Useful also. So the first thing is the fibrotic stricture. These esophageal webs, they are not fibrotic strictures.
Yes.
I agree with you, sir. And also this stricture is in immediate post-cricoid region where the maintenance of the scope is very difficult and tricky. You might injure the lateral the esophageal wall and cause a full thickness stricture, injury.
What should be the frequency of dilatation after once you have dilated?
Sir, there are two schools of thought. One I would prefer is elective dilatation after every 6 weeks, even if the symptoms don't recur.
Yes.
And the another school of thought is dilatation on demand. Once the patient recurs with the symptoms, but in my setup, I prefer the protocol of elective dilatation for at least 2 or 3 sittings, and then keep it on demand.
Okay.
So can you follow the Siam, please? So I have placed my another bigger dilator, and it is now I am feeling some resistance, but I have gone through. I think this is 11 number dilator. So we have achieved dilatation up to 11, which is okay.
Yes, yes.
So what we will do is we will do a check scopy by
Yeah.
the side of the guide wire. We will keep the guide wire in place just for our guidance, and we will try to negotiate the scope across. Scope, please. So in such cases of Plummer-Vinson syndrome,
Yes,
we need to maintain the post-op nutrition of this patient
yes, yes.
and
Hemoglobin.
keep them on hematinics so that their hemoglobin doesn't drop.
Yes.
Though here we heard that her lab parameters were within normal limits, but most of the times these patients are anemic. So now again I am in the post-cricoid pyriform fossa. I am trying to negotiate gently through across by the side of the guide wire, and you can see we have easily negotiated
Yes, yes,
into
yes.
the esophagus. There are some amount of
Blood
oozing
there.
which is self-limiting. Now since I am into the esophagus, I will ask my assistants to remove the guide wire. Guide wire kadun taka. Kadun taka. This check scope is also very important because sometimes there is a growth below the stricture
Yes.
which we need to biopsy. And now I am into the stomach.
Yes, yes. Very nice.
Okay. So we will just complete the diagnostic gastroscopy for her. So now we are in the antrum. Mandar has already demonstrated how to negotiate the pylorus, but here we can go near the pylorus, give some air. It is already open. So now here I am in the first part of duodenum, and then I will make a movement on the right, big wheel up, small wheel to the right, and now I am into the second part of the duodenum.
Yes, yes.
I need not to go below there. The mucosa, if you see in the duodenum, appears to be normal, so there is no signs of malabsorption. There is no cobblestoning of the mucosa, and so we are not taking duodenal biopsies here. We
Many
again
times we
inspect-
see a lot of froth, white froth. Is it
Yeah, yeah.
Is it necessary to wash it and then wash the mucosa?
Yeah, it is, if you really suspect a malnutrition, because but in here the patient is having the blood parameters were normal.
No, no, froth, white froth in the stomach.
Yeah, yeah, I agree with you. There are some drugs with cymethicone, if you give them prior half an hour, so
Okay.
this froth can be reduced.
Okay, okay.
But it just adds to the cost of the patient sometimes.
Yes.
But many centers follow that protocol.
Okay, okay.
Good morning, everyone. I would like to request Dr. Makarand Patki sir and Dr. Sanjay Khandagle sir, senior surgeons from Chhatrapati Sambhajinagar, to please chair the following session.
So now we are coming to the post-cricoid region. I am withdrawing the scope gradually.
Yes,
You
yes.
can see that there is some oozing, but it's self-limiting most of the times. No need to do anything. And here is the segment which we dilated.
Dilated, yes.
There is no full thickness injury. There is no perforation. Gradually, and there is no abnormal mucosa also. So no need to take a biopsy from here. And we are completely gradually inspecting. It is a nice dilatation
Yes,
done
yes, yes. Wonderful.
without any perforation. Thank you.
Thank you very much, Advai. Very wonderful
Thank you, sir.
demonstration of dilatation.
Any questions, sir?
This region is also, we see commonly the inlet patch.
Yeah,
Uh-huh.
we can see an inlet patch here sometimes, which is suggestive of reflux disease.
Yes.
There is no need to take a biopsy. It is only suggestive of a reflux disease, and you need to explain the patient that this is a benign condition, and
Yes.
usually no need just PPIs and treating the reflux will take care of it.
Yes, yes, yes.
Correct? Which are? Thank you, sir.
Yes, wonderful. Nice.
Yeah.
Okay. Shifting to OT2, going with the fourth case. 24 years old female came with complaints of pain in abdomen epigastric region since 6 months, pain aggravating post meals and complaint of nausea and vomiting since 2 days. Patient blood investigations are within normal limits, and now patient is posted for diagnostic OGD. Over to you, Dr. Joy, sir.
Start? Yeah. So this is a patient of epigastric pain, which we are evaluating.
Yes.
So as we go inside, this is for beginners. You can see the tongue, the base of the tongue, the epiglottis. You just go below it, and then you see the vocal cords here.
Yes, yes.
Okay. And this is the pyriform fossa, the left pyriform fossa and the right pyriform fossa. This is important places not to miss, because these are the places of malignancy very commonly found in the upper GI,
Yes, yes.
in the oropharyngeal region.
Yes, and base of the tongue.
Yes. And this is the airway.
Yes.
To me, this looks slightly edematous. Maybe this patient is having long-standing reflux, or so this is one of the places where people find it, the beginners find it difficult to negotiate. It should always be done under view. Keep looking at the lumen. Keep looking at the lumen. Yes, this is a very a young lady, but I can say the esophagus doesn't look that healthy.
Yes, yes.
Yeah. You come here at the lower end. Okay. This is the Z line. You can see, if you can appreciate, the merger of the stomach mucosa with the esophageal squamous mucosa. Okay. Important is you have to note the distance, which is around 35 in this case, and then gradually look at the G junction. To me, it looks erythematous. It doesn't have any obvious erosions. There is one tongue of mucosa.
Yes, yes.
There is a tongue of.
Can you put on NBI?
Yes, NBI concern. One second.
Yes. No problem.
No. Have to freeze it.
Yes, yes. Now
Yes.
the tongue will be very well appreciated.
So here you can see the hypervascularity here.
Yes, yes.
Okay.
Yes, yes. This
Can
is
you see the tongue of mucosa
yes,
here?
Yes, yes, yes.
Okay. This is very clearly
Wonderful,
seen.
wonderful.
Yeah.
Yes.
So that is it. So this is the evaluation of the G junction. To me it looks slightly lax. Normal. And then you go into the stomach.
Is it malignant lesion?
Yes,
Yes,
this
yes.
looks something ominous.
On
Not happy with the look.
Inciso
See,
and-
one, the orientation of the stomach, it is not as normal. It would go directly to the pylorus. Here it looks
Yeah.
to me like this is a constriction
Yes.
in the corpus. Okay. So now, and this is the ulcer.
Ulcer, big ulcer.
It is a big ulcer with the margins
Yes.
proliferating, and the base is having slough. So this is a classical ulceroproliferative lesion.
Yes, yes.
The first diagnostic differential is definitely malignancy to be ruled out. Okay.
Yes, yes.
So we will come back and evaluate it. I'll just go further and see anymore, and then we'll come back and in detail evaluate this lesion. Let me see. So I'm trying to get across, but yes.
I think it will be easy if you deflate the stomach.
Yeah.
And follow the lesser core. Yes,
Yeah,
yes.
yeah. Here is the pylorus.
Yes,
See,
yes.
the stricture is here in the body, and this is the pylorus.
Yes, yes.
Looks quite okay. And then, okay,
Yes, yes.
okay. We're just evaluating the duodenum. I would always suggest beginners to go as much as possible using the scope,
Yes.
because recently we found a aortoenteric fistula in the D3, D4 region.
Wonderful, wonderful.
So,
This is upper enteroscopy.
yes, there is no harm in
Yes, yes,
going it and evaluating.
Yes, yes.
And if it is a routine thing for me, I make it a point and ask my fellow juniors also who do it, so that it becomes a habit for you to
Yes, yes.
keep seeing. And 99% of the times you may not get anything, but there is always a possibility, especially in GI bleeds.
Is it possible to diagnose SMA syndrome in such with
Yes,
such technique?
definitely. SMA syndrome we can diagnose, but I can tell you one thing, that SMA syndrome, the investigation of choice is not an upper GI endoscopy.
Yes.
You can see the SMA pulsations,
Yes, yes.
but the best investigation is a CT with oral contrast. Okay.
Angulation is important.
Yes, the angulation. Here, now you see how much of the length
Yes,
we
yes.
are seeing while coming out. लॉक एक मिनट इसको पकड़ी लो. We are still in the duodenum. You can see the duodenal folds. Note this duodenal folds.
Yes, yes.
Once because of that stricture, the angulation is slightly difficult, otherwise we can
Yes, yes.
hold it. Pakda. See, now this is the D1 where this is the pylorus, and if you see the D1, can you see from here?
Yes.
The folds are less prominent.
Yes, yes.
Okay.
Which is the blind area?
This is also called the graveyard of the endoscopist,
Uh-huh.
because look here, this is the D2 region,
Yes.
and then when you come out, suddenly, especially when you're not very, you're a beginner, there is a tendency that this slips off.
Yes.
And you may miss lesions in this region. So always important to look it in all angles, circumferentially, and always having the lumen in the center.
Wonderful, wonderful.
Okay. So now this is the pylorus, the antral region. The stomach here is deformed.
Yes.
I am saying so because my movement is not as usual it should be. I have to make some different movements to get into the pylorus. Okay. So now this is the ulcer.
Yes.
Okay. So
Is it on greater curvature?
I'll show you. So this is the G junction.
Yes.
As we come in, so can you see the scope?
Yes.
The scope is going along the greater curvature. एयर इंसफ्लेट करो, एयर का पंप बढ़ा लो, लीक नहीं एयर चाहिए मुझे. नाही ना ब्लू तर दाबलं आहे पण एअर. So this is the lesser curvature, the shorter route to the pylorus, and this is the greater route to the. Can you see the long curve it is taking?
Yes.
If you see from here, the route on the right, on the right side of the screen is the lesser curvature.
Yes.
And this one here which I am showing is the greater curvature. So as you see, the growth is there on the greater curvature side.
Yes.
Okay.
Yes.
And clearly not a very nice punched out ulcer or anything. It is very irregular, ulcerated and proliferative. So high possibility of malignancy. So we'll take a biopsy from it.
Yes.
Okay.
Is there any role of NBI while taking the biopsy?
Sir, NBI, I would say it is good for early lesions like the tongue of mucosa you see.
Yes.
But in such very evident lesions where there is a clear ulcero and a normal mucosa margin, I don't see much of a lesion. But yes, you can see. Have a look at this normal mucosa.
Yes.
The reticular pattern.
Vascular pattern, yes.
Come over here and look at this lesion at the margin.
Yes.
You can see that it is becoming irregular, and right at the margin it is very dense, hypervascular, and rest the ulcer is obviously seen because it is having slough.
Yes.
Again here you can see the vascular pattern.
Yes.
Okay. It is highly irregular, very classical of malignancy. Okay, so hold karo. Biopsy forceps. Sorry. Minimum how many biopsies should be taken, sir? Sir, at least 2 to 3 biopsies we take. Biopsies depend on what is the pathology. So if you are taking in a case of ulcerative colitis, then you have to take from each of the segments 4 biopsies. Yes. Here, the area where to take is scope agad lenge. The margin is here.
Yes, edge biopsy.
Yeah. Kholo. Close. See, here we got just the margin.
Yes.
Okay. I'll try to go. Hold it. Scope हम पकड़ा. Scope ऐसा पकड़ा. ऐसा पकड़ा. Open. Catch. Yes, here we got a good
Yes.
punch.
I think it is always better to go for well technique to dig and take the deeper biopsies.
Yes, so the first biopsy we have taken it.
Yes, yes.
That is also called the biopsy on biopsy technique.
Yes, yes.
That is a very effective way for lesions, especially which are not so evident like this. Sometimes the lesion may be submucosal, maybe a lymphoma which is growing.
Yes, yes.
So in such cases, okay, so this is called biopsy on biopsy. Open.
Yes.
Nahin. Catch.
In gastroscope, the channel is 2.8 millimeters. That's why this is the only forceps. But in colonoscope, we can take the biopsy with jumbo biopsy forceps, which is bigger and gives a good amount of tissue to the pathologist.
Okay. यहाँ पे दिखा सकते हैं आप?
हाँ, yes.
We'll just show you the ये वाला यहाँ पे.
Yes, yes, yes.
I can't see. Okay. So these are the biopsies. I cannot see it, but I hope you are appreciating the 1, 2, 3 pieces of mucosa we've got. Again, I'm not still very satisfied.
Yes.
I need to feel that crunch of the malignancy, that hard feeling, and then I'll stop. So one important thing we need to know is that histopathology is one aspect. At the same time, while doing endoscopy, you should have a visual diagnosis as well, which is very important.
Yes, yes.
एक मिनट स्कोप हम थोड़ा जाए
Dr. Joy,
yes
there is a question online because we have
yes please do
we have YouTube viewers also.
Catch.
So one of them has asked, how do we send the biopsy in normal saline or formalin? That's the question.
No, this is a malignancy, so you have to send it in formalin only. So if it is a culture, if you suspect some infection, then maybe you take it out, split the samples, but this is clear malignancy which has to be fixed in formalin.
Yes, yes.
Open.
If you suspect tuberculosis, then you can send in normal saline for TB PCR.
Yes. You want me to send it? I don't think, I
No.
doubt this is open.
This
Punch.
is clear-cut malignancy.
Yes, this is clear-cut malignancy. Yes, I got it there from the base as well. Okay, so we got enough biopsies. I think we'll... so I was saying something that when you do endoscopy, you should have a visual impression, which is very important. Because many a times I have seen that you take the biopsy and the biopsy comes out to be negative. Suppose this biopsy comes out to be negative. What is the next step? depends on the visual impression of the surgeon or the endoscopist. So if you have a doubt that this is malignancy and visually you were pretty sure that this was malignancy, then you should insist on going back and getting a biopsy. Otherwise, what will happen? A report of benign lesion will go to the patient, and then the patient may go on for another 6 months and come with a very advanced malignancy, maybe which is not possibly curative. So it makes a huge impact. So that is the reason the visual impression of the endoscopist is very, very important. So here we are done with the biopsy.
Can I add one practical point which I have experienced?
Definitely, sir, please. Your experience is valuable.
So while pulling the biopsy forceps in the channel, there is some tissue loss. So I usually take the forceps with scope. In the last piece will be bigger. Last piece will be bigger.
Okay, okay. So we will do that, sir. We will follow what you said. I appreciate that. That's a very good point which you made.
Yes, thank you.
So what sir wants to say is, see, you take a biopsy, and when you pull it out of the channel, everything sticks, a lot of things stick in the channel.
Hello, sir. Hello.
Yes, I can hear you.
Yeah, I am Dr. Amarvani. One question from my side.
Yes, catch.
Is there any role of EUS now at this stage?
Why do you want an, I would ask you, why would you want a US?
So, see, visually you are sure it is a malignancy.
Visually,
you are sure that it is a malignancy.
So how is the, see, I think this would be a better discussion. So I am asking you counter questions rather than just answering you.
See,
so what is your thought process when you ask for an EUS? Why do you want an EUS in this?
So one thing is to know the depth of this ulcer.
Yes.
Second thing is the lymph node status.
Okay. Fine. So I will answer it. So the way this mucosa is ulcerated and going, the main purpose of EUS is, one is staging of the T stage, the T, and the peritumoral N staging. There is T, N, M classification. The tumor staging can be done T1, T2, T3, T4. This visually to me itself is T3, T4, I would say. Okay, so why do you want an EUS? I'll withdraw the scope with the forceps and we can discuss it. So when the purpose of doing an EUS is it amenable to endoscopic?
Mucosal resection.
Yes, endoscopic mucosal or submucosal resection, and here you can see the lesion, the mucosa is so badly ulcerated that it is an advanced case itself. Okay, so EUS is good in very so EUS is good in advanced very early lesions where you can contemplate a submucosal resection. But in lesions such as this, there is no role. Even if you do a EUS, you will have to do a CT scan to get the T stage and the M staging as well, because in this case I would definitely इधर से निकाल रहा हूँ, खोल दिया था. I hope I have answered your question, doctor.
Yes, sir.
Okay, so advanced lesions, no significant role of EUS. Whereas early lesions, definitely a lesion. If this was a very small ulcer, I would have thought about it.
Dr. Joy, there is one more question from the YouTube viewer.
Yes, sir.
That what is the number of samples you have to take from the ulcer, and is it necessary that we have to take it only from the edges or not?
So the number of, as I said earlier also, in a malignancy, like lesion number is dependent on different lesions. In colon, in ulcerative colitis, you take from different biopsies 4 punch biopsies, whereas in malignancy 2 or 3 biopsies right from the edge. Edge is the area. If you take right from the ulcer base, you will get slough tissue. Whereas if you take from the margin, you will get the growth. So the margin is the place from where the border between the normal mucosa and the ulcerated mucosa, that is the area from where you should be taking the biopsy. You can please give your comment, sir. So we are done with this case. Very important to communicate with the patient's relative about this finding.
Very nice demonstration, Dr. Joy.
There was one of the one comment in the. I hope we are not delaying for the next case. If it's so, you can move on. There was one comment in. It is a good thing for this ENDOSURG for the surgeons. So usually I used to teach at SVP NHL Medical College. So I tell my GI surgery residents that most mythology have, like Shankar has his Trishul, the Greek gods have their trident. So the surgeon also should have a Trishul. One of the Trishul is laparoscopy. The other point is endoscopy, and the third is radiology and ultrasonography. If you know all these three, or you're reasonably good, I can tell you, you can be as invincible as Shiv.
Yes.
So to become an all-round surgeon, I would say more than an MCH degree or in a GI, you need an all-round, like
approach.
How a lesion looks from inside, how a lesion looks from outside. So it gives you a 3D view, and I can tell you that it will make you a different surgeon,
Yes,
a much
yes.
more capable surgeon. So that is the reason this endoscopy for surgeons, and I really appreciate Praveen sir for having organized this so well. Such good cases. Many cases are yet there actually. Okay.
Yes, yes. Wonderful demonstration, Doctor.
Thank you, sir.
Over to OT number 3, Dr. Mandar sir.
Yeah. CA body stomach.
23 years old female came with complaints of difficulty in swallowing since 1 month, complaint of nausea and vomiting, history of similar
Esophagus.
complaints 2 years back. She was diagnosed case of chronic iron deficiency anemia
Lower
with
and
multiple transfusions in the past.
shows
She is a known case of Lummer-Vinson syndrome.
changes
History of esophageal dilatation
of
done for
erosion.
upper esophageal web 2 years back.
G junction erythematous.
Plan is
okay.
endoscopic evolution,
fundus,
SOS esophageal
normal.
dilatation.
Stomach deformed लिखना है सबसे पहले.
Over to you, sir.
Okay. Stomach.
So
हाँ, disoriented लिखा है कि deformed.
hello. Good morning all again. We'll be starting with this second case of esophageal web. So you have heard the history. So now my plan is to evaluate, and if it is conducive, then I am planning to go for pneumatic dilatation. In the first case of esophageal web, Advait showed us the dilatation with Savary-Gilead dilators. Now here I will try to evaluate, and my plan is to go for pneumatic dilatation using a CRE balloon. We are just waiting for the patient to get anesthetized. So this patient has had this history of esophageal web, and she has undergone dilatation in 2023, and now she has again developed a recurrence. So probably this is a case of Lummer-Vinson syndrome. So the main cause of this esophageal web is iron deficiency anemia. So the theory is, because of chronic iron deficiency anemia, there is oxidative stress, and because of oxidative stress there is okay, I'll begin with the case now. So am I visible? Are you
Yes,
getting
yes,
it?
yes, yes.
Yeah. So this is I have reached the pyriform fossa. So I can't see any opening. So such cases are not ideal for pneumatic dilatation. So I will go for SG only, fabric because I can't see the lumen at all.
Yes.
So I will try to pass a guide wire. Pakda. Sister mala hai wire there. And as I said, we can do this dilatation using a CRE balloon, but for that you should be able to see some lumen. Since I cannot see anything, I have cancelled the plan of doing pneumatic dilatation, and I will go ahead with SG dilators only. So same thing, now my guide wire has come. So I will try to pass the guide wire across the stricture using a fluoroscopic guidance. Sometimes it will go with a U. Siyam bagu mara. Shoot. Are you getting the hey halwa na? Wires halwa? Wires mare rehta hai. Are you getting the fluoro image? Sir, are you getting the fluoro image?
Yes, yes.
So my guide wire has gone very smoothly, and I will just evaluate again. So here we are using a specially designed little stiffer guide wire. Kada scope. Slowly, once the guide wire is kada. Nicely in position, I will slowly take slowly take out the scope, making sure that the guide wire stays in position. Shoot. Kadu. Sorry. Here. So I'll start with number 9, aciditis number 9. So it was a thing like a corrosive stricture or post malignancy stricture. Then we should start from the lower smallest possible dilator. But here, since it is a case of esophageal web and I could see some lumen, so I have decided to go with number 9. So here all the time you have to confirm the position of the guide wire. Sometimes accidentally the guide wire can come out. You have to lubricate the tip of the dilator and slowly pass the guide wire again using the fluoroscopy guidance. Can you see the dilator going in?
Yes.
So these dilators, they have a khali kya? So okay. So these dilators have a see the varti, thoda varti. Yeah. So this black dot, can you appreciate? So that is going down. So that is the widest part of this dilator.
Yes.
And you have to make sure that that part goes beyond the level of the stricture or beyond the level of the web. Kada. So because the tip of the dilator is beveled, so only if the tip goes inside, it will not bring out the desired level of dilatation. So you have to make sure that the widest part of the dilator crosses the level of the stricture. Normal gastroscope is generally 9.5 millimeters in diameter, outer diameter 9.5. So if you want to pass the scope, the dilatation should be at least till 11. Shoot. Khali.
I think NBI scope is 95 and 150 series was 92, 9.2 millimeter.
9.2, yeah.
Is it necessary to keep the dilator for a few minutes?
Sir, actually there are no clear-cut guidelines.
Yes.
But see, each endoscopist has a different practice. So what I generally do is the widest dilator which I pass, that I keep for a at least for half a minute or 1 minute full,
Yes.
just to make sure that complete dilatation has happened. But there are no set rules for how
Okay.
much time you should keep it.
Yes.
Generally, CRE balloon, if you are using that, we definitely keep it for 1 minute at least.
Yes.
मी करतो. नको. Shoot. Okay. So since this is a web, the stricture is at the proximal level. But if the patient has a stricture in the lower esophagus or mid esophagus, then you have to make sure that the dilator has gone completely beyond the level of the stricture, and that's why fluoroscopy is a must. Sometimes if you are using a CRE balloon for dilatation, there you can get away without using a fluoroscopy. But if you are using these AG dilators, fluoroscopy is a must.
Yes. CRE balloon is a transparent balloon and you can see the dilating stricture through it with your endoscope.
Yes, sir. Shoot. So now this is the widest part of the stricture, dilator. Now I have gone nicely deep inside, and I'll take out the wire and I'll keep the dilator inside for a period of half a minute. धरून ठेवा. So now this patient was asking me before I started the procedure that she has undergone dilatation in 2023. So why again I have developed this stricture? So the problem is iron deficiency anemia.
Yes.
If the patient don't follow diet properly, then they will definitely develop recurrence of the web. And in case of Plummer-Vinson syndrome, this can definitely progress to cancer. I have had 3-4 patients who had this Plummer-Vinson syndrome. I did their dilatation for 3-4 consecutive 5 to 10 years, and eventually they develop cancer.
Yes.
So it is a real risk.
Supposed to be pre-malignant condition.
Yes, sir.
Yes.
So I think half a minute has done. I'll take out the dilator and I'll just assess it with the scope again.
Another pre-malignant condition is Barrett's esophagus.
Yes, sir.
How many times you come across such condition?
Sir, माझं प्रेझेंटेशन आहे आज संध्याकाळी त्याच्या.
Yes.
So, sorry, but anyway, I'll just assess it first. Section बंद है. I'm still finding some resistance. Yeah. Now I have gone beyond.
Yes. This was much difficult than previous treatment.
Yes, sir.
Yes.
Generally, this esophageal web is seen only in patients with iron deficiency anemia with Plummer-Vinson syndrome.
Yes.
But theoretically, it is seen in other conditions like Sjogren's syndrome. Then some people graft versus host reaction with patients with chronic and severe GERD.
Yes.
They can also develop this web formation. But in our day-to-day clinical practice, I think the iron deficiency anemia is the commonest cause.
Yes.
So the distal esophagus looks absolutely clean, normal. I'll just take out all the air from the stomach. One more thing, whenever you are doing dilatation for stricture or web, you should see some bleeding that has happened. That confirm that dilatation has taken place. Because if you are not haven't dilated adequately, then there won't be any bleeding, and that will be like half-hearted job, and patient will not get good relief from his symptoms. Okay, can you see this?
Yes,
this is
yes,
the
yes.
area of the web.
Very nice.
So no signs of malignancy, that's for sure.
Yes.
I will use NBI, but actually it is of no use here. It is a long web.
Yes, yes.
Whenever there is recurrence, generally you find this.
Okay.
The area of the web increases, and the chances of complication post dilatation are also more with progressive dilatation episodes. So this is a long area of injury. So if she doesn't follow her diet properly, then she will definitely develop recurrence again. So she has to be monitored for a good diet. She should be advised good diet by a proper dietitian. And but in our country that is the problem. These patients, they don't come for follow-up very regularly. Okay, so that's it. So any questions from our patient? Yes, sir.
Wonderful demonstration, Dr. Mandar.
Thank you, sir. Thanks, sir. Yeah, hey. So when you are doing dilatation for other things like say malignancy, then it is always a better idea to have a pediatric scope in your armamentarium. So see, many times the strictures are very tight, and this stricture was not very tight because she had a web, so I could easily pass the stiff guide wire. But sometimes if the strictures are very tight or a long stricture like a corrosive stricture, you are not able to pass the stiff guide wire, and sometimes you have to use Terimo guide wire also. And in those conditions, sometimes you can create a false passage. So it is always a good idea to have a pediatric gastroscope with you. So even if the lumen is very narrow, sometimes you can pass that across this narrow lumen, that scope across the narrow lumen, so that the chances of complications are reduced with this.
Is it available pediatric gastroscope with Olympus?
Do you have a pediatric gastroscope? They have that.
Okay.
But generally at our center, so we have pediatric endoscope. The other advantage of having a pediatric endoscope is for passing a nasojejunostomy tube.
Yes.
So because if you try using a normal gastroscope, then the guide wire comes out through the mouth. Then you have to bring that guide wire from the nose, and that becomes a very tedious procedure. Instead, if you have a pediatric scope, you can pass that scope through the nose of the patient, and the guide wire can be passed through the scope, so it will come out from the nose, and over the guide wire you can easily pass your Riles tube or a nasojejunostomy tube. So these are the advantages.
Is it different from bronchoscope?
Yes, sir. The length is more. It is exactly like a gastroscope. Only thing, the diameter is narrow. Okay. Shorter diameter.
Yes,
about 7 or 8 mm. I'm not really sure. But the working channel is also small. So there is definitely limitation for its usage.
Yes.
But if you are having a dedicated endoscopy unit, then it is always a good idea to have that with you. So for doing pediatric POEM and other advanced procedure, we cannot use that endoscope because the channel diameter is very small. So we cannot pass the normal accesses through that channel. Okay, even for taking biopsy, we generally use spy bite, the biopsy which we use for spy cholangioscopy.
Can it be used for foreign body removal?
So it's difficult because the foreign body forceps are quite thick.
Yes.
They cannot be passed through this pediatric endoscope.
So it is for diagnostic purpose and some few limited purposes.
Yes, yes. And as I said, we pass a spy bite.
Yes, yes.
There's a question online. When do you use a biopsy forceps with spike and without spike?
Shifting to OT1 by Dr. Praveen Survanshi sir. एक 35 years old female came with complaints of pain in abdomen since 5 years, nausea since 1 month and intermittent vomiting since 15 days. Her LFT is within normal limits. MRCP was done which was suggestive of cholithiasis without cholecystitis, cholecholithiasis with dilatation of IHBR, CBD dilated of 12 mm diameter and multiple intraluminal calculus largest measuring 10 mm. Now patient is planned for ERC with CBD clearance and stenting. Over to you, Suryavanshi sir.
Yeah. So again, welcome you all for this live endoscopy workshop. So this is, as mentioned, 35-year female having gallstone with CBD stones. So I already intubated patient with the side weaving endoscope, and I am in the second part of the duodenum. Can you appreciate one structure here?
Yes.
Prominent structure?
Yes.
Okay. So this looks like a major papilla.
Yes.
Okay. It's very, prominent structure here. But if you see carefully, there's nothing is flowing out, and also I am not getting proper positioning of this papilla. So I just turned it down and went deep inside. Now, can you appreciate here now? There is another structure here, which is the deep inside the diverticulum. So this is how, and again, whatever you see that vertical reach to which leads to the major papilla. Can you appreciate this vertical reach, mucosal fold?
Yes.
So that also has to be looked to, label it is a major papilla. So now this is the major papilla here.
Yes.
And that was initially which was seen, it is a minor papilla.
Yes.
Okay. Now also you can appreciate it is deep inside, and again it is inside the duodenal diverticulum. So can you appreciate? There is a diverticulum.
Yes.
So these are the cases which are comes under the difficult cases for the cannulation. And not only that, since there is no this muscle wall around the duodenum, so these are the cases where the injury is while doing sphincterotomy or papillotomy, you can injure it very easily. So you have to be very careful while dealing with such cases where there is a papilla is completely inside the diverticulum.
Can we get
I have already now cannulated. Yes.
Fluoroscopic picture.
Yes. Can you see now?
Yes. No fluoroscopic picture.
Fluoroscopy, please. 1 minute time now. Hello.
Yes. Now we have got studied with stones.
Can you? Yeah.
Yes.
Now you can appreciate there are multiple stones of varying sizes. So what you should do ideally, first guide attack. Once you are with cholangiogram confirm that you are in the common bile duct, pass the guide wire, and over the guide wire first you go in the common hepatic duct. And then start injecting further contrast, and then withdraw the sphincterotome so that small stone they don't migrate into the intrahepatic biliary tree, especially when there is a significant dilatation of the common hepatic duct, right and left duct with IHBR. Then this small fragment, when you inject contrast from below upward, they get migrated into the IHBR, and then it becomes very difficult to retrieve them with routine ERCP. Then you need otherwise cholangioscope and all that to take them out. So best way is, once you are confirmed that you are in common bile duct, and if there are multiple stones like this, then go up into the common hepatic duct and then start injecting contrast and slowly withdraw the cannula to visualize the common extrahepatic biliary tree. Inject, screen. Now you see I am injecting and I am withdrawing it. Now you can appreciate,
Yes.
I am withdrawing, and gently he is injecting. So now we can appreciate there are multiple stones in the intrapancreatic and the retroduodenal and the supraduodenal portion of the common bile duct. There are no stones in the right or left duct. Is it clear now?
Yes.
Okay. So now we'll do carefully sphincterotomy in extension.
Suryanshi sir, you see the ampulla is in diverticulum.
Yes.
So is there any particular trick to cannulate such kind of ampulla, or is it easy?
It's not definitely it's not easy. So these are the difficult. Initially only I mentioned that these are the difficult cases to cannulate. So and again these ampullas, they are not supported with a duodenal wall. Normally our ampullas are supported by the duodenal wall, so they are comparatively stable ampullas, and then it's easy to cannulate them. Since they are, you must you can appreciate they are inside the diverticulum, so they are very unstable ampullas. So to cannulate them is very difficult. So best way is if you get them in the right position before you start really feeding with them. Once you do a failed attempt to cannulate them, they become edematous, and further they occlude tissue edema, occlude the ampullary opening. So you must be very gentle, very precise at first time only when you are cannulating these ampullas. You should not make half-hearted attempts to cannulate them without proper positioning of the ampulla or proper instrumentation and the visualization of the ampulla. If your scope, sometimes it becomes that your scope is not stabilized or not stable, then you must take long route, make your scope stable, and then you start cannulation.
Sir, you said take position.
Yeah.
Like we would like to know what exactly would you say?
Position is that the ampulla should be at 11 o'clock position.
Yeah, at 11 o'clock.
11 o'clock, and the scope should have the shortest route, so that that is more comfortable position for the cannulation of the ampulla. If the scope is not stable, though you have got good position, and when you start attempting cannulation, and then the scope start moving, or getting displayed backward, then you struggle having the access to the ampulla. So not only that the initial position of the ampulla, but another important thing that the scope should be in a very stable position.
Sir, you said about the short route and the long route. Can you elaborate?
Next case I will show. Because this is if you lose this position, then every time you may not get it. So again, that is another important thing. Once you have cannulated, just finish the procedure. Don't take out the guide wire and you think that I can do it again. So next time it may be difficult. Once your scope is stable, you have got nice position, don't change it, especially for such cases. So now I will do very controlled sphincterotomy. Okay?
Yes, wonderful.
See, so what I will do now, I want to cut this deep circular muscle fiber out the sphincter itself only, without cutting mucosa. So what I will do, with limited, you will appreciate, I will cut only deep circular muscle fiber, see, without cutting mucosa. Can you appreciate? Okay?
Yes, wonderful.
Yeah, take a balloon. Yeah, CRE. So again I will do balloon sphincteroplasty, very controlled, not very aggressive. Okay.
Because of thin wall.
Thin wall, that's right.
So the extent of sphincterotomy in a routine case and in such case, the difference?
See again, see what I did after putting the sphincterotomy inside, after bowing it, I lifted it. So you can feel with that lift what is the length of the sphincter muscle.
Okay.
Okay. So because here is no duodenal wall to restrict your sphincterotomy, what normally we do otherwise.
Yeah.
Okay. But since there is no duodenal wall, so what I do, raise the put the sphincterotomy inside the papilla and raise it. And again feel the circular muscle fiber.
Okay.
And just 60% of that you do sphincterotomy.
Whereas in a routine case, there would be a landmark of the
Landmark,
duodenal mucosa,
duodenal mucosa.
the duodenal folds.
This is really a very difficult case.
So this is a
Yes, balloon.
CRE balloon. Yes. So we'll do very controlled, very gentle sphincteroplasty.
What is the balloon pressure advised and diameter?
So this is 12-15. 12-15. Yeah.
Yes.
Yes.
And
Yes.
pressure?
3.
Okay. Is there pressure gun?
Yes.
Can you show it
Sure.
to the audience? Yes.
So there is a pressure gun. So here you can with this rotate very gently, very just millimeter by you can inject it in a very controlled fashion. Control. Trigger. Okay. So you have achieved pressure of 3. Just keep it there for 1 minute minimum, 1 to 2 minutes.
Yes.
So the benefits are the fiber also gets stretched out easily without much injuring them or tearing them, and also if there is a bleeding, it also get controlled. So the bleeding is less if it is gently control inflation of the balloon, and if you keep balloon there for 1 to 2 minutes.
Yes.
ठीक है. Deflate. Again deflate. Can you appreciate now?
Yes.
Nice, you can peep inside the common bile duct. Huh?
Yes, very nice.
Yeah. So there is no bleeding also. So I will advise for the beginners, they should not do such cases until unless you have got enough experience, you have got enough feel of everything, all manures. So avoid such cases at the beginning. Select simple cases, simple stones, simple biliary tree.
So there is a question online. For beginners, how do you negotiate the duodenum? You'll have to show it in this or next case.
Next case I will show. I think last case I showed that. That's why which avoided that demonstration. So now, if you had notice on the cholangiogram, there is a large stone at the lower portion of the common bile duct. So we must take that out first. Inject contrast. So inject contrast. Screen. Inject. नहीं जाता. ठीक है. Inflate. हाँ. See now, once you are at the stone has come out.
Yes.
Can you appreciate? The last stone has come out.
Wonderful.
Without much efforts. So this sphincterotomy was, sphincteroplasty was adequate. Can you appreciate?
Yes.
It is quite large stones, more than 15 mm, I guess. Okay.
What is the limit of the size of the stone for balloon removal?
Deflate. Pardon?
What is the higher limit of stone size for balloon removal?
See, I removed up to 20 mm stones with the balloon. But in that case, CBD should be also nicely dilated.
Okay.
Yeah. inflate 2.5.
Is there any chance of
See,
perforation?
can you appreciate? These
Yes,
stones
yes.
are coming out.
Yes, yes. Is there any chance of perforation while removing the large stone at the site of papillotomy or sphincterotomy?
Now, if you use too much of force unnecessarily, then definitely you may injure.
Yes.
But if if it's controlled, if there is too much of resistance, then you should not do that. You must stop. That's why as a surgeon we can understand these things better.
Better, yes.
We have
yes.
many options, so we will not stretch unnecessary any particular technology or technique to clear the things. We will use judicious. Can you appreciate now?
Yes,
See,
yes.
see how many multiple stones are coming
Multiple
out.
stones, yes. Wonderful.
Deflate. Inflate. 2.5. See, a lot of stone with multiple marks coming out. Inflate kelega. Okay.
Yes, yes.
Now it is a clean swab. After that, what I do, I inject a lot of saline, keeping it in the common hepatic duct. So whatever mug is there, that comes out with the, this saline flow. Inject. Yes. But ठीक है राव दे आता. It's not working. ठीक है. Balloon inflate कर check occlusion collision करो. Inflate. Inflate. Inject contrast. देखा. हाँ? दूसरा के. Deflate. The channel is not working. एक मिनट. So now you can see very nicely dilated ampulla with sphincteroplasty. Hello?
Yes.
Yes, yes.
Yes.
We are exchanging balloon. Inject. Inject. See, it should be done only when the this sphincteroplasty has been done. We should not inject too much of contrast or saline when the biliary tree is closed system.
Yes.
Then it will may induce the cholangitis then. Okay. So because it is flowing out easily, that's why you can inject. Now you can appreciate mugs coming out freely through the widely open ampulla. Okay. Yeah. Inflate balloon. Inject contrast. Now we'll do check cholangiogram. So what we do, we inflate the balloon at the lower end and then inject the contrast. So whatever you are seeing, that is the air there.
Yes.
There is no stone. Can you appreciate?
Yes, yes.
Everything is clear. Close, deflate. Okay. So now these are the cases, where there is a plenty of muck like this, gallbladder is still, multiple stones are there. So post-operatively, definitely I will do balloon swapping again, because definitely this patient is having very wide cystic duct, and always there are chances that stone may get slip into the corn bile duct, during operation or sometime in between. So that is better to do balloon swapping after taking out the stent. So normally for such cases we put 10 French single pictal catheter, okay, and we keep pictal in the duodenal lumen.
Sir, Dr. Amarvani here.
Yes.
One question. For retained stones or the failed ERCP, after how many hours or how many days you do the laparoscopic coldocotomy?
See, now with endoscopes we have many, for ERCP you have many options for the difficult stone. Okay. So if in such cases, if we are not able to take them out with just ballooning, then you can use basket. If not, then you can use mechanical lithotripsy. So we have demonstration of all these cases today itself. So again, there are two types of stone which are otherwise difficult. One is the large stone with undilated lower CBD. In that case, we have to crush them out before you take them out. We have to fragment these stones in multiple pieces before you take them out. If the stone is large and the lower corn bile duct is also equally dilated, just wide sphincterotomy with the basket and all that, you can take them out. If not, you can crush them with the mechanical lithotripsy with the basket. Okay. If that is also not possible, then nowadays we have got this colonoscope. With the colonoscope, you can do EHL. You can fragment them with the laser or the this EHL, this lithotripter. And if that also fails, then you have surgery, CBD exploration. So being a surgeon, what this EHL colonoscopy, it costs huge to the patient. One session of EHL, it costs not less than 1.5 lakh. So it's better to go for the CBD exploration if the gallbladder is intact. If the already cholecystectomy is done, and if there is a residual stone, then we use all these advanced endoscopy technique. But if stone is not, we are not able to take it out with the simple like the basket or balloon sphincteroplasty, then we prefer to, and if the gallbladder is intact, we prefer to do laparoscopic CBD explosion and cholecystectomy than using this EHL and all that. But if the already cholecystectomy is done and there are difficult stones, then only we use advanced endoscopic technique. That we feel that is more cost effective than for every stone using advanced endoscopy technique. Is it clear?
Yeah, yes, sir. If the gallbladder is intact and you...
Your voice is not clear, madam.
Okay, sir.
Please be close to the...
Is it clear, sir, now?
Yeah.
Okay. If the gallbladder is intact and the ERCP is successful, so this patient is still admitted, the next day you do the lap poly?
Yes, it depends upon the level of difficulty. If if you do a lot of advanced technique, then we definitely don't do immediately next day. We observe this patient minimum for 48 hours and everything is settled, then we do cholecystectomy. But if it is a straightforward stone with without much intervention, we could clear the corn bile duct. Even we have done in the same setting. Immediately we shift this patient to the operation theatre and do cholecystectomy in the same anesthesia. That also we have published this paper in Indian Journal of Surgery 3 years before. So everything depends upon the case to case.
You are giving prophylactic antibiotic in all cases, sir?
Yes, definitely. You
what
must.
Antibiotic you are giving, sir?
We are giving this cefperazone.
Cefzolin.
Yeah.
Hello, Praveen.
Yes.
After successful ERCP, is it necessary to get the bilirubin settled down for surgery?
If it is marginally raised bilirubin or
no, higher bilirubin.
No, if definitely if bilirubin is very high, and if there is a cholangitis, severe cholangitis, sepsis, then you must wait for it to settle, because another giving anesthesia, doing laparoscopy, and if it is a difficult case and all that, then unnecessary you are exposing patient to the longer anesthesia when already liver is already liver function is compromised.
Yes, yes.
So again depends. We have to consider every factor before you take this decision of same setting, lap chole and the ERCP.
If lap chole is not possible in 2 or 3 days, so how much time interval will you advise?
Pardon?
If lap chole is not possible within 2 or 3 days, so how much time interval will you advise for lap chole after ERCP?
See, again depends upon the case. If the patient is sepsis and severe cholangitis, then until this everything is settled down, after we discharge this patient, so we allow just not only bilirubin to settle down, but all inflammation, everything has to settle down. So we will do after 2 weeks of this, 2 weeks to 6 weeks. We advise patient come back for the cholecystectomy 2 weeks to 6 weeks.
Yes,
if there is a severe another cholecystitis, all that, then definitely we wait for the 6 weeks for the even callus angle inflammation to give time for the inflammation to settle down in the callus angle also.
Yes, yes.
Yeah.
1 to 1.5 months is a better time, I think. Yes.
Okay.
There's one online question. Do you give per rectal indomethacin?
Yeah, it's recommended to avoid pancreatitis, but we don't practice in our center. So I feel precise cannulation, not to poke pancreatic duct too frequently, not to do unnecessary maneuvers, too much of harsh maneuvers. These are the more important thing as an endoscopist than treating it with some medications like this, with not very proven role.
After removing very large stone with a balloon, is it necessary to remove or retrieve the stone, because it may cause obstruction at IC junction or in the lower intestine?
No. If it is less than 2 centimeter, you should not worry.
Okay.
So I think someone had asked what is short course and long course.
Yes.
See, so I am withdrawing my scope. Okay. So this is stomach. I am at the esophageal junction. So always scope, takes the greater curvature like this. Okay. Along the greater curvature, Siam. Show Siam. Show the scope.
Siam is not proper position. Yes.
See, can you appreciate? Show the complete Siam.
Yes.
Scope dikha pura. See, scope always, whether it's a gastroscopy or ERCP, every scope reaches the antrum through the greater curvature.
Yes.
Okay, this is how I reached the pylorus. Now I am going into the
endoscopic picture is lost.
Yeah.
Endoscopic picture, please.
Hello.
Yes.
Can you see now?
Yes.
Now I have cannulated this duodenum. Okay. Can you appreciate now how the scope is?
Yes.
It has completely taken the greater curvature path. Okay. Now it has reached into the first part. Now I am going into the second part. Okay. Now this is known as the long route. Okay. Yeah. Now also I can see minor papilla. In long route also, if you now I will show you, I can see the major papilla. Can you see this? This is at 11 o'clock position again. But it is through the long route. Can you appreciate on Siam?
Yes.
It is along the greater curvature. So this is known as the long route. So whenever the scope is not stable with the short route, you can try this way to stabilize the scope. Okay?
Yes.
But that is not very ideal position for the cannulation. It makes cannulation more difficult. Okay. So to make it short, what I am doing now, I am turning this small wheel on the right side like this, fixing it, pulling it, and can you see the external image?
Yes.
And rotating this my scope head clockwise like this and pulling it out. See all these three. See
Yes,
at the
yes.
C-arm,
Yes.
see at the endoscope and my hand movement also.
Yes.
See, I am pulling it out because it is locked. Scope is locked. The tip is not getting withdrawn and just the scope is getting withdrawn. See now, it has
Yes.
become now straight.
Yes, yes.
And now show the scope again. See, it is the short loop. Now it has not taken greater curvature. It has taken lesser curvature.
Yes.
So this is known as the short loop. So this is now a normal scope position for the ERCP, short loop. Is it clear?
Yes, yes.
Very clear, sir. Fantastically
ठीक है.
demonstrated the long and the short. It is a very, very important concept to know when you're doing especially ERCP.
Thank you.
Wonderful demonstration, Praveen.
Thank you,
Yes,
Bakaran.
Yes, yes.
Coffee is being served outside. Thank you, sir. Shifting to OT number 2, procedure by Dr. Advai, sir.
Tea and coffee is being served outside.
54 years old male came with complaints of pain in abdomen since 3 months, complaint of nausea and vomiting since 10 days on and off.
Hello.
He is a known case of chronic alcoholic since 10 years. His hemoglobin is 12 gram %, platelet is 82,000. USG is suggestive of chronic liver parenchymal disease, mild splenomegaly and pseudo thickening of GB wall. His plan is diagnostic upper GI scopy, SOS variceal banding. Over to you, sir.
Yes, good afternoon. Am I audible?
Yes, sir.
So we have just heard the history of this patient, the chronic alcoholic. So now we are suspecting varices, though there is no history of hematomesis or coffee ground color vomitus. His platelets are adequate. So we will try to enter the esophagus. So it is quite easily we have gone into the esophagus.
Endoscopic picture is lost, please.
Can you see the endoscopy picture?
Yes, yes, yes. Now we can see.
So I am now in the upper esophagus. So gradually you suck out the fluid, gradually advance your scope. In any case of prior history of chronic alcoholism, you should be very gentle while negotiating the scope for the first time. So you should see everything under vision and then let your scope progress.
Yes.
So here we can see varices. They are medium sized varices. So I will again inflate at the GE junction and cross, go into the stomach, aspirate if there is any fluid here, go across, see some changes of portal hypertensive gastropathy, not much.
Yes.
So now I am trying to go into first part of duodenum, because most of the times these people are alcohol with tobacco abusers, so they might have a duodenal ulcer as well. So you should inspect the duodenum thoroughly. So there is no ulcer in the first part of the duodenum, and this is the blind area. So you gradually under vision go into the second part. So here we are okay. There is no duodenal ulcer. We are coming back. Now we are in the stomach. Here we will inspect the incisura and then go into the fundus and inflate it nicely and look for fundic varices. So I don't see any fundic varices here, because if there are fundic varices, it is very, pardon? Yes.
If there are fundic varices, then what will be your?
Yeah, I was about to say that only, because if there are fundic varices, you should tackle the fundic varices first and then the esophageal varices, because the blood flow in these varices comes from below upwards.
Yes.
If you do the banding above, these fundic varices may bleed in the next 1 or 2 days. So there are no fundic varices, we are sure about it. So we will again deflate the stomach
I think there are multiple hyperplastic polyps.
Yeah.
In the stomach.
Yeah.
Will you review them with narrowband imaging? Yes.
These are the hyperplastic polyps. These are typically because of hyper acidity. We can see if we have narrowband imaging here.
Yes.
So we need to inflate the stomach again adequately, fundus, and I have not attached a cap, so I might not be able to give you a big clear visualization, but the pit pattern appears to be regular here.
Regular, yes.
So we are sure that this is hyperplastic polyp.
Yes.
Yeah, so we are not interested in taking it out because it is very small. It is a diminutive polyp, and we will leave it alone. White light. So I will deflate the stomach, and our plan is to go for endoscopic variceal band ligation. Would you agree, Mandar? Yes. So inspecting the varices, there are no cherry red spots, or there is no knuckle here, because the patient, if you see a knuckle, it is very dangerous sign, because during banding the varix may open up, but we are fortunate that we are not having any knuckle sign or any cherry red signs on these varices, but we will tackle them.
How we grade the varices on?
Sir, initially there were first and foremost is you inflate the air into the esophagus and see if the varices are collapsing. If they are completely collapsing, they are grade 1.
Yes.
If they remain like this, inflated without any suction, grade 2 to grade 3. And if you find it difficult to negotiate across these varices, it goes to grade 4. But nowadays, we also use small and large varices to make the things simple.
Yes.
So I think these are large varices which require banding, and banding is a very easy procedure, and this is an ideal situation for a beginner to start with banding, where there is no knuckle sign, patient is stable, hemodynamically he is stable under anesthesia. So I would for the beginners I would suggest, before going for any banding procedure, they should administer injection terlipressin, so that the portal pressure reduces during the procedure. So this is what I follow.
How much dose is given? Terlipressin?
1 milligram.
Okay. And
1 milligram, maybe half an hour to 45 minutes prior to the procedure, if it is an elective procedure. Of course, you can give it a bolus dose also if the patient starts bleeding during procedure.
And do you always give propofol for banding procedure?
Most of the times, because if the patient starts retching during banding, because these patients are alcoholic patients, they are quite, they might become rowdy and uncooperative. So it is preferably to keep the patient under sedation, propofol sedation. Now I will show you how to load the band. Can you give me the scope? So we are using, can you focus on this? A multi-band ligator from Shaili. So this is an Indian brand, and the bands are quite
Is there any difference between Indian companies and Boston and
Mandar? Though Boston has, they say that it is quite easy and the tension on the bending tube of the scope is less, but I find Indian companies bands also quite effective. What I would prefer is two thread band rather than a single thread band. So can you focus on this? So now this is the band ligator, the handle. I will fix it to the scope. Cap काढली का तू? अरे पण ते लीक होईल ना, सक्शन नाही होणार. हाँ? होतं? ठीक. So now this is the hook. So I would insert it. So once it is out, I will ask my assistant to hook it into this. There is a knot here, so you have to hook it before the knot and then gradually pull this thread. This is a single thread band, Mandar.
Yeah. So I find bands with single thread, they exert extra pressure on the bending section of the scope. So I generally prefer bands with two
threads. So now once you are here, you ask the assistant to fix the cap. He is applying some jelly, being very particular about the scope tip. It is nice. And then you tighten this thread. So here there is a groove on this band ligator. Can you see this groove?
Yes, yes.
Huh? So now you hook this knot inside this groove nicely. Pull it. It slipped. So now this knot is inside this groove, and just pull this thread, and like this you rotate it to tighten the thread. So once you are tight enough, you just push it, the lock. Now the band is ready to fire. We can also see the position of the thread. I would slightly make it in line with the channel scope position. So now we are ready with the band. I will ask my anesthetist to give some propofol so that the patient should not retch. Apply copious amount of jelly here.
So Advai, even the handles, sometimes you get the handles with click.
Yeah, but I don't find any difference. Do you prefer the handles with click?
No, I don't. It gives you a false
yeah,
release.
Sometimes it gives you a false sense of band getting fired. It is better to do it on your hand tension release.
You should get the giveaway. That
Giveaway.
is the ideal side.
Yeah. So now again, gently we will try to go across the upper esophageal sphincter. We are there. So now we are into this esophagus, and while inflating under vision, we will try to go across this varices. Yeah. So I would suck here and flush the things. The anesthetist has asked me to wait. So we will wait for some time because there is slight drop in the oxygen levels. The anesthetist has requested me to remove the scope. So I am removing the scope. We'll keep the band loaded.
So till this is going on, one or two questions. Can you do banding if the patient is having active bleeding? If you see a spurter, like actively bleeding varices are there.
Yeah,
can
if you can
banding?
locate. So in such situation, I would like to first secure the airway of this patient, intubate him, and then go in with a band and locate the site of the spurter. And first band, what would I would apply is go below the spurter and apply a band on the varix below the spurting site. Then you apply another band above the spurting site. By this time, the spurter will get occluded, and most of the times you can achieve. If you go for the exact site of spurting and try to suck it, it will open up more and it will give you more amount of bleeding, and the patient will regurgitate.
Yeah, you will keep on sucking the blood rather than...
You keep on sucking the blood and the varix will not come inside. Importance is to place a band securely below the spurting site. So that will reduce the blood flow to the varices. Administered 2 milligrams of terlipressin. This has helped me. Exactly 2 days back, I did the same case. There was a band ulcer. I did a banding 15 days back, and the patient presented with melena. And once we put in a scope, it started bleeding. So we intubated the patient immediately, and then administered termlyspacin, and then banded the side below the bleeding side. Banded the varix below the bleeding side. So once the anesthetist gives us a go, we will proceed with the procedure. It is very important not to panic in such situations. You should believe in your team, and it is a teamwork, of course. And during endoscopies, the saturation might drop because the airway is we are compromised in such patients.
This is a very important situation which most of us will encounter during endoscopy. And as Dr. Advai said, it is important not to panic. And I would always suggest one thing: always have an anesthetist at the head end. If possible, if you're giving anesthesia, if there are practices where one gives propofol and does the scopy. But I would say that it is not worth it.
Yeah.
If you are doing it with TIVA, you do it with an anesthetist. Because many a times the saturation may drop and you forget on the procedure you're going to do, and then your entire attention is on the airway, saturation and everything, which becomes very messy sometimes. Even one patient lost is really not worth that.
No. Yeah. I will completely agree with you. Though there was a paper which has suggested that propofol anesthesia with a trained nurse is adequate, but it doesn't stand in the court of law.
Yeah.
And we should let it be the court of law. First, we should prioritize the safety of the patient, and we should not compromise on the giving an anesthesia without an anesthetist.
Exactly.
I will completely agree with.
The concept of trained nurse is there in the Western world, where technicians handle a lot of part because of the shortage of anesthetists. And secondly, sometimes for a short procedure, it's very difficult to get an anesthetist. For maybe a single procedure, just a scopy, so sometimes it's very difficult, then the time doesn't match.
That is the importance of a teamwork. You should develop a rapport with your anesthesiology colleague. Ki, boss, even if there is one case, you give some time to us and you come. Because then this will establish a rapport and a sense of security for both the anesthetist also and the endoscopist also.
Yes. In short, the final, the underlining word is that if propofol or any anesthetic agent is given, always and always have an anesthetist by the patient's side.
Definitely.
We can start now. Pramod? Yes, sir. Sir, Advai, come.
Okay. So now the anesthetist has given us a go. We will start the procedure.
Yes.
Without wasting any further time. They have inserted a nasal cannula that has caused some trauma. So we are across the upper esophageal sphincter again.
Endoscopic picture is lost, please.
So this, am I audible?
Yes, you are audible, but there is no endoscopic picture on the screen.
Okay.
So is it beneficial to have a water jet with you?
Yeah, it is beneficial to have a water jet to clear this such kind of bleeding situation.
Sometimes when you are applying the bands, if the one band slips out, and sometimes that will occlude the lumen of the scope, and that can also be cleared using that water jet.
So now
it is always beneficial to have a water jet with you.
So now what I will do is, I would just go above the Z line.
So you start from below or from
above? No, always start from below, just above G junction, the scomocolumnar junction. The first band should be applied just above the scomocolumnar junction. We will try to suck this varix. nicely. Once it is complete read out, I will ask my assistants to hold the scope, and with the other hand I will fire the scope. There is a giveaway, and then gradually, just with stopping the suction and giving some air, you can release the varix. So a nice good amount of a varix is being sucked in.
Sometimes I have observed that if the varices are really big, after you apply the band, the varix, banded varix part will get caught in this
yeah, that is what
channel.
that is what I wanted to demonstrate. First is you have to stop your suction, then start giving air. Don't pull out your scope. Let that banded varix slip out of your band barrel. So again, there is a giveaway. See, now I am giving air. Now it has slipped away, and now gradually I am removing it. This blood which you are seeing is because of the nasal cannula and not from the varix. So you need not to panic. It is just localized bleeding and temporary one. Yes, Mandar, what do you say? I think the varix have almost gone.
Yes, yes.
Yeah. Dr. Mandar has gone for a procedure.
Okay, sorry. I didn't saw. So what do you say, sir? The varices are almost flattened out.
Yes, it is a very good banding. I can see that there is a obvious difference in the pressure.
So
if you can see just above the banding, the varices have obliterated.
Out. And I prefer not to create an artificial varix and band it, because it will try to slip out the mucosa and cause a band ulcer there. So if the varices are flattened out, I would just remove the scope. Okay. See now, here also you cannot see a varix. Okay, it is completely flattened out. Here also,
just above
completely flattened out. I think I will just come out and call it a day. After 6 weeks, I will call up the patient again for a diagnostic gastroscopy to see any residual varices.
What should be the distance between the two bands or two varices?
2 or 3 centimeters, usually in a spiral fashion, we will come up.
Yes.
So that a very close distance will not allow you to suck in the good amount of chunk of the varix, and there would be pressure on the banded varix which is below. So that band might also slip out if you are very close enough. So what I would do is start typically around 2 centimeters, and while sucking, gradually withdraw the scope so that the upper part of the varix comes inside the barrel, and then fire the band.
Yes.
So if there are no questions, we will go to the other room.
We have questions for the anesthetist.
Thank you very much.
Anesthetist, sir.
Grade 2 to the grade 3 varices.
It was a difficult procedure, and more difficult for the anesthetist. Anyway, okay.
Thank you, sir. Shifting to OT number 1, procedure by Dr. Mandar, sir. Patient, 60 years old male, complaint of pain in abdomen since 1 month. Operated case of open appendectomy for cholithiasis 4 years ago. Patient LFT is within normal limits. USG ectopelvis was suggestive of CBD diameter of 12 mm and CBD calculus of 14 by 4 mm with prominent IHBR. Post-cholecystectomy status. MRCP is suggestive of common bile duct dilated with diameter 2 centimeters and distal CBD with multiple calculi, largest measuring 13 by 9 mm with central IHBR dilatation. Patient is now posted for IRC with CBD clearance and CBD stenting. over to you, Mandar sir.
Hello, am I audible there?
Hello.
Hello. Can you hear me there? Hello.
Sir, you're audible, sir. You're
Yeah,
audible,
sorry.
sir.
So there's some technical glitch, so we had to wait for some more time. Now you have heard the history. So I'll be doing ERCP in this patient. Now this patient they have kept in the prone position. So either you start in left lateral position, or my practice is to do all the ERCPs in supine position. So that helps me to get a proper cholangiogram. But it's personal preference. Some people do it in left lateral, I do it in supine, here they do it in prone position. So it is personal choice.
Dr. Mandar, what is the ideal position a newcomer, a beginner should start with?
So left lateral, definitely left lateral. The only problem is if you start with left lateral, and once you cannulate, by position, looking at the position of the guide wire on fluoroscopy, you may not be sure whether you are in the CBD or PD. So that problem will be avoided if the patient is in either in supine or prone position. But for easy intubation across the duodenum, left lateral is supposed to be the best. So now I have gone into the at the G junction. I'll be entering into the stomach. So once you go into the stomach, you make sure that all the secretions which are there in the stomach, they should be sucked out completely. Then you distend the stomach lumen, and then pass the scope exactly the way you will pass a gastroscope. You should go along the greater curvature like this. Then you will start seeing the pylorus like this. Can you see the pylorus? And once you see the pylorus, this is called a setting sun sign. Like this, you go into the duodenum. You start seeing the duodenal lumen. Then you turn the scope clockwise. Turn the small wheel also clockwise. Lock the small wheel and slowly shorten the scope. This is called shortening of the scope. So then once you go in the D2, then you look for the ampulla. There is a diverticulum in this patient also.
Yes.
So all the patients, they have kept two in there. Two patients of
yes, it is a test of the endoscopist.
even the esophageal waves also, there were two patients. Can you see the fluoroscopy image there? Are you getting the fluoroscopy image?
I would request Dr. Parmar sir and Dr. Pethankar sir to be the chair.
Yes, sir. Yes, sir.
Yeah.
Yes, sir. Yes.
So can you see the clips which the surgeon has applied during lap cole?
On the cholangiogram. On the CM.
fluoroscopy, yeah.
Yes, sir. We can appreciate.
Yeah. So now this is the pylorus, ampulla, and this is a large diverticulum, but ampulla is not intradiverticulum. So now my scope is straight. I try to cannulate. It is not completely shortened because the position is little odd. Now my cannula has come out.
Mandar,
yes, sir.
Your position is position of the scope is quite dicey.
Yeah, because
for an experienced endoscopist like you, it is okay. But do you suggest for the beginners to put the scope in such position?
You should completely keep the scope in exactly straight position. But here the patient's position is a little odd. Even the ampulla is also not exactly at the right place. That's why I have to keep the scope in this little awkward position. Now my cannula has come out. You target the ampulla and adjust your small wheel and try to go inside.
You are also quite away from the ampulla, eh?
Yeah. Now I'll ask my assistant to bend. Bend kar, thoda. Bend, thoda. So by bending, you align yourself towards the CBD. Okay? And guide wire.
Yeah.
Once
Very nice.
Then so having a good technician is of utmost importance. When the wire goes straight like this, then you are sure that you are in the CBD. then you do deep cannulation, and once you go beyond the level of cystic duct, then you ask the technician to inject the contrast. So can you see the air cholangiogram? Okay, now he has started injecting. Slowly I will bring my cannula down. Khali दाखवा थोड़ा, सियाम थोड़ा, हाँ बस बस. I'll slowly come down. Yes. While I am coming out, he is injecting the contrast, and you will get. Can you see the stone, Advay? So that is the air. बाहर आलो. अजून टाका इंजेक्ट जरा.
The CBD seems to be significantly dilated.
Yes, yes.
Like, would you keep
see any stone?
A diagnosis of a choledochal cyst?
Possibly. I was about to say that. I can't see any stone, but okay. Now I'll do the papillotomy. Adi झाली का ERCP?
Yes, looks like it is.
Yeah. So it looks like a already sphincteromized papilla. That's why you could see some air even before I went inside. So I'll just extend the papillotomy a bit. Bend. Ajun bend. So while doing papillotomy, you keep on going inside and come out so that you can get some idea exactly in which direction the CBD is there. Okay. I can extend it a bit. What do you think, Joy? Can I extend the papillotomy?
Yes, definitely you can. I was just going through the MRCP images.
See, the moment I extended the papillotomy, we could see the gush of bile coming out. Ajun bend kara thoda. You can safely cut till this fold of the duodenum. There is no risk of perforation. Since I couldn't see any big stones, so there is no need to extend the papillotomy further. So I will extend the guide wire for a stiffer guide wire.
Dr. Manda, why a stiffer guide wire?
Because now I am going to exchange this cannula for a balloon.
Okay.
So the length of this Terimo guide wire is short. So if I try to exchange it, then the wire length will become short, and I will not be able to do proper exchanging in that.
So while cannulation, you use a different wire, and then...
Yes, yeah. So that is a good point. Actually, Terimo guide wire, we call it a pathfinder wire. So normally, see, in this case, probably this was already a sphincteromized papilla. So cannulating CBD was not difficult in this. But if you are doing it in a fresh case, then normally we pass the cannula in the common channel, and then using the Terimo guide wire, we generally find the path towards CBD or PD. And once you are inside the CBD, once you do cannulation, papillotomy, then you exchange it for a stiffer guide wire.
Okay.
So that on this stiffer guide wire balloon.
So there are different companies and wires,
Yeah.
like Visiglide from the Olympus, then the Boston has a HydraJag, and the Terimo obviously.
So here we are using Olympus Visiglide. So depends on personal choice. My preference is to use Visiglide. I exclusively use Visiglide in all our ERCP patients, because I find the longevity is more. So these wires are little expensive compared to Indian guide wires, but they last longer. You can easily do at least 8 to 10 ERCPs using this guide wire.
This is a very important point what Dr. Mandar said, like the cost. These wires are pretty expensive, the sphincterotomes are expensive. So you need to be very cautious when you use, what you use, how you use.
And that depends on your assistant also. If your assistant is good, then the life of your accessories is definitely more. Now if you see the fluoroscopy, I have gone deep inside the bile duct. Now I'll ask him to inflate the balloon. And now once the balloon is inflated, I'll slowly pull the balloon out. So along with that, if there are any stones, those stones will also come out. Yeah. And once you come near the ampulla, you should push the scope down. Concentrate on the fluoroscopy image.
Down into the D3?
Yes. If you keep on pulling the balloon, the direction will be on upper side and then chances of perforation will be there. Instead, you should push the scope down. So it will be along the long axis of the CBD. And then only the stone will come out. There is a big stone.
Yeah, there is a big
There
stone.
are multiple stones. So you should keep a constant pull on this. Here if you have done your gynae rotation, then that will come into play.
Yeah.
Exactly the way you deliver the head of the baby. Slowly try to pull it out. If you do it in Hess, the balloon will get burst and you will lose the balloon.
A good episiotomy was done by Dr. Mandar and then the baby is delivered.
Slowly you should do that and wait for the balloons, stones to come out. Never do it in Hess. Never just try to pull the balloon out. It will definitely get perforated. Yeah. Once the head is delivered, the pelvis and other things will come out easily. Okay, I think I have cleared all the stones. But still I will go inside again, shoot, inflate, and after the, if you are sure you have done complete clearance, you should do balloon swipe at least twice. Because there will be small particles which will remain inside. Deflect.
I think that is the importance of a good sphincterotomy.
Yeah.
You may not be able to pull out each and every stone, but if you make a good passage, the flow of bile will also push off the smaller stones and the nidus will not be there to become a bigger stone.
And normally what I do, because we are surgeons, we are used to giving lavage after the So similar thing I do. If there a patient has a lot of small particles or if there is deflect, and if there are pus or purulent material, then I give wash at least 30 to 40 cc NS I will inject inside, so that will wash away all the muck, purulent material, small stone particles, sludge, everything will just come out.
So here there was a discussion, just we touched choledochal cyst. So how would we diagnose a choledochal cyst in case?
So you can see a nice fusiform dilatation, the way we saw in this patient.
Yes.
And you normally you should see some narrowing near the ampulla. Here the narrowing is not there. So now after looking at the stones, I am not very sure whether it is a choledochal cyst or a case of pure CBD.
If it is a CBD stone and dilatation of the CBD because of the stone at the lower end, there will be some amount of intrahepatic biliary dilatation as well.
Yes.
So that is a very critical point. If there is no HBR and the CBD is dilated, then you need to keep in mind the diagnosis of a choledochal cyst. Why choledochal cyst is important? Because
now I am sure that I have cleared everything. Still I will do what is called as occlusion coloniogram. I have inflated the balloon. Balloon is at the tip of the ampulla, and now I am asking him to inject some more contrast, so that no.
So there is a question on online. What are the chances of stricture after papillotomy or sphincterotomy?
No, stricture will not form because we are cutting the muscle. So stricture will not form.
So the answer is that here we are cutting across the ampulla, the circular muscles. So
we are doing actually myotomy here.
Yeah, we are doing a myotomy. It is not a dilatation, it is a myotomy.
Khali. Yeah. Can you appreciate the CBD is completely cleared? There are no stones.
Occlusion cholangiogram looks pretty clear.
Yeah. But deflect. Once you do occlusion cholangiogram, I'll again go inside deflect. And before I declare that everything is cleared, I'll just do last balloon swipe. Inflate.
Before you take out the scope,
no,
a comment on comparing the scope size with the CBD size.
Yeah. So now the this Olympus, one more stone was there.
Yes, yes. Dr. Mandar, can you increase your voice?
Increase my
voice.
Oh, sorry. Sorry.
Yes.
Is it better now?
Yes.
Okay.
Much better.
So now, Joy, what do you think? Should I keep a stent or not?
I think we should keep a stent
Yes.
because multiple stones are coming out.
Yeah. The only thing is patient has already undergone cholecystectomy. But see, looking at the stone burden, I think it is always safer to keep a stent. Deflate. The stone extraction is a very simple OPD procedure that will not add to the cost or to the morbidity of the patient. So sorry, stent placement. Inflate. So I am definitely going to put a stent in this patient. Yeah.
When stent should be placed, when stent is not placed.
So suppose the patient has had a single stone, and I am very sure that I have cleared out everything, and patient has no cholangitis.
Yeah.
In those situations, there is no need to keep a stent, even if the gallbladder is intact. Say at our center, since we have our endoscopy theatre and laparoscopy theatre just samne, so many times we do both the procedures in the same sitting. So in that situation also, sometimes we won't keep a stent.
Okay.
And as I said, if there is
what is the advantage of not keeping a stent?
so we just avoid one extra procedure. That's the only advantage. That's the only advantage.
What type of stent you are planning?
A single pictal. So since we have done a wide papillotomy, I am going to keep a single pictal stent. So if we want the stent to remain there longer, then I would have preferred a double pictal stent. Here, even if it comes out after some time, then that is not a problem. But I definitely don't want the stent to migrate inside. That's why I am putting a single pictal stent. Nowadays, straight stents we very rarely use, only for a case of stricture, because straight stents they are more stiffer. So those stents can be passed across a tight stricture little more easily compared to these double pictal stents.
What is your experience about Teflon coated stents that Dr. Maidul?
Those are more stiff.
Yes.
If you are trying to put them across a very tight stricture, then those stents are preferred.
Yes.
But for a benign condition like this, generally we use a simple plastic stent, single pictal or double pictal.
Straight stent, you mean both sides straight, no pigtails.
No pigtail, yeah. So now this is the end of the pictal side of the end of the stent. Shoot. So I have gone sufficiently inside, and I will just release this stent. Kadu. Kada na.
So during the last ERCP, there was a question like how soon or how early can we, the stent is out? अच्छा स्कोप के साथ है.
हाँ स्टेंट है ना? कड़ा. 10 फ्रेंच होता था?
वायर के साथ
10 फ्रेंच स्टेंट होता? Sorry, my mistake. I thought it was a 7 French stent. I didn't realize that. Sorry.
Okay.
So actually, I would have preferred a 7 French stent, not a 10 French stent. For a benign condition, we generally prefer to put a 7 French stent. Here, there was a miscommunication from my side. So, but that's not a problem. 10 French stent is also okay.
Dr. Mandar, what is the further workup for this patient? Like, how do you follow up now?
So my plan, see, patient has already undergone lap chole, and there is still maybe 5% chance that this can turn out to be a
choledochal cyst. Yes.
So I'll go for stent extraction after a period of 3 weeks, and after that I'll repeat a NMRCP in this.
Okay.
Okay.
So stent removal, and during that time you will again sweep, balloon sweep?
Balloons, no need. I'll do just a check cholangiogram.
Okay.
Now the
and if there are stones forming again and again, then the possibility that it is a choledochal cyst is very high.
Yes.
In the absence of a gallbladder, again, and in the absence of a distal CBD stricture, if there are stones forming in the CBD, then it is very clear that it would be a choledochal cyst.
Definitely. And see why it is important to know whether it is a choledochal cyst or not, because it is a pre-malignant condition.
Yes.
So if it is a choledochal cyst, then that cyst has to come out. Okay, so that's it. I'll come out.
Excellent demonstration, Dr.
Thank
Mandar.
You. Any questions from the audience side?
Since you have your endoscopy and laparoscopy theatre side by side, Dr. Mandar, there was a question in the last ERCP. How soon after the ERCP can the cholecystectomy be done?
See,
how much is the timeline you usually?
So ideally, the earlier teaching was to wait at least for 24 hours.
Yeah.
Because ERCP is a potentially morbid procedure. There are possibilities of patient developing post-ERCP pancreatitis. But nowadays, with improved technique, improved instrumentation, the incidence has gone down significantly. So many times we do it in the same sitting.
Yes.
So first I'll do ERCP, clear the CBD, and then we just shift the patient to the next theatre, and the surgeon will do
So after
ERCP.
endoscopy, ERCP, when you do a cholecystectomy, do you encounter any problems with the distended bowel because of the air?
No, we use CO2. No?
Okay.
Earlier those problems were there definitely, but nowadays we use, carbon dioxide. So the moment I take out the scope, within next 5 to 10 minutes, the abdomen completely gets decompressed. So as such, that problem is not there nowadays.
Yes. So the
only problem will be if the patient develops post-ERCP pancreatitis after the surgery. Then we are in a kind of a dilemma whether the complication is because of...
That is what Dr. Praveen Suryavanshi said.
Yeah.
Like it is important to assess how your procedure
Yes.
went. If you have any doubt that it was a difficult cannulation
Absolutely
or multiple cannulation, then it is better to wait, because if you do a cholecystectomy and then the patient has persistent pain, then you keep wondering what is it, whether it's a bile duct, bile leak or pancreatitis. And
or perforation also.
Yes, in pancreatitis also there will be some amount of fluid collection. So then you will there will be a diagnostic dilemma, and so that is the reason you should keep it, space it apart.
Yeah.
But
you can go case by case.
Yeah.
Okay, they have to shift to the other OT. Thank you.
One question from my side, sir.
Yeah.
Dr. Amarvani, this side.
Thank you, Mandar sir.
After the sphincterotomy,
Now we are shifting to
how do you deal with the
OT3, procedure by Dr. Advai sir.
Shifting to OT3, procedure by Dr. Advai sir. 37 years old female, ERC with CBD clearance, with CBD stenting done 3 months back for choledochal lithiasis. Operated case of lap cholecystectomy 2 months back. No fresh complaints at present. Has now come for stent removal. Her blood investigations are normal. USG abdo-pelvis is suggestive of mild hepatomegaly with normal caliber CBD with stent in situ. Her plan is ERC with CBD stent removal and CBD clearance. Learning objective indications for balloon sweeping during stent removal are stricture reassessment, remaining small stones can be removed, and forgotten stent that is more than 4 months.
Over to you, Advai sir.
Am I audible?
Yes sir. Yes sir.
Hello? Am I audible?
You're audible sir.
Yes, you are audible.
So now we have heard the history of this patient. So Mandar and Suryavanshi sir have already demonstrated you how to negotiate a side weaving scope. But see, we can nicely see the patient is in left lateral position, which I prefer.
Endoscopic picture is not there. Please.
Are you getting it now?
Yes, we are getting the endoscopy.
So now here we can see even with the side weaving scope, we can easily see, identify.
Sorry, but the screen is blank. We have a window for endoscopy picture, but the screen is blank. No picture over there.
So once we get the image, we will start negotiating the side viewing scope. So are we getting the image now?
Not yet.
Not yet. So till that time we get an image. The difference between a forward viewing scope and a side viewing scope is the camera is placed at 0 degrees in a forward viewing and at 90 degrees in a side viewing scope. So what we see is the lateral wall of the esophagus while negotiating. So once we get the image, you please tell me so that I can proceed further.
So there was some question about papillotomy. Somebody was about to ask.
I heard, but at that time the question they had shifted. I think it was a question from the madam sitting there in the audience.
Yes, sir. I am Dr. Amalwani. The question is, when you are doing the papillotomy and sphincterotomy, the complication is always the bleeding. So if there is any hypotension, the bleeding doesn't stop, how do you go about it?
So madam, there is a kind of a stepwise approach. Once you do the papillotomy and if the patient starts bleeding, first thing you should do is complete the papillotomy. So many times if the muscle is not completely cut, then the blood vessels will be torn partially and they will keep on oozing. Once you complete the papillotomy, then the vessels may undergo spasm and the bleeding will stop. If that doesn't stop, then first you can inject some ice cold water over that. So that will cause spasm of the blood vessels and again that will help you stop the bleeding. If that doesn't work, then you can instill adrenaline with normal saline, 1:20,000 pounds. So instill that over the bleeding part, wait for some time and then the bleeding should stop. If that also doesn't work, then you can inject normal adrenaline in that area. That will give some tamponade action plus vasoconstriction. If that doesn't help, then you can put a CRE balloon inside the CBD and keep it inflated for some time. Again, that will put pressure on the bleeding point and then wait for the bleeding to stop. And many times bleeding should stop by this time. If that doesn't work, then you can also use a fully removable, expandable metal stent. So again, that will exert pressure on the bleeding point and that will help to control the bleeding. And if you are really unlucky and bleeding continues, then you have to go for interventional radiology and you have to do the angioembolization of the bleeding vessel.
Mandar, have you ever had to send a patient to an interventional radiologist?
Sorry?
Have you ever were in a situation where...
One situation where I had done endoscopic ampulectomy.
Okay.
After a papillotomy, I have never encountered.
Usually we can tackle the sequence which you said. I would deny we will inject or instill adrenaline because for that you need to remove the guide wire or by the side of the guide wire you are saying. But what I would do is I would inflate a balloon and wait for 2 or 3 minutes, just keeping the access inside because
by just completing the
papillotomy most of the times it is stop.
Only in one patient I told you, we had done endoscopic ampulectomy. After that the bleeding wouldn't stop.
Yeah, endoscopic ampulectomy is known for bleeding.
We had to take help of the interventional radiologist.
Yeah.
There was one question on YouTube. Somebody was asking, is there any correlation between H. pylori infection and acute pancreatitis?
Have you read? I have never read about such. But I have never read a paper also regarding that.
Such because it affects the gastric part of the...
Yeah, it usually the colonization is in the antrum and it increases the acid production. Yes, definitely it can lead to peptic ulcer disease and any further complications. But I have never heard of acute pancreatitis. I have never heard of.
Generally, pancreatitis is seen after viral infections.
Yeah.
Viral infection causing pancreatitis.
दुसरी केस घेऊन टाका. दुसरी केस घेऊन टाका. So Mandar, still till there is some technical fault in the transmission.
So one more discussion that was going on. There that they had kept the patient in prone position. So what is your preferred position?
No, I don't prefer the patient in a prone position because first of all, the airway gets compromised, and if the saturation drops, the anesthetist doesn't become comfortable. We have to immediately first of all withdraw the scope, then make the patient supine, then so that for that I would not prefer. First, that is the first important thing. Second, left lateral you are quite comfortable. Negotiating across the duodenum is also very easy, and anesthetist is also very comfortable. So since our traditional teaching, I have learned ERCP in a left lateral position. Of course, when I want a detailed cholangiogram, or if I am not sure, I would turn the patient in a supine position rather than a prone position, because the prone position definitely compromises the airway. And as Dr. Maidev, though he is the teacher of most of us, he has started doing ERCPs in supine position, and he prefers that so that the cholangiogram doesn't, you get a very clear cholangiogram. But I still start with
AIG people, they do it in prone.
AIG people, they do it in prone, but we start it on left lateral, and if required, we make it supine.
So I to do most other cases in supine position.
Okay. I usually preferably start with the left lateral, because supine also there is a risk of aspiration sometimes. They suck the stomach completely, and then if required, you can just change the patient into the supine position. That is easy. Mandar, what I usually in the back of the mind, we will take care of the anesthetist so that he takes care of our patient while we are busy in the procedure.
See, and most of the patients are a little high risk. They are not all ASA grade.
Yeah. Most of these patients are sick patients.
So
sick
prone
patient.
is really not comfortable, neither for us nor definitely not for the anesthetist. If the patient is a little overweight, obese, even making that patient prone is a task. So I haven't done ERCP in prone in
maybe many years. I don't know. Sometimes for pancreatic duct cannulation, sometimes they say that prone position is required, but in my practice, I have never encountered such difficulty. So I think they are shifting. There is some technical problem. So before that, so once that problem is resolved, we will start with this case. Till that, they are going to shift to some other OT.
राइस पण काढायचे झालं शिफ्ट
Hello.
Hello. Out here.
Shifting to OT number 2, PEG procedure by Dr. Mandar sir.
Yeah.
The patient history is a 60-year-old male. Patient is a known case of Parkinson with motor polyneuropathy. All 4 limbs were affected. Known case of hypothyroidism and bronchial asthma. Patient is bedridden, unable to walk since 1.5 months. Patient is on RT beats. Hence, patient is now planned for percutaneous endoscopic gastrostomy. MRI being suggested of age-related cerebral atrophy with chronic ischemia insults in bilateral periventricular region. Nerve conduction velocity suggested of predominant motor polyneuropathy affecting all 4 limbs. Plan is for percutaneous endoscopic gastrostomy.
Yeah. Am I audible?
Yes, sir, you're audible.
Yeah.
Over to Dr. Mandar, sir.
Yeah. So now we are planning to do a PEG procedure, and believe me, when I tell you, the most difficult part of this procedure is putting the mouth gag. So here also we are finding it very difficult because these patients are bedridden, they have neuropathy, some other neurological problems, and generally they are not intubated, they are not paralyzed. So in those patients, putting this mouth gag is the most difficult part. PEG. Okay, ठीक है. So putting a mouth gag is very difficult because many a times we have to do this procedure in bedside in the ICU setting. So चला हे पकड़ा लागेल ना कोणाला तरी काढायचा. So now fortunately with the help of our anesthetist we are able to pass the mouth gag. हे पकडू नको, तुम्ही mouth gag पकडा. So now I'll go inside. So the patient was on RT feeds. So before taking out the Riles tube, we have aspirated everything, suck out all the contents on the stomach. So now I'll go across the esophagus. Are you getting the endo picture?
Yes, yes.
Okay. So now I'll go into the stomach. I'll suck out all the secretion from the stomach to prevent any problems of aspiration. Then before proceeding with the PEG, we have to check whether the distal part, duodenum and everything is healthy. There should not be any mechanical obstruction in that part. Okay. Now duodenum looks okay. काय वाटतं आदित्य, अद्वय? Are we good to go?
Yes.
Okay. So I'll come out now. Now it is a 2 people's job. So now before starting with the PEG insertion per se, we have to distend the stomach so that the stomach, anterior surface of the stomach comes in opposition with the anterior abdominal wall. Now you should dim the light in your OT.
That is what I was going to say.
So I am distending. See, generally these patients are skinny, cachexic, but this patient is comparatively healthy. They have maintained the nutrition well. Hey, dakho re. Can you see the
glow? Can you see the glow? Can you appreciate the glow?
Yes.
Yeah.
So this is the ideal position. This is the diphisthanum. So you should put somewhere in this quadrant.
Yes,
so now
you would prefer a midline or
a little on the left side of the midline.
Okay.
So we see the impression, transabdominal. Yeah, perfect. You are good to go. So then you have to give local anesthesia there. Local.
Can you show endoscopic picture?
Yes, sir. This is the endoscopic picture.
Yeah.
So he's press karo. So he's pressing from out. So I am seeing the impression. So this is the good position.
Yes.
And I have distended the stomach enough so that even if some part of omentum or rarely intestine, if it comes in between, that should go away.
Mandar, what is the importance of glow? Can you elaborate on it?
So I told you, when you see the glow and when you see the thumb impression, that means possibly there is nothing in between the stomach and the...
actually signifies that there is the most important intestine is the transverse colon, which might come here. And if you don't see the glow, you please don't puncture.
Yeah. So now, take a stab. Hala?
So till the time we are getting things arranged. Now
Stab.
Now there is we are taking a
And
stab. Can you focus
yes.
here on his hands?
So now he has taken a stab and he is widening this opening, because through this, bas. Okay, through this the trocar will go. Bas. Yeah. Now through the same incision, he will pass the trocar with the cannula, plastic cannula. And he should go completely perpendicular to the causpice hai ka? Dao de ada. And the important part is he should go completely perpendicular.
So under vision,
yeah,
he should enter.
Go straight. Yes, perfect.
So
okay,
he has gone.
Yes.
Yeah. Now from here I will pass a snare. That other part. Wait, I'll tell you then.
So importance is not to lose the position of this cannula.
Yeah.
And you should keep it perfectly under vision. So now Mandar is.
Now you can switch on the light.
Now you can switch on the lights.
Okay, open.
Okay.
Now I'll encircle the cannula using my snare. Pull. Band. Bas. Now pass the thread. Now he'll pass the thread. Okay.
Now
Open.
The thread is out.
Open.
Can you appreciate
Close.
the thread?
Close.
Now
Yes. Close.
Will
Okay. Now
has hold this tightly the thread.
Now I have caught the thread in my snare and I slowly pull this out. Dalo.
So it is always a two-person job.
Okay. Can you see the thread has come out?
Yes.
Open.
Why is it necessary to catch the cannula with snare?
It's so that the thread doesn't slip out. It's not necessary.
Yes.
But the life becomes easier if you have the cannula inside.
Yes.
Now focus the camera on his hands, so he will show how the knot is been tied.
So this goes through this, and this is the stomach side of the tube. It will come out through this loop.
Okay. Yes.
And this forms a knot. Pakada. So this becomes a secure knot.
Yes.
Now I'll ask him to pull the thread out. Pull slowly.
You have to keep the cannula inside the position and just pull the thread so that there is no shearing effect of the thread.
Pull
on the stomach.
Once you get some resistance, then slowly pull this out. Yeah. Knife. Extend.
You just extend the incision a bit so that the tube comes out easily. You should not take a laparotomy incision. We are not going to put in a stitches there.
Yeah.
Just enough so that the tube comes out. Yes.
Okay. So you get the resistance
on the tube. So we are happy with the position. Now I think Mandar, would you do you every time check the position of the tube?
Yes. I'll make sure that I go inside. I check whether the tube is firmly in place or not. Okay. I'll just go inside. Yeah.
Yes.
Very
Good.
nice.
So this is the ideal position, somewhere in the mid body, more towards the antrum.
So if there is some oozing from the site of the pec tube, what would you do?
I'll just
put in some traction and keep.
I'll keep holding it.
It will take
Generally, that should stop the bleeding. The stomach is a very vascular organ, so some part oozing, some oozing you do expect. Once that happens, then I'll fix it. Caesar.
So now focus on the hands of Dr. Mandar.
Caesar. Hey, hold. Caesar hai? See, generally some sets they give Caesar also. And now this is a plate. This plate will go over this jelly. So we'll lubricate this a bit. Again, this is not a must. So this plate will remain on the skin side and other plate was on the stomach side. Now you can decide how much length of the tube you want outside the body. This is a stopper. So that will go over this. You can, after giving the feed, you can clamp this so that the feed will not come out. And you can decide, normally I keep this much length. So I'll cut this, and for the timing I'll keep this open so that all the air from the stomach should come out. And see, normally after any surgery, intestines or even the stomach will will show some paralysis. So similar principle I follow here. Since we are handling the stomach, you expect some kind of gastroparesis immediately after the procedure. So we keep this open for a period of about half an hour. And once the patient is shifted back to the ward, then we clamp this and then we can start the feeds.
So normally when you start your feeds?
After 2 hours. After 2 hours.
Do you start with test feeds or regular feeds?
We start with test feeds.
What we do is typically we will start with test feeds
of
50 ml,
50 ml.
For 1 or 2 feeds, and after that if the patient doesn't puke out or there is no problem, so we will start him on regular feeds.
So the best part of this is you don't need any sutures. Sometimes even if you don't do any dressing, that also is okay. But it's a good idea to keep some dressing.
For 24 hours, small dressing, and after that leave it alone.
You can start with the feeds. There are 2 lumens, 2 openings. From here you can give the feeds, and from this channel you can inject some water so that to keep this tube clear. So the longevity will be more. The advantage of this PEG tube over RISE tube is firstly the lumen is wider. The largest RISE tube you can put, maybe it is 18 French. This is 24 French. So you can give larger quantities of food. Even things like dal rice or even roti, you can crush it in the freezer and mixer, and that can be given this. Second thing is the length of this tube is shorter. So the chances of tube blockage are lesser than as compared to the RISE tube. And patients are definitely more comfortable with this rather than having a RISE tube.
The most important thing is the G junction is not
open.
And
aspiration.
Therefore the chances of aspiration get reduced with the RISE tube.
So if you expect longer tube feeds, then it is definitely advisable to go for PEG rather than RISE tube.
When would you change this tube?
Only if it gets blocked. It's not a must. It can remain like this if you take good proper care. Then it can remain patent for even for 6 months. And nowadays you get exchange kits from companies like Wilson Cook. So that you can just take that this tube out and insert that exchange tube the way you insert a Foley's catheter. So the exchange is also very easy. So it is really a boon for the patient. We can shift to the other OT now.
What is the manufacturer of this tube?
Let me check. So many companies are available.
Yes,
when we started, this is Avanos. So when we started, that time only Freca tubes were available.
Yes.
The Freca tubes, the problem with those tubes was the French they were available only in 20 French.
Yes.
These newer companies, they have come up with 24 French, and they are little more easy to deploy.
Now they are used for nasojejunal purpose only.
Yes, sir. By far, Many companies are there, as I said, but Cook, Wilson Cook, Boston Scientific, Medtronic, those 3-4 companies are good.
Yes, yes.
Very easy to
Initial
use.
days of my practice 25 years back, I used to go to my medical gastroenterology friend for assisting him this procedure that I have remembered.
Yeah. So actually, sir, this is a surgical procedure.
Yes,
so
yes, but at that time, I was not having gastroscope.
That's true, that's true. So when I was learning endoscopy, I was with Dr. Bapai sir, and he had told me to stop doing all the surgeries if I want to become an endoscopist.
Yes, yes, yes.
So I stopped doing surgeries, but when I did this PEG tube for the first time, that gave me satisfaction कि चलो कुछ surgery अभी कर रहा हूँ. So this procedure is very close to my heart.
Yes, yes.
Okay. So we can shift to other OT, sir.
What are
Thank you, Mandar sir. Now
Yes, sir.
shifting to OT1 by a project by Praveen Suryavanshi sir. Patient 37 years old male complained of difficulty in swallowing liquids greater than solids since 2 months. Pain in abdomen, epigastric region which aggravates post meals, nausea, vomiting after meals, decreased appetite and weight loss. Ogidoscopy done outside suggestion of dilated esophagus with resistance noted at GE junction with fundal gastritis. X-ray barium swallow is suggestion of ecclesia cardia. Now plan is for poem. Over to you, Suryavanshi sir.
Hello, am I audible?
Yes, yes.
Yes. Again, as mentioned in the history, 37-year male came with history of dysphagia, and on endoscopy there is a dilated esophagus. Can you appreciate this esophagus?
Yes, yes.
So this is a dilated esophagus with without any mucosal changes. So there is no esophagitis, and at the lower end of the esophagus, can you appreciate there is a resistance?
Yes,
Yes, I'm entered inside. Okay, so there is a resistance at the esophageal junction, and there is no any food residue into the gastric lumen. Okay.
Yes.
So and his manometry has been done, which has reported as a type 2 ecclesia cardia. Okay. So now this for poem, what is first step is that you must examine the esophagus very thoroughly. There should not be any severe esophagitis or any candidiasis, or it should be clear of all food particles. Since with mucosotomy we will be going into the submucosal plane. So if the esophagus itself is full of food particle or infection like candidiasis, all that, everything will take inside the submucosa, and after myotomy we get exposed to the mediastinum. So again we will be contaminating mediastinum also. So that's why before you start your procedure or mucosotomy, esophagus has to be cleaned. Give this thorough wash repeatedly until and unless completely clear water you are sucking it out again. Okay. Now once esophagus is clear completely, then we have to measure the location of the esophageal junction. Normally it is at 40 centimeter. So in this case also it is around. So now this is the esophageal junction. Can you appreciate?
Yes, yes.
Okay, but just see here. Scope dakho, ikkada dakho. And always you measure when you are withdrawing the scope. So whenever you are withdrawing the scope, that time scope is straight. When you are pushing the scope, especially in the sigmoid esophagus and all that, that time scope may not be straight. So that time you may get the false reading. So at the time of initial assessment and at the time of final assessment for the adequate myotomy, always measure the length of the scope at the time of withdrawal of the scope. Is it clear?
Yes, yes.
Okay. So I push inside, I am now withdrawing. The scope is straight now. So this is the esophageal junction. And now you see here. Can you able to see here?
Yes, yes.
So this is 50 mark. So this is 50 mark. This is 45 mark. And this, it is just proximal to the 45. That means around 43 centimeter the esophageal junction is there. Is it clear?
Yes, yes.
Okay. So now what since it is a type 2 achalasia, I am planning 6 centimeter myotomy on the esophagus side. Okay.
Yes.
And between the mucosotomy and the proximal end of myotomy, there has to be 3 to 4 centimeter of the normal
distance,
submucosal tunnel.
Yes.
Okay. So that 6 centimeter plus this 4 centimeter, 3 to 4 centimeter. So approximately 10 centimeter. Okay. And again for the mucosotomy, I will take minimum 2 centimeter incision. So I must puncture, it is 12 centimeter from the gastroesophageal junction. Is it clear?
Yes, yes.
Okay. So now this is a 43 centimeter. So my puncture site will be at 31 centimeter. Okay. So this is now 30 here. So this is 30 now.
Yes.
See, this is 30. This is 30.
Yes.
Okay. So so this is like 29, 30, and this is 31.
Yes.
Okay. So I am approximately 11 to 12 centimeter proximal to the esophageal junction.
Yes.
So that 2 centimeter mucosotomy, 3 to 4 centimeter normal submucosal tunnel without myotomy, and then 6 centimeter myotomy.
Yes.
And after that 2 to 3 centimeter myotomy on the gastric side.
Yes, yes.
Okay. So here I will now. So you can do either anterior myotomy or posterior myotomy. Okay. There are no any benefits of any myotomy or other. Whatever you are trained at, whatever you are comfortable at, you can do. But being a surgeon, what I believe, that if you do this myotomy posterior, if at all there is any recurrence or any failure, then you can do surgically anterior myotomy comfortably.
Yes, yes.
Okay. So that's why I prefer to do posterior myotomy. Or if surgically already Hellas cardiomyotomy has been done, and after if patient has come with the recurrence, then endoscopically you can do posterior myotomy again.
Yes, yes.
So I keep posterior myotomy reserved for the endoscopy and the anterior myotomy reserved for the surgically.
Yes, yes.
Okay. So being a surgeon, we have this flexibility.
Yes.
Okay.
Yes. How to confirm you are in the posterior line?
So again, very good question. See, one thing is that, you know, we can, once we inflate the esophagus, we can see the posterior impression of the spine. Can you see this?
Yes.
Spine posteriorly? Good. Can you see?
Yes, yes.
Spine. This is anterior cardiac pulsation, and this is spine. And again, whenever you inject, you know, fluid,
yes,
it
yes.
will, since patient is in the supine position, it will accumulate on the posterior surface of the lumen.
Yes.
So now you can appreciate the fluid is on the posterior side.
Yes, yes.
Okay.
Yes, yes.
So again, I will suck it out. Sure. So at 5 o'clock position, we have to puncture the mucosa, go into the submucosal plane.
Yes.
Open. Inject. See now.
Yes,
I am
yes.
injecting. So immediately there will be mucosal bleb. Inject almost 20 cc of
Indigo caramel.
normal saline
Okay.
with stain with methylene blue.
Acha, okay, okay.
ठीक है.
Yes.
So as I mentioned, this mucosa usually get raised distally.
Yes.
ठीक है. So I will go distally like this. So can you appreciate?
Yes,
Very nicely raised mucosa.
Yes, yes.
Then I
Was
will
that 23 French needle?
23, right.
Yes.
So use 23 so that it doesn't leak out from the same opening again.
Yes, yes, yes.
The bleb remains there. So I am doing now mucosotomy. Open.
Mucosotomy with needle only, with energy source.
Is a TT knife.
Acha, okay, okay.
Hold. Open.
This is monopolar current you are using.
Monopolar. Monopolar endocut.
Endocut, yes.
किती उचलला हिच्या आईला. I am just further raising these flaps
Yes.
so that my scope stays there comfortably. So I have entered submucosally, okay.
Yes, yes.
This is submucosal plane. So this is another important steps, in poem that
Now there are bipolar gadgets like speedboat. Have you any experience?
no, the bipolar forceps we have,
Okay.
but for with dissection purpose we don't use it.
Okay, okay.
This is only for the coagulation.
Coagulation.
Yeah. See now, can you appreciate this is mucosa posterior, muscle layer posteriorly.
Yes, yes.
This is submucosa, and anteriorly there is a mucosal layer. So now we have to stay in this plane throughout. So now there are different ways, technique, usually,
Yes,
normally, what I have seen, most of the endoscopists, they keep this like this, muscle layer posteriorly
Posteriorly,
and the mucosa anteriorly. And then with the tip of the instrument like this, they will divide like this, like this. But what I prefer to do, open. See, I am keeping muscle
yes.
layer on my left side
Yes.
and mucosa on the right side.
Okay.
ठीक है?
Yes.
And like this semicircular way, एक मिनट. Hold. See, like this. Half circle I am covering like this. See,
Yes,
from
yes.
3 o'clock position to 9 o'clock position, every time I will go like this. Now I come back again at 3 o'clock position. ठीक है? I am going to the 9 o'clock position like this.
Yes, yes.
Huh?
Yes,
So you can cover more area. See the scope has got more mobility in up and down direction than left and right. And for us also it's very easy to manipulate big wheel than the small wheel.
Yes, yes.
Because this is how this way it helps for the faster dissection. So every time you keep on injecting, this saline, so that mucosa is raised. So whenever you find that the submucosal plane which is not stained, that means there is no adequate, raised flap is raised. See, like this, yeah.
Yes, yes.
I'm going from 3 o'clock position to 9 o'clock position.
Yeah.
So, now there are vessels.
Yes,
So
yes.
this vessel you must coagulate. Okay. So these are the vessels which are on perforators. They communicate subserosal plexus to the submucosal plexus. These are the perforators responsible for the esophageal varices in portal hypertension. Okay. Now this is on the lateral side. In fact, I can avoid. Okay. I will not coagulate this. So, especially in patient with sigmoid esophagus, where the course of the esophagus is tortuous, the best way to remain in the lumen straight is to stay perpendicular to the circular muscle fiber.
Yes.
Okay, now this is circular muscle fiber. Can you appreciate here?
Yes, yes.
Huh?
Yes.
So I should not go in this direction. So I will not be perpendicular. So what is the right direction? Is this way.
Yes.
Stay perpendicular to the fiber.
Yes.
Okay.
Yes, yes.
Open. Can you appreciate it? Circular muscle fiber.
Wonderful.
So stay close to the fiber so that you don't injure mucosa. Okay?
Yes.
So this is known as endocut. It comes in pulse.
Pulse, yes.
So like again some endoscopies they use coagulation like this.
Yes.
So it I prefer to use it only when there are vessels. Can you appreciate there are vessels?
Yes, yes, yes. Yes. This can you get with bipolar?
This I will manage with yes, of course. I am just dissecting around it.
Yes. Endocut is one pulse of cut and two pulse of coagulation, I think.
Yes. Okay.
Yes.
So this is how these vessels they come from the subserosal to the submucosal.
Yes.
So these large vessels. So I will coagulate these vessels.
They can spoil the field if they bleed.
Yes, yes. So this is very very small place.
Yes.
So any minimum bleeding will make read out completely. So it's best way to have best vision is to avoid bleeding. Open.
Yes.
So these are the coag grasper. So here I will use coagulation. Oh. Open. Catch. So these perforators,
yes.
they get retracted inside the muscle,
Yes. Wonderful
so
demonstration of coagulating such bleeding
yeah.
points. Yes, yes.
So what I did, I just compressed it with my scope itself, with the cap.
Yes, yes, yes.
Okay, still. So one limb I have, coagulated, and I hope that current has passed to the other limb of the vessel, which was bleeding.
Yes, yes.
And now I am compressing it.
Yes.
So slowly I will withdraw it, and I am hopeful that this bleeding will stop. Have you understood what I did?
Yes, yes, yes.
See, there are two limbs of the vessels.
One
limb was bleeding, other limb was intact.
Yes.
So instead of keep on catching this limb,
yes.
which get most of the time retracted inside, I caught this limb,
Yes.
I use heavy current so that this current will reach to this limb.
Opposite.
Opposite, and it will help to stop the bleeding.
Yes.
And again compress it. Now I am withdrawing it again. So see, this deeper portion has stopped, but this is the mucosal end. Okay.
Yes.
ठीक है. Open. Catch. Again, be very careful not to injure mucosa.
Yes.
Open. 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 Catch. Open.
Yes, yes.
ठीक है?
Yes, yes. Is this a bipolar coagulator?
No, no. Monopolar.
Okay, okay.
See, I'm bleeding has stopped. Okay? Okay? He? Bipolar. He there. तिकडे काय करतात? Open. Catch. Open. Open. Catch. Open. Injection. We always intubate these patients.
Yes, yes.
So that whatever wash we give fluid, most of them will get accumulated in esophagus. So they should not aspirate it. So whatever submucosal injections you give, it just remains there for 4 to 5 minutes. After that, you get reabsorbed. So you have to keep injecting repeatedly. Bas. Open. Already vessels were there. I am using coagulation. So this I am using coagulation. Okay.
Yes, yes, yes.
So it is not that controlled, coagulation. Okay. Endocut is a controlled, cutting. Again, there are vessels here.
Yes, yes.
Bipolar.
Is this a Valley Lab cautery or Arbe?
Pardon?
Cautery is Valley Lab?
No, this is Arbe.
Arbe, okay, okay.
For this, RV is good for this endocut. You know?
Yes, yes, yes.
So for endoscopy suit, I think RV is the best. I think BP किती है? Open. Catch. Catch. Open. So I have reached already 40 marks. Okay.
Yes, yes.
So my target is, minimum 46. So our esophageal junction has 43. So I must go 3 centimeter beyond that on the stomach side. Okay.
Yes.
Dr. Joy is there. You have any questions?
No,
any
sir,
comments?
we are spellbound by the beautiful dissection.
Yes, yes,
Absolutely fantastic. No
Wonderful.
questions. Just admiring the surgery.
No, no, no.
The ease with which you are going and identifying each and every vessel and coagulating. It's a fantastic display.
Normally you don't get this much also bleeding. So I am dissecting not side to side. I am dissecting downward to upward. Like this.
Yes, yes.
By changing the, by rotating the scope. So I am keeping this is a circular muscle fiber, perpendicular to that.
Is this a scope of 190 series?
Yes.
Okay.
Inject. It doesn't make difference. Yeah. This is just for the conference purpose I got this, but my own scope is 170 series.
Yes.
And I'm doing with those scope only.
No, light is much brighter of this scope.
That we can adjust on a LED also, wall also.
Yes.
When we reach at esophageal junction, usually this submucosal plane also get narrowed.
Yes, yes.
We inject. Bas.
There is usually a vertical vessel on left side at this level.
See, there are vessels at the roof. I will preserve those vessels.
Yes, yes.
So it need not, divide or ligate or, coagulate all the vessels which come on the your way. You must try to preserve as much possible. Open. Catch. If you are done completely this submucosal tunneling from 3 o'clock to 9 o'clock position properly, then only comfortably you can move your scope like this.
Yes.
Otherwise, it gets stuck. Your scope itself gets stuck during the submucosal tunnel. That means that proper adequate tunneling has not been done. Inject. So I'm so my scope is at now 41 centimeter. So I'm very close to the esophageal junction.
Yes, yes.
Okay, open. Can you appreciate the lumen is getting narrowed here?
Yes, yes, yes.
Because I am at the esophageal junction now. Inject. Bas. Open.
After myotomy, in which cases anti-reflux procedure is necessary?
Pardon?
After myotomy, in which cases anti-reflux procedure is necessary?
See, for poem, see myotomy, healers, whenever you do, routinely we do anti-reflux procedure.
Yes.
But in the poem, now some people are doing this anti-reflux procedure, fundoplication.
Yes.
But that is again in evolution stage. How effective it is, how complete it is still in a debatable.
Yes, yes.
But it is not routinely done and any anti-reflux procedure after poem. Okay.
Yes, yes.
But this is the major things which is debated against poem is the post-procedure reflux.
Reflux,
and that
yes.
reflux is definitely there. We cannot, deny that.
Yes, yes.
But in our series, just 15% of the patient they required PPI to control these symptomatic reflux. Rest, hardly 10% there is a reflux on endoscopy, but patients are not symptomatic. Okay? And
Yes, yes.
almost 70% of the patient there is no reflux at all. So now many techniques or recommendations has been were there to avoid reflux, but
Yes,
nothing is working right now. So once you cross, esophageal junction, you appreciate, see this is the lumen here. So at this point it was the narrowest. Okay. Once I cross this narrow, suddenly there will be big lumen again.
Yes.
And again there will be palisade appearance of the vessel. Can you see these vessels on the muscle?
Yes.
Palisade, multiple small vessels.
Yes.
So these are the gastric side now. I have entered into the gastric submucosal plane. Okay.
So you are going 4 centimeters.
Yeah.
Yes.
So again there is a vessel at roof also. I will try to preserve that vessel.
Yes.
Hello.
Okay. Karan.
Praveen, what is the incidence of surgical emphysema after this procedure?
Yeah, you get pneumoperitoneum or pneumoperitoneum in this patient.
Yes.
So if you are using, we use carbon dioxide for these cases. If you are using judiciously on the low flow, and then you don't get. Initially, whenever we started, almost 50% of the patient we used to get pneumoperitoneum.
Hello.
This patient also,
Hello.
if you see here, can you show? So whenever we drape this patient, we always keep abdomen open.
Yes.
To inspection, regular inspection.
Okay.
So anesthetist, they keep inspecting it. If there is a distension, then we can do just puncture it with the routine our angiocath and take out the air during the procedure itself. Okay. But now you can appreciate there is no pneumoperitoneum at all.
Yes.
And sir, important thing is you should make the tunnel roomy.
Yes,
so if the tunnel is too narrow, then the CO2 will get trapped, and then that will percolate through this.
That's right.
And the chances of pneumoperitoneum or pneumometastasis are more. If the tunnel is roomy, then the CO2 will leak by the side of the scope.
Yes.
That's
the pressure will not rise.
Dr. Makaran?
Yes.
Till the time Praveen sir starts myotomy, the technical problem of OT3 which we had discontinued has been solved.
Yes.
So Dr. Advay will be showing ERCP, balloon sweeping and stent removal.
Yes.
Over to Advay.
Yes. Thank you.
We are again ready with the same case. It is a due to the ERCP with stent removal. But so the history of this patient is it is post ERCP CBD stone extraction followed by lap chole. But the stent was forgotten for almost 4 to 5 months. So this is one of the primary indication of after doing a stent removal, we should go for cholangiogram, check cholangiogram and CBD clearance if required again.
Yes.
So there was some issue in oxygen levels, but it has been taken care of. So we will start. So should I start? Yes. Okay, thank you. So are you getting the endoscopy picture now?
Yes.
So here we will suck out everything into the secretions in the throat and try to identify the pyriform fossa with a side weaving scope. It is a bit technically challenging sometimes. But now here we are into the pyriform fossa. Okay. So with slight down movement of the big wheel and gentle pressure, you can enter the esophagus, and you can see the sliding mucosa of the esophagus. Okay.
Yes.
So once you are comfortable, you start giving gentle pressure see with the side weaving also, by down wheel of the down movement of the big wheel, you can see the entire lumen of the esophagus.
Yes, yes. It is just like 30-degree laparoscope.
Yeah, yeah, yeah.
Yes.
So this is a 90-degree scope, but by making the big wheel away, you can change the angle a bit. Importance is to suck these secretions into the stomach, because the patient might aspirate. So you spend 1 minute in sucking these things.
Yes.
So you can see this is the pylorus,
yes,
and this is the setting sun sign. We are into the first part of duodenum.
Yes.
Once we come at this loop, you just turn your big wheel up, small wheel to the right, and you enter into the second part.
Yes, yes.
You can see this stent well in place. So then what you do is you to release the small wheel so that the scope comes in alignment with the stent. So are we okay?
Yes, yes.
So we can see this end of the stent.
Yes.
This is, I think, a 7 French stent,
Yes.
which can be pulled out through the scope.
Which gadget
Easy.
you are using? Either alligator jaw forceps or...
Pardon, sir, I cannot hear you.
Which gadget you are using to remove the stent?
I would be using a snare.
Snare, okay.
Should I continue or remove the scope? Kadu? So there is some problem with the saturation levels.
Okay,
So
okay.
anesthetist has requested me to remove the scope. So while coming back also you should suck completely and give the access to the anesthetist. Most of the times, because of propofol, there is a transient fall in the oxygen saturation by just lifting up the chin and because of the tongue fall. Usually it can be avoided by when the scope is inside the esophagus, it prevents the tongue fall, but sometimes you have to remove the scope for a proper ventilation.
Dr. Advait, till the patient is stabilized, we shift to OT1 in the meanwhile.
Yeah, okay, sir.
Hello?
Yes.
Yes, sir, you're audible, sir.
See, now you can appreciate this is the 43 centimeter, and this is the narrowest portion here.
Yes.
Okay, can you see in the scope also?
Yes.
Here,
Yes. Yes.
This is 45. Sorry.
43.
This is 45.
Yes.
So 2 centimeters just proximal to is 43.
Yes.
So what we are marked. Okay.
Yes.
So and I have gone 3 centimeter beyond the esophageal junction on the stomach side like this.
Yes. Yes.
Okay, these are the oblique muscle fiber of the stomach.
Yes.
Can you appreciate?
Yes.
Okay. Now what I have to do, I have to come 6 centimeter proximal to this to start the myotomy. So 43, so this is now like 37. Okay.
Yes.
Can you see here? This is 40.
40, yes.
And this is
37.
37. Okay. So I will start myotomy from here. This is how we calculate distance.
Yes. Yes.
Don't you?
Yes, sir. And it should be at least 2 centimeter below the mucosal incision.
So we did mucosotomy at 31 centimeter. So it is almost 6 centimeter is there.
So the principle of POEM, it is a flap valve. So where you are incising the mucosa, the muscle is intact, and where you are cutting the muscle, the mucosa is intact.
Yes. Yes.
So sir is first using coagulant for first few cuts, and then he'll use a cutting current.
Cutting only.
Praveen is the exception to the rule that if you want to become a good endoscopist, you should leave surgery. Hello? You are the exception.
See, everyone need not to go to all advanced procedure.
Yes.
But a basic procedure as a general surgeon we must know.
So I feel every general surgeon should know at least basic diagnostic
Yes,
upper GI and
yes.
lower GI scopy.
Gastroscopy
And if you get more interest, you become passionate about it, you go for the advanced endoscopy,
Yes.
leaving other surgery.
Surgeon should not leave surgery.
Okay. Now it is said, whether you should do just circular myotomy, leaving behind vertical muscle, But what I believe, what we are trained in surgery, that there should be, complete 180-degree mucosal pop out for the adequate Hellas myotomy.
Yes.
Okay. So if you want to achieve that in endoscopy also, you must divide vertical muscle fiber also. But
Sir, actually when you cut the vertical longitudinal muscles, you are actually not cutting them, you are just splitting them.
Splitting them, that's what.
And once you do full thickness myotomy, that confirms that you have cut all the circular muscles also.
That's right.
So maybe initially you can go for only circular in the proximal part, but as you go closer to the GE junction, you should do full thickness.
So what I am doing, I am putting my this TT knife inside, raising the muscle. First posteriorly I am using just small burst of coagulation, and then I am cutting with the cutting current like this. So can you appreciate now vertical muscle fiber below?
Yes.
So as rightly said by Mandar, as we progress further, we will do full thickness. Okay, see now we are dividing both vertical and circular muscle fiber.
Very
Is it
nice.
clear? So we are actually into mediastinum, posterior mediastinum.
Yes.
And you are doing it almost bloodless.
Yeah.
We can't see even a single drop of blood. Very nice.
Thank you.
The trick you have told that first you should give a burst of coagulating current. That is working very nicely.
See, having a good cautery also helps, but your technique has to be right.
Yeah.
So because you are doing it very nicely, that's why you can't see even a single drop of blood.
Clean cut.
So you'll divide that fiber, one fiber is...
Yeah. So any questions?
I think the entire audience is zapped by your
No,
technique.
no. It is stunned to see the perfect dissection.
See, I tell you, as a surgeon, if you are in the right plane,
Yes,
the
yes.
things are very simple and enjoyable.
Yes, yes.
Staying in the right plane is the most important thing for any surgery.
But they see very easy with expert hands also, and that gives pseudo confidence. That is also another thing.
That's what I was about to tell. Most people sitting would now start thinking that it's so easy a procedure, we can
Yes, yes.
start doing it from tomorrow.
Yes, yes.
Makran,
Huh.
we are shifting to again Advai. He has got hold of the stent.
Yes, yes.
And till the time sir completes, goes ahead with myotomy,
Yes, yes.
we'll finish that procedure.
Yes, yes. Yes, Advai. Hello.
After stabilization, what I have done is I have quickly gone into the second part of duodenum.
Yes,
With
yes.
the help of a snare, I have caught hold of the stent. Okay. Here the principle is you try to catch the stent as distally as possible,
Yes,
so that
yes.
the scope stent comes through the scope,
Yes,
and you can watch it coming out of the ampulla. Gently you pull. See this, there is lot of sludge and muck which is being coated
yes.
around the stent. So we are through.
Yes, wonderful.
So उडेल ते सगळं. हां चला. Now what I am going to do is, though this is a previous ampulla with a previous sphincterotomy, so cannulation would be easy. Now I will ask my assistants to give me a ultratome. Fluoro, please. So my scope is, can you see the fluoro picture?
Yes, yes.
My scope is nicely in a straightened position, and the ampulla is at 11 o'clock. So I am comfortable with this. So now gently bend a bit. Tamba. Bend. Putting wire. Wire taka. So the wire is been advanced. जाऊ द्या होते wire वर. Shoot. Wire is getting coiled. थोडं मागे घेऊन परत जाऊ द्या. थोडं तुझं हे घेतो का मला सियाम दिसत नाही. So now the wire is looped somewhere into the tree. थोडी मागे घ्या, मी वरती जातो, मग तुम्हाला सपोर्ट मिळेल. So you have to work in tandem with the assistants. So now what I have done, I have pushed my ultratome. मागे घ्या आणि परत स्ट्रेट जाऊ द्या. Wire, shoot. The wire is gone up now.
Yes.
So what I will do is I will start putting contrast from above. There is some bleeding coming from the common bile duct. Contrast. Shoot. Taka. So you can see that common bile duct is a bit dilated. Okay. And there is some sludge into the distal common bile duct.
Yes, yes.
So what I will do is ask her to change this wire with a balloon, with a Visiglide आहे, exchange करू आपण. Okay. So now we will exchange आणि balloon सुई. ठीक है ना पेशेंट? So now I am gradually exchanging my ultratome with a balloon. So
Yes.
once I am out, yeah, we are out. Sister, balloon gaya. So if you can see, the sphincterotomy is quite wide enough, done previously, so I am not going to extend it further, because anyways I am dealing with sludge and not bigger stones. So now we are ready with the balloon. Balloon is going up. Fluoro. So what I typically prefer is to inflate the balloon first into the lower part of the common bile duct. Inflate kara. हाँ, balloon inflate. Balloon inflate. And try to remove it so that it is easily coming out. So there is no stone there.
Yes.
Now again, now wire tight पकड़ा ना, जात नहीं है balloon वर. ओढली तुम्ही wire, फ्लोरो, wire ढकला. Yeah. Okay. वायर थोडंसं टेन्शन ठेवायचं फक्त, म्हणजे मी जेव्हा पुश करतो ना तेव्हा वायर ओढायची नाही आहे खाली. फ्लोरो चालू ठेवा. देयर इज सम रेजिस्टन्स फॉर द बलून टू गो अप. आय डोंट नो वाय. आस्किंग माय असिस्टंट्स टू कीप द वायर इन अ टेन्शन, बट द बलून इज नॉट गोइंग अप. And there is a bit oozing here.
Yes, yes. We are not getting fluoro picture here on the screen.
वायर वरती डीप ला जाऊ द्या. वायर डीप नाही आहे. हां हां
Hello.
ठीक आहे ठीक आहे.
Hello.
बलून चढत नाही आहे. काहीतरी वायर खराब होती का? बलून जात नाही ना.
Hello, sir. Can you see our OT?
Yes, yes.
Yeah.
Gastric,
To OT
lower
one,
end of the gastric myotomy.
So are you getting the endo picture from our OT?
Yes, yes, yes.
Yes,
Praveen, yes.
Yeah. So this is lower end of the gastric myotomy. Can you appreciate vessels below here?
Yes, yes.
Huh? So
Yes.
we have to be very careful not to injure.
Yes.
Again, same vessel is going, see here, and
Yeah.
going to the submucosal plexus, which we have preserved. Are you appreciating this?
Yes, yes.
Huh?
Wonderful.
Yeah. So, so we have finished myotomy, and here you can see now it is 46 centimeter, 45 centimeter externally. Okay.
Yes, yes.
Huh? Now I am withdrawing it. So this is the portion where it was a esophageal junction was there, lower esophageal sphincter. So almost 2 to 2.5 centimeter we have gone below. Then we are withdrawing it. This is the esophageal side of myotomy. Okay. There is no, so it's nicely wide open. Okay. So
Yes.
this has become because we have divided the vertical muscle fiber also. Okay. So wide open myotomy here, Now this is the upper end of the
Myotomy.
esophageal myotomy.
Yes, yes.
Now I am withdrawing it. Now this is the area where mucosa and the muscle both are intact.
Yes.
Okay. So now I am withdrawing. Now there is a mucosotomy. So there was a again 2.5 to 3 centimeter of the normal tunnel without myotomy or mucosotomy.
Yes.
Okay. So another trick of complete myotomy, whenever now I am passing my scope, I am just walking inside the stomach without any resistance like this.
Yes.
See, there is no resistance at the
Yes, yes.
esophageal junction, which initially we were struggling
Yes,
to
yes,
pass. Okay. Okay, it's easily walking in. So
Yes.
that another indicator that we have done adequate myotomy. Then now we will close this mucosotomy. So again, till end there is no pneumoperitoneum.
Yes, yes.
Open.
What clips are you using, sir?
These are the,
Olympus?
not Olympus. These are Korean company. They are cheaper than Olympus.
Disposable clips?
No.
Reusable.
Disposable.
Reusable. Okay,
Fire. Reusable. Applicator, na? Reusable. So, disposable with rotating and all that facilities available, but they are very costly.
Yeah.
That per application cost around
3,000.
3,500, 4,000. But this single chip clip itself costs just 700 to 800 rupees.
Okay.
Olympus is also having the same price.
Yes, yes.
Praveen.
So
700.
this applicator is Olympus,
Ha,
but
ha.
the clips are not Olympus.
Okay. Applicator, I think 40,000.
Yeah.
I am having that applicator in my hospital.
So now this is must to have accessory for any endoscopy
Yes, yes.
unit.
If you are
Not
using
just for the poem, but for the control of the bleeding.
bleeding, yes.
For
yes.
the other, we should have. So what is important here, that once you are place the clip, suck, so
Yes.
that there is approximation of the mucosa, and then you fire. So whenever you are firing, actually, withdraw. It is a blind, scope. Misfired.
Misfired, yes.
Not
Clip on
misfired.
clip.
No. The scope got withdrawn. So what you should do, keep your scope inside the lumen. So once it come out, you don't injure anything. Open. Fire.
Yes. Wonderful.
ठीक है?
Yes.
One more. So what I mean to say, everyone need not to do all these procedures,
Yes.
but we don't know what else is there on our way
Yes,
in
yes.
advanced endoscopy.
Yes.
So we must prepare for that situation.
Yes.
If any further advanced procedures comes, then as a surgeon, we should able to, take them and, do it in a, I feel not, better way, at least as par with any other competent endoscopist.
No, these clips are very useful after polypectomy bleeding. If there is bleeding after polypectomy.
That's right. Fire. Okay?
Yes, yes, wonderful.
Thank you.
Can you hear the sound of clapping?
Yes, yes, yes. Thank you, thank you. Thank you.
It was really wonderful procedure. Praveen, is it necessary to go for esophageal manometry before?
Yes, 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 yes. You must go because inometry, classify it into type 1, type 2, type 3.
Yes.
If it is type 3 especially, then we have to do more myotomy on the esophagus side.
Okay.
Okay. And again, you must explain it to the patient that, if there's a type 3, like a corkscrew esophagus, then that patient will feel dysphagia,
yes.
but there will not be stagnation of the food.
Yes,
So otherwise, post-operatively they keep complaining, atak raha hai. So if you can convince them before operation that by this operation we can do long myotomy and will relieve maximum spastic segment of the esophagus, but not all. So those spastic segments which are in the proximal esophagus, they may make them give them feeling of dysphagia, but they will not be actual stagnation of the food particle, which is a major concern.
Yes, yes.
That we have to explain before operation. So then they accept post-operatively.
Yes, yes.
So that counseling helps before operation if you are done manometry, and
Yes,
also
yes.
it helps you to decide the length of myotomy on the esophagus.
Yes, yes. Is it necessary to get it done post-operatively also, manometry?
No, not required, not required.
Okay.
No. But post-operative follow-up endoscopy has to be done,
Yes.
whether patient is complaining or not. So in our institute, we do after 6 weeks, after 3 months, after 6 months and 1 year.
Okay, okay.
Yeah.
And in
Just
sigmoid esophagus, what precautions and what are the results of poem?
See again, sigmoid esophagus, whether it's a poem or Halar's myotomy, the challenges are same.
Yes.
That the esophagus itself is such a hugely dilated, and there is no aperistaltic. So patient will have some sort of retention, fluid retention, so that, but there will not be complete obstruction.
Yes,
That
yes.
what you get. There will be some retention, but it will keep clearing without causing much problem.
Yes,
So having small frequent meals, keeping gap of 2 hours between meal and bedtime, that all restriction or the dietary suggestions must be given to this patient, and they must follow it very strictly. Otherwise, they will have food aspiration later on, just because of the fluid get stagnated in the esophagus.
Yes, yes. Yes.
Sir, one question from my side.
Hello.
Thank you, Suryavanshi sir. Now we'll be shifting to Unit 2, OT2.
No, there is some question, I think.
Yes, Praveen.
Sir, a question from my side. When do you do poem and when do you do Hellers?
See again, if it is a first time patient is coming to us, if it is a type 3 achalasia cardia, then definitely poem is better than Hellers, because we can do long cardiomyotomy. And I think for me the only absolute indication for the Hellers cardiomyotomy is that if patient, some previous surgery has been done in esophagus, like previous ESD, EMR, or banding has been done, then I will not do, or a patient with portal hypertension, I will not do poem. Otherwise, the rest all cases, poem has benefit over the Hellers cardiomyotomy. Like patient with type 3 achalasia cardia, patient with previously operated upper abdominal surgery, patient with compromise other general health of the patient with ISD and all that. So where the laparoscopy have limitation of pneumoperitoneum and all that, limitations we don't have in poem. So these are the in fact benefit of poem over the Hellers cardiomyotomy.
Thank you, sir. We are all spellbound.
Yeah, thank you, ma'am.
Thank you, sir. Now we'll be shifting to OT2, Pressure by Dr. Joy.
It's repeat.
A small announcement. Lunch is being served near the registration.
Patient 71 years old female came with complaints of burning type of pain in the epigastric region, aggravating post meal since last 1 year, vomitings post meals. All blood investigations were within normal limits. CCT abdominal done, suggestive of enhancing polypoidal intraluminal growth of 30 by 20 mm in pyloric canal of the stomach, extending to the large part of the duodenum. Ogidoscopy was done, suggestive of gastric polypoidal lesion. Histopath reports suggestive of hyperplastic polyp. This is the previous ogidoscopy report showing the polypoidal growth just in front of the pyloric opening. Plan for snare polypectomy. So over to Dr. Joy, sir.
Hi, good afternoon.
Yes, good afternoon.
The esophagus looks normal.
Yes, yes.
Yeah. Hmm. Where is the polyp? Oh, it's in the duodenum. Huh? It's not a pyloric one, it's a duodenal one.
Duodenal polyp and wide based.
Yes, yes, yes.
It will require submucosal resection.
Yeah, I think so. I'm just having a look at the base.
Yes, yes, it is broad based.
डॉक्टर मंदार को एक मिनट बुला लेना ना. डॉक्टर मंदार को एक मिनट बुला लेना. हाय डॉक्टर मंदार, ये डियोडिनम में है. हाँ ठीक है ना. So we have a stock here. So that's the reason I called Dr. Mandar for a opinion.
Yes, yes.
What this is the stock.
But it is very broad. Will it be removable with snare?
Snare करना है कि?
So it will be better if you have something like a loop. You can apply a loop first and then apply a snare. But the stock is really wide. Or
yes,
we can do something like ESD.
आपको आना पड़ेगा.
हाँ. So what I'll plan, we can inject along the base.
Yes, yes.
So
Yes.
that we get some more cushioning.
Yes, yes.
Adrenaline inject करना
नहीं 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 NS with methylene.
NS with methylene हाँ इन्होंने तैयार रखा है adrenaline नहीं करना.
Hello, Dr. Joy.
Yes.
Dr. Makaran here. Can you see the distal edge of the base? Because it is better to inject at the distal end first. Once you inject.
No, sir, it is not a. This is a proper polyp. We can see the stalk.
Yes, yes, but
so
it is always better to inject at the distal
yes,
part.
yes, definitely, definitely. So he'll be able to pass the scope by the side of the.
Yes, yes, yes. That's what I am saying.
इधर इंजेक्ट करना है.
See if you are able to go beyond the polyp from this side. Yeah. I think he has nicely gone beyond the polyp.
Yes.
So he can inject along the base of the polyp.
Yes.
Elevate that polyp, create some more cushion for ourselves, and then apply a snare. So nice. I wanted that to happen. Yeah, it has now popped up back into the stomach. So
yes,
it is
yes,
actually
yes.
originating in the stomach, not in the duodenum.
Yeah, yes, yes.
So what you do, you inject along this base.
Yes. Life has become comfortable.
Yes. Yeah, yeah. Actually, I was expecting that to happen.
Yes. Yes.
Now don't go in the duodenum. Otherwise, the polyp will go back into the duodenum. Be there.
Okay.
Yeah, be there. Go
Chalo,
on the top
snare.
of the polyp and inject.
स्कोप पकड़ लेना.
I think it is better to inject transduodenally.
Sorry?
It is better or comfortable to inject transduodenally rather than from stomach.
Yes, we'll see. Once he injects, I think it will come more on the stomach side.
Yes, yes.
So as sir had suggested, you should go on the distal part of the stalk and inject it there.
Yes, yes.
There
yes.
first.
Yes, yes. That is the stock. That is the point. Correct, correct. Wonderful. Yes.
So now we are giving buscopan to the patient.
Yes.
So his peristalsis will go down. So life will become more easy.
इधर इंजेक्ट कर.
Yeah, that is the correct point.
नीडल आउट करो. बराबर डॉक्टर मंदा. Wait, inject.
Pull back the scope. See where you are injecting. I think I've gone beyond. Yeah, it went out. Come.
Needle out. Yeah? No, yeah, do it. That's fine. Come on.
Yes, that's the correct. Can you keep the scope distant from the base of the polyp and then try to inject?
Yeah, we are trying to do that, sir.
Yes, yes.
No, you continue. It's difficult, I could understand. Oh. Excellent.
Wonderful demonstration. Hello. Hello.
Yes.
Manda.
No, it was a. Oh, sorry, Acha, you are there.
Yes.
Yeah, it was a
Hello?
difficult one.
Yes.
The problem is I don't have a mic.
Okay. And now you can speak.
Yeah. So probably I have removed the entire polyp. I'll just go back inside confirm that, and also I have to see the base, whether it is bleeding, whether I have created perforation. Everything I have to check.
कहाँ गया? लेने गया क्या?
हाँ, सामने है.
पानी लेने गया क्या? सिरिंज दूसरा वाला चाहिए होगा.
So we could see some bleeding in that portion.
Yes.
So we are getting other instrument ready. So till then I have gone beyond the bleeding point, and I am just keeping the scope there, so that will have some tamponade effect, and that will help in controlling the blood. Let's see.
What is your plan to stop this bleeding?
Sir, first I will have to see the bleeding point. If it is a small bleeding point, then I will apply clip.
Yes.
Hemoclip. See, normally at such polyps, I would have gone with a loop first.
Yes.
I would have applied loop.
ये निकालना ना.
Yeah. Hello?
Yes.
So now I have a mic with me, so I can speak. So now we are trying to control the bleeding.
Yes.
So here, this portion we had injected the methylene blue. That's why you see this pigmentation.
Yes.
But the base is proximal to this. Maar, pani maar. Ithe.
Yes.
Here somewhere is the point of
Bleeding, yes.
Mar.
Can you increase the airflow to keep the stomach distended?
Hey, sir, we are in the duodenum.
Okay.
The bleeding is in the duodenum.
Okay.
Stock was coming from the duodenum. The polyp was prolapsing in the stomach, but the stock is in the duodenum.
Yes.
Mala cap पाहिजे रे. ESD cap. ESD cap. बीपी थोड़ा कम कर सकता है?
I think the flow has decreased.
Hello? Yes, sir.
I think flow has decreased.
Oh.
You can wait, I think.
We'll wait for some time.
Yes.
मला गार पाणी पाहिजे रे, ice cold. But we have to apply some clip or something.
No doubt.
We cannot leave it like that.
No.
Pani. So I am trying to
remove
get ice cold water or ice cold normal saline. So that generally helps. It will give temporary vasoconstriction, and bleeding will temporarily stop, and at least we should be able, we'll be able to see the bleeding point.
Yes.
Pani mar. and I am also trying to get a cap, ESD cap.
Okay.
So I'll apply that over the scope so that the vision will improve. I think bleeding is definitely reduced.
Yes.
Yeah.
It has decreased.
मला हे पाहिजे आणले का कॅप ESD कॅप हां हां हो मॅडम जरा BP 100 पर्यंत करता येईल का BP आय वॉन्ट द BP डाऊन टू 100. I am taking out the scope and I'll apply the ESD cap over the scope.
Okay.
So the vision becomes better.
Yes.
That cap gives some distance between your earpiece and the mucosa.
Yes.
So the vision becomes definitely better. So nowadays for almost all the therapeutic procedures we use this cap.
Okay.
Thumb. Okay. गार पाणी आणलं का हां हो
Bleeding much reduced, huh?
Yes. हाँ एक मिनट हाँ So this is all raw area. Pani. This is the bleeder. Oh. Oh.
It is obstructing the field.
बंद करून टाका 2 मिनिट गार खरंच आहे ना ते एकदम हो या so now see with the help of this cap and ice cold water
yes
you can at least start seeing something.
Yes, area.
So this is a real time scenario. These things can happen in your private practice.
Yes, definitely.
I think
bleeding has stopped.
Yes.
अजून
गार पाणी मारा बंद करून टाका छोड़ो I think I'll just wait for some time.
Yes. That will be better policy.
Because by over-zealously doing something
yes,
that will
again it
cause
will
more
go on
harm.
bleeding.
इथं आहे ब्लीडर असं वाटतं. नाही पाणी मारा परत गार.
Small bleeding is there.
गार.
Wait for 5 minutes.
बंद करून टाका. दिसू दे एकदा. So this was the stock.
Yes.
I have just injected ice cold water. I am just trying to be there. So this is all raw area.
Is there a heat probe available?
I have to check. Otherwise we can use coagrasper also.
Yes.
But I'll see. If it is necessary, then only I'll go for anything. So we have reduced the BP also. It's around 100, 110.
Yes.
So that has also helped. एक मिनट हाँ क्लॉट है धगल तो हाथ में जरा. No sir. Yes sir. That is my plan. Yes sir. मार पाणी आहे सर. ब्लिडिंग आहे. हा क्लॉट आहे म्हणा वरचा आलेला.
Hello.
Yes sir.
हाँ, it is significantly reduced.
Yes sir.
Yes.
हा क्लॉट आहे वरचा.
हाँ, क्लॉट आहे. Active दिसत नाही कुठं.
I just suck out that clot.
So keep the clot in the stomach and you can go and see the raw area. Yes.
It's controlled now.
Yes, nicely controlled.
I think I don't do anything.
Yes. Check scopy after 2 or 3 hours, and that will be sufficient.
We'll keep check on his hemodynamic status.
Yes. You can apply heat probe if it is there just once or twice.
Yes. See, because applying clip over here will be very difficult.
No. Heat probe will be the
heat probe will be ideal. Yes.
Best method.
In 1 or 2 cases, we had to use the Hemosil powder also.
Yes, powder is also nice.
But I think इथे काही गरज नाही वाटत आहे.
नाही छानच आहे.
I think we can get away by doing nothing.
Yes.
काय वाटतं अद्वय? What do you think? I think let's not do anything now.
How much is the blood pressure at present?
110/70.
Okay.
It is not too low also.
What you can do is you can inject the adrenaline on this fold, which is going into inside the duodenum, na?
But it will cause rebound bleeding after.
But right now
there is no need, I think.
I think the bleeding has stopped.
Yes.
I won't do anything.
You just deflate the stomach and check after 5 minutes.
Yeah.
I think if there is no bleeding, there is nothing to be worried.
So till then, you can shift to the other OT. I'll wait for some time.
Yes. After 5 minutes, we can do check scopy.
Achha. Okay. Now, anyways, we are going to take a lunch break.
Yes.
So you guys go and enjoy the lunch. I'll wait here. Okay. Thank you.
Thank you, Mantar. There will be half-hour lunch break after this, and we will join after half hour. Thank you.
तो सगळा एरिया रॉ आहे तर कुठनं ते ब्लिडिंग होत आलं. करू.
Thank you so much for our chairpersons Makri, Patki sir, Parmar sir. Thank you.
नाही परत आपण टाकू नको आजच टाकू. बीपी काही एवढं पण कमी नाही आहे.
Hello.
Thank you so much
to our chairpersons Patki sir.
We'll break for lunch now, and the second session will start at 2:30 p.m.
थोडं पाणी मारता हळू मारा. आता फोर्स कमी ठेवायचा. आता बस. आता मला नाही वाटत काय करावं. नको का
Hello, hello. We'll be starting with the second session very soon.
मारुति ठीक आहे आधी हे चालू करायचे का
Welcome back. We are starting with the second session of endoscopic procedures. Uh, 48 years old male complained of pain in abdomen since 2 years. A patient came with septic shock with obstructive jaundice with cholangitis with multiple organ failure. Secondary to large CBD stone. Emergency CBD decompression with ERC stenting done. At present, the latest labs, bilirubin within normal limits, USG abdominal size of 13 mm calculate proximal CBD, size of choledocholithiasis with GB sludge and CBD stent incentive. ERCP size of large stone greater than 1.5 centimeter in CBD and CBD stenting done. The MRCP size of choledocholithiasis causing proximal biliary tree dilatation. Calculus of 11 by 10 mm in mid CBD. CBD diameter 15 mm with moderate central IHBI dilatation and displaced CBD stent. Now patient is planned for hydraulic lithotripsy or mechanical lithotripsy with colonoscopy. Over to Mandare, sir.
Hello. So welcome back. I hope you all had a nice lunch and ready for this post-lunch session. So you have heard this is an interesting case of choledocholithiasis with a large stone. The sonography and MR is showing about 13 mm stone. So we'll see, depending on the cholangiogram picture, we'll decide what to do for this stone. Whether to go for mechanical lithotripsy or SPY, that will decide depending on the size of the stone. So like always, I have gone across the stomach. I suck out all the secretions from the stomach. So this is the pylorus and this is called setting sun sign, and I'll go into the D1. From D1 I'll try to go in the second part of duodenum, and now I'll shorten the scope. Okay. So now I have reached the ampulla, second part of duodenum. Shoot kara. So Advay, this position looks better, no? Yeah. So for cannulation, the ampulla should be in this quadrant, like upper right quadrant of the screen. So now, I think this patient also has undergone ERCP. Acha, okay. Stenting. So now my job has become easy. So I'll just go. See, this is somewhere will be the pancreatic duct opening. Can you appreciate Advay? Yeah. And this is the CBD opening. So because of previous papillotomy, it has gone way up. Now I'll ask my assistant to pass a guide wire. Yeah. Can you see the air cholangiogram? Yeah. Are you getting the fluoro picture there in the audience?
Yes. Mandar, yes.
Okay, now he is injecting the contrast. So as he is injecting the contrast, I'll slowly bring my cannula down. I will try to localize the stone. Yeah, it's a big stone.
Almost about the size of the scope.
Yeah.
What do you say about the lower end of the CBD?
So lower end is definitely narrow. So my plan is to go for sphincteroplasty first. I'll dilate this opening. So they have already done enough sphincterotomy. So there is exchange karo wire. So there is no point in extending the papillotomy any further. So I'll dilate this opening by using a CRE balloon. So the CRE balloon is passed over a guide wire. So I am exchanging this Terimo guide wire for a more stiffer guide wire. So here also we are using same VisiGlide by Olympus.
Sir, what
Shoot. Yeah. So I'll So looking at the cholangiogram, the stone size is somewhere between 13 to 15 mm.
Yeah.
And the shape is also not very good.
Oval shape it is. But it is good that it is not a square stone.
Square stone, yeah. So you should see the hand movements of my assistant. He's so fast. It's really good. Pleasure working with a good technician. Wire.
So now Mandar is going to cannulate the ampulla directly with the balloon.
Yeah, unfortunately the wire came out. It doesn't matter. The ampulla is very wide. Taka wire. Okay. So the way we dilate esophageal stricture, same principle we use here also. The entire balloon should be out of the scope and inflate. Now 2/3 of the diameter should be inside the CBD and 1/3 should be out. And you have to keep a tension on the balloon because as he starts dilating, the balloon can get pulled inside. Putla balloon? No, no? Okay. Yeah.
Up to how much are you planning to dilate, Mandar?
15.
Okay.
So this CRE balloon has a inflating device. 2.5. अजून कर वेळ. So that gives us pressure and काहीच झालं नाही अजून करायला. काहीच नाही झालं.
So this is a 12-15 mm CRE balloon. We have dilated up to 15, I think. So.
Yeah.
So Mandar, are you comfortable till 15 or you can go above 15 also?
I think in this case we have to go above 15. Let's see. So once you inflate, you keep the balloon inflated for a period of 1 minute. So it achieves two things. Firstly, it makes sure that enough dilatation is achieved. And see, after this sphincteroplasty, you expect some bleeding to happen. So that bleeding will also be controlled to some extent if you keep the balloon inflated for some time. And even while decompressing, you should decompress it in steps.
So what are the probable complications of this balloon sphincteroplasty?
So the most common problem is bleeding, post-sphincterotomy bleeding. Sometimes it can also cause perforation. Yeah. Overzealous dilatation can cause perforation. There have been some incidences where the patient has developed pancreatitis after balloon sphincteroplasty. But nowadays we do sphincteroplasty only after doing part sphincterotomy. So when the balloon is dilating, the direction of the dilatation will be towards CBD. That's how we can prevent or reduce at least the chances of pancreatitis. But in spite of taking all the precautions, these complications can happen in odd patients.
Sir, one question from my side.
Yeah.
What are the absolute indications for this colonoscopic lithotripsy and absolute contraindications?
What are the indications? So, see, when the stone size is bigger, like this patient has, we have already done enough sphincterotomy. So extending this sphincterotomy beyond this point will not be possible. Then there are high chances of perforation are there. So that can be prevented by doing this balloon sphincteroplasty. So balloon sphincteroplasty will dilate this opening and we can achieve dilatation up to 15 to 18 mm also sometimes. Kadu?
I think
we have
indication is cholangitis.
Cholangitis, yes. And if the patient has any bleeding dyscrasias or if you see there is no bleeding, at all.
Yes,
So I
yes.
think we haven't achieved anything by dilating this. So we have to go for further dilatation.
So maximum size I think is 18 millimeters, 15 to 18. CRE balloon.
15 to 18 we get. So what do you think, Advai? Should we dilate more?
We should dilate a bit more.
Yeah.
And I was going to ask you whether you going to use after dilatation directly a balloon or you are going to go with a basket.
First I'll try a balloon.
But don't you think that by pulling with the balloon, it might get impacted in the lower end and then the basket might not go up, or it will cause a difficulty?
And we can disimpact that, no? We can if that happens, we can push the stone back in the proximal part of the CBD. But see, the chances are there that basket can get blocked. Like the balloon can get
To disentangle the basket is a difficult task.
Sorry?
To disentangle the stone from basket.
Sometimes that becomes very difficult.
Yes.
But here we are going to use a lithotripsy basket only.
Yes.
From Olympus. So if that happens, then we are in a position to crush that stone.
Okay.
But before that, I think I should try with
balloon.
Stone extractor balloon. Sometimes this balloon sphinctoplasty can also cause this problem. Particularly the stones which are lying in the distal part of the CBD, those stones, they get compressed.
I would like to request Dr. Amravani Medith ma'am from Oman and Dr. Gaikwad sir from B to chair the session.
Yeah, correct. So now the balloon is getting inflated. Hopefully we should achieve more dilatation with this.
This is a 15 to 18 balloon.
Yeah. Okay. Bas. Yeah.
I think 16 and a half suffice.
Yeah. थोड़ा कर.
प्रेशर किती आहे? प्रेशर 4 नाही बस झालं. किती आहे? 4.5 पर्यंत कर.
थोड़ा कर. See, we can see this white ring. So that white ring is the place where the dilatation is actually happening.
Yes.
So through the balloon you can keep a watch on that.
Yes, this is the beauty of this CRE balloon. It is transparent.
Yes. If you think the overinflation is happening, then immediately you can ask your assistant to reduce the air.
Yes.
By this you can try to prevent perforation.
Yes. What is the pressure given?
So now this is showing pressure of 4. So 4.5. So at that pressure the balloon diameter will be about 16 mm. 16.5, sorry.
Okay. And this gun is manufactured by which company?
This balloon is manufactured by Boston Scientific, and this inflation device is of Wilson Cook.
Okay.
So this is by Boston Scientific.
Yes.
So these accessories, CRE and other accessories are, Boston has a very good range of those accessories.
Yes.
Even the sphinctrodome of Boston is good. So either you can use sphinctrodome by Boston Scientific or by Olympus.
Yes.
Both are equally good.
Is it reusable balloon?
Yes, sir. So technically they are single-use accessories.
Yes.
But not only in our country, everywhere they reuse the accessories. For other, it would be impossible to afford a ERCP procedure because each accessory costs somewhere around 20,000.
Yes.
So if you use reusable, disposable accessories for every patient, single procedure will cost more than 1 lakh rupees.
Yes.
Kadle? Kadu? balloon. So I'll first try with the balloon. I think I'll go with basket. See, I think even after using this balloon, we haven't achieved
therefore I was going
sufficient
to tell you
dilatation.
to
So
go with
I
the
think I'll
mechanical
go for
basket.
mechanical lithotripsy directly, rather than wasting time in trying to extract with the balloon. The stone is pretty big. So we have to do mechanical, we have to crush the stone. Unless we break the stone, it will be impossible to take that stone out.
Is there any demonstration of laser lithotripsy with spyglass?
So there is one more case of spyglass. So Dr. Praveen sir probably will show that.
Okay.
So this case we have kept for mechanical lithotripsy.
Okay.
So this is a specially, can you focus it on camera on the, so this is specially designed lithotripsy basket. So this has got an plastic sheath through which the wires will come out, and this is a metal sheath. So once we catch the stone in this wires, slowly this sheath is advanced, and this sheath will actually bring about the lithotripsy of the stone. So I'll go, it has got three components. This is the wire, on that top of that is a plastic sheath, and outside is the metal sheath.
Yes. So what is the length of the instrument?
The length is about 1.5 meters. It has to go through the scope. No?
Okay. And channel width is, I think, larger.
So these therapeutic scopes, they have about 3.7 mm, 3.8 mm diameter of working channel.
So this will not pass through colonoscope?
No, it will, but the length is shorter.
Shorter, yes. Recently I had opportunity to extract the stone from ileocecal junction in a 92 years old male who has developed colocystoduodenal fistula, and the stone was 3.5 centimeter.
Metal sheet मांगे क्या?
Hello,
yes sir.
Recently I had an opportunity to remove the stone from ileocecal junction, wall stone, which was impacted there.
So sir, now the plastic sheet is going inside.
Yes.
And I'll try to pass this plastic sheet, and I will try to catch the stone. Open. Okay.
Yes.
Can you see the prongs open nicely?
Yes.
So the stone was somewhere here. आला करा बंद करा हळू आला I think I have caught the stone. Okay.
Yes.
हाँ बस पकड़ूं जरा. First I'll try to take it out like that. थांबा ना. Slip. जमतोय का बघू. नहीं है क्या? It is not coming without. So I'll go in, and now I ask him to advance the metal sheath.
So how it works?
So can you see this metal sheath advancing?
Yes.
So it will advance and go near the stone. खाली push. So now he is advancing and okay.
I think the stone has slipped.
Slipped, yeah. काढा परत plastic sheet बाहेर काढा.
Is it for only soft stones?
नहीं.
Heart stones can be
Heart stone
done.
can also be used.
Okay.
But probably now the stone was slipped out.
Yes.
Didn't got.
Andar,
थोड़ा open
what I
and
would think,
contrast
we can put some contrast.
थोड़ा सा. So now I'll check by injecting some contrast inside. थोड़ा open करा. हाँ. Yeah. हाँ, okay, okay. Stone is still there. Open, basket open. I think that stone was not caught properly. That's why it slipped out. थोड़ा उघड बंद करा. थोडं बंद करायचा प्रयत्न करा बास्केट. उघडा परत, उघडा पूर्ण उघडा.
Put in some more contrast.
Contrast. हाँ.
खाली है stone.
We have partially crushed the stone, I think.
Yes.
But all the 4 wires should be seen around the stone.
2 wires are getting stuck to each other, I suppose.
एकदा बंद करा परत बघू.
Slip.
Open. हाँ. Open. थोडं बंद करायचं. थोडं बंद करा बास्केट. शूट. कॉन्ट्रास्ट. हाँ बस जास्ती नको.
Yes.
This one wire should go on that side of the stone. Then only I'll be able to catch the stone completely.
Now it is, I think, better caught.
हाँ. आता असा फण्यासारखाच आहे. नाही हा 2 वायर आहे. पूर्ण ओपन आहे ना. हो.
Mandar, can you ask the focus on assistant's hand, what he is doing?
Yeah, in fact, he is not doing anything. He can't do much.
No, he is holding the stone, I think.
Yeah. आता जरा बारीक करून बघा. हां. ओपन. चला बंद करा बास्केट. पूर्ण बंद करा. पूर्ण करा पूर्ण बंद केले. नाही बंद. शूट. तर इकडनं जायचा प्रयत्न करतोय मी. हां हां हां, पकडा स्कोप, पकडा, होल्ड द स्कोप. हां, ओपन ओपन ओपन. हां करा, सोडा स्कोप सोडा. आता बरं आहे, आता बरं आहे. हां आता बरी वाटते ना, बघा बंद करून. या आला. I think now probably we have caught it fully. Yeah.
Can you think of directly pulling the stone?
Yeah, I'll try.
It has crushed.
नहीं,
I think.
अर्धवट है. हाँ,
हाँ,
ओपन 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 जरा थोड़ा, हाँ थोड़ा. करा बंद परत. अर्धवट आहे. हां ठीक आहे. आता मेटल घाला पुढे. नाही नाही, ओपन 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 ओपन. आय एम स्टिल नॉट एबल टू कॅच द स्टोन फुल्ली. हां आता गेलं का. हां हां आता ॲडव्हान्स.
Gradually advance the metal sheet.
आम्ही आत जातो जरा. या हळू हळू. शॅ सुटला, स्लिप्ड. शूट शूट शूट. नाही बंद 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 बंद. शूट शूट खाली घ्या का रे. कॉन्ट्रास्ट टाक, कॉन्ट्रास्ट. हां दोन तुकडे झालेत. शूट. या लॅटरलच करा बाहेर. शूट. बंद करा. काय होतं हो. ठीक आहे, राहू द्या असंच. हा बलून द्या आता.
Are you trying balloon now?
Yes, I'll try because I could see the stone was fragmented. I could see two fragments. So I'll try to take out the distal fragment. नहीं नहीं, balloon दे ना. त्यातनं बाहेर टाकू. शूट 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 फ्लुरो हां आता या या आता ना इन्फ्लेट करू पहिलं हो आणि कॉन्ट्रास्ट टाकू now I'll first do check cholangiogram to see exactly where the stone is and is it really fragmented or not. Huh. Possible. किती आहे बलून नाही नाही दोनच का
Sir, the CM you are using is uniplanar or biplanar?
लॅटरल करो ना पेशंट को पूरा मेक हिम कंप्लीटली लॅटरल हाँ हाथ काढून घ्या हाताखाली हात काढून घ्या अंगाखालचा ना हात परफेक्ट
सर एबीपीचा निघाला
अजून काढा डिफ्लेक्ट करा अजून थोडं केलं दीड करा दीड हां पूर्ण नाही हो थोडं कमी थांबा डिफ्लेक्ट 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 शूट शूट करा वरती दाखवा थोडं हां आता इन्फ्लेट नाही 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 आता इन्फ्लेट फुगवा हो केलं लवकर करा हो शूट so the stone is definitely fragmented. I could see 2 fragments.
Yes.
I'm trying to take out the distal one. Deflate. Shoot. Inflate. सारखं गावात नका घेऊ ना ते तिथेच ठेवून द्या but even this fragment is not coming out. Deflect kar. Deflect kar. Kela? I'll again try with the lithotripsy basket. The balloon is not able to take out even the distal fragment.
Yes.
The balloon is broken into 2 pieces, but even the lower piece is still big. We will have to do lithotripsy. I'll try once with mechanical, otherwise we'll have to go for SPY.
What is the size of this lower stone? Can you compare with the width of the ERCP scope?
So it is so it is not looking very big actually.
Ah.
So that's why I am hoping that that stone should come out. After fragmentation, the diameter has definitely gone down.
Yes, yes.
करा ओपन केला खालचा तरी पकडायचा प्रयत्न करू आता. So this fluoroscopy is a two-dimensional image. हाँ आता बंद करा हळूहळू. बंद करा हळूहळू. नहीं ओपन करा लगेच. So when you see all the 4 wires, that means
yes,
you haven't gone completely across the stone. हो आम्हाला वेळ लागणार. शूट करा की नाही देते हो.
Yes, I think.
Hello. Parallelly, we'll be shifting to OT number 3, in which we have a case of migrated CBD stent.
A 35-year-old female operated for laparoscopic CVD exploration for choledocholithiasis on 4th August 2023 with CVD stent in situ. She has no fresh complaints at present. All her blood investigations are within the normal limits. MRCP findings post-cholecystectomy status. Her CVD measures 12.6 mm. CHD measures 11.5 mm. There is distal CVD stricture with CVD stent in situ. Plan is ERCP with CVD stent removal and CVD clearance, SOS stent reinsertion. Over to you, Dr. Advai sir.
Hello, good afternoon. Am I audible?
Yes. Advai,
so, as we heard, the case plan was quite simple. Which was told to me is to put in a duodenoscope, remove the previous stent, get a cholangiogram and come out, and if required, restenting. So when I put in due to lack of time, what I have done is I have put in the duodenoscope already, and what we can see is the stent has been migrated upstairs into the upwards into the common bile duct. Can you get the fluoro image?
Yes.
Huh?
Yes.
So what I have done already is I have negotiated a guide wire across parallel to this stent, and my ultratome is also my sphincterotome is also near at the top of the stent. So what we will do is we will try to remove this stent. It is one of the most difficult cases. At times may require spyglass also, but we will try to remove this stent. Exchange.
What is the type of this stent?
Pardon?
What is the type of this stent?
Sir, it is a straight plastic stent.
Yes.
Maybe the Teflon stent which we were discussing during our lunch.
Yes.
Fluoro. So gradually, while maintaining the wire, I am being assisted by Archana. She is quite well trained into this. So now I will be inserting using a stone extraction balloon, and by the side of the stent I would inflate the balloon and try to pull the stent below. Sometimes we need to use a rat tooth forceps by Olympus to get hold of this kind of a stents and remove them. Balloon gaya. So by the time she is getting the balloon ready, we will try to stabilize our scope. Fluoro. एक मिनट नुसते वायर उडू नका शूट 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 हां ठीक ग्रॅज्युअली टेन्शन ठेवा so what I have asked her to just keep a tension on the guide wire so that my balloon slides over it.
We are not getting the fluoro image, sir.
There should be synchronized movements between my pushing and her pulling so that the wire remains in place. Intermittently fluoro. So therefore in ERCP you should have a well-trained assistance. Otherwise your life becomes, see there was a small stone also which has already come out. So gradually I am trying to negotiate my balloon above at least 2/3 of the stent, and now what I will do is ask her to inflate the balloon. हुआ 3 पर्यंत 3 हाँ. So now what I have done is I have inflated the balloon and now I am trying to pull it out, but it is just coming by the side of the stent.
Bus ko pen lage. Fluoro picture.
Yeah, it has.
Yes.
It is gradually coming out. बस को पेन प्लीज. पेशेंट लाइट है क्या? Gently fluoro. So you can see that the stent has also come down, but not yet completely, but there are stones below the stent.
Yes.
Deflate. So again, fluoro please. Again we will have to go above 3.5 पर्यंत फुगवा. बलून फुगवा 3.5 पर्यंत. Fluoro. See the stent is coming out.
Yes.
Shoot. It is slipping inside again.
So we'll be shifting to OT1.
Hello, Advait.
Yes.
We'll be shifting to.
Just a minute, sir. See, I just wanted to show that we have removed the stent.
Yeah. Just okay.
So it has come out of the CBD. Okay.
Yes.
Yes. Can you really appreciate this stent?
Yes,
sir. Yes.
Okay. So now I will just remove it and do a cholangiogram again.
Yeah.
Okay. Exchange.
And will you put the stent again?
Meanwhile, we'll shift to OT1. Mandar has done his stone fragment removal and he is about to conclude the procedure. Over to Dr. Mandar.
Snare there.
Are you getting the endo picture? Hello? Yeah. Are you getting the endo picture?
Yes, sir.
So now I was able to crush those stones and I have removed both the fragments. I am just clearing now to see whether any residual fragment is there or not. See, can you see all the muck which is coming out?
Yes.
Yeah. Ban kar.
ओलंपस से कोई है क्या?
Probably I have cleared the CBD. I am
पूरा
still not
एयर निकल
100% sure.
उसकी वजह से सब पूरा नीचे मेस हो गया है.
हाँ पानी मारा जाता है जरा. हाँ. Now I'll
पूरा एयर निकल जा रहा है.
give some lavage and to
ओपन. थांबा.
drain all the fragments. See, all the fragments will now come out.
ओपन.
So while we were offline, I could take out both the fragments, large fragments, and along with that, lot of muck came out.
Close.
Yeah.
Shoot. बाहेर आला है तो.
अरे छोटा करा बास्केट थोड़ी बारीक कराइए. Yeah, basket contrast. Now I'll just do one check cholangiogram. I'll inject some more contrast. Can you see the fluoro image?
Balloon and tear.
Yes.
Probably I am able to take out all the stones. What do you think, sir?
Yes.
Open kara basket purna.
ये क्या बदलना रे काय?
Now the basket is fully open. I'll just close. Now finally I'll do one balloon swipe just to confirm that all the small fragments are also drained. Balloon द्या. मैं बाहेर टाका देत ना.
Will you put another
So-
stent or this sphincterotomy is good enough, sir?
Sorry?
Will you put another stent because there is a lot of
Perimalic?
Yeah, definitely. Definitely I'll be putting a stent. Irrespective of the sphincterotomy size, because there were so many small fragments, so we can never be 100% sure that everything has come out.
Yes.
Even if a small fragment stays inside and if the patient develops cholangitis, then that will be a really failure on our part.
Bend.
Inflate?
Bend.
Kela? So now I inflated the balloon and I'll just try to pull this down.
Ma'am, थोडंसं इकडे होता का?
I think I have cleared
श्याम
everything.
दिसत नाही.
Yes.
ओके.
आता contrast
वरती
टाका.
जाऊ दे वरती.
I'll just do one occlusion cholangiogram
गॉलब्लॅडर मध्ये गेली का? स्ट्रेट जाऊ
just to
दे
be
जरा.
doubly sure.
हां. नुसतं पुश नको करू. फिरून पुश कर.
So just beyond the scope is my balloon which I have inflated. And
Yes.
proximal the entire CBD looks quite clean. I think
ठीक है, हो गया.
I have cleared everything.
Yes.
Okay, so
Mandar, after completion of your procedure, can you demonstrate how the mechanical lithotripsy?
yes sir, I'll do that.
Yes.
Deflect kara. So
Contrast.
this tells us that endoscopy requires a lot of patience.
Yes.
You have to keep on doing the same
Shoot,
thing
shoot.
over and over again and again. Inflate.
Yes.
Kela?
Lower end.
Now everything has
Lower
come out.
ठीक है. बस. तर परत वरती जाऊ.
Here
आणि
the
मोठी
problem
वायर
was
टाकून
the
घ्या.
okay, now my balloon has also come out. So definitely everything is clear. Now I'll just take out this and I'll put a stent.
अगं वरती जाऊ दे ना मला. वायर काढू नको, थांब ना. मला वर जाऊ दे,
Seven.
मग वायर काढ ना.
Double pictal. Single 710. 7.5 पण झालं.
What is the regular size of the stent you are putting, the 7 French?
So generally when for benign we always prefer to put 7 French stent. And if it is a stricture, when I say benign, it's a stone disease I meant. For stone disease we generally always put 7 French stent only. For a stricture we can choose between 7 French or 10 French.
Does the
And
CBD size matters?
Not really. Stricture matter. If it is a benign stricture and if it is a resistant stricture, sometimes you have to we have to go on increasing the diameter of the stent. So initially if the stricture is really very tight, then we can put only say 7 French stent. Then in the second sitting we can increase from 7 French to 10 French. If the stricture still persists, then we can put one 10 French stent and along with that one 7 French stent. Like this we have to do case by case.
Is there any role of metallic stents nowadays?
Yes, for malignancy definitely. For permanent palliation we use metal stent. Even for benign strictures we use fully covered metal stents. Particularly if the stricture is in the lower part of the CBD, those stents really help to prevent the recurrence. And nowadays with the advent of liver transplant, you get complex strictures. The strictures are really high up in the proximal part of the duct. So there also we get specially designed stents with a long lasso. Those are metal stents. So yes, metal stents definitely have a role even in case of benign strictures. So now here we are putting a double pictal stent because we don't want the stent to migrate either outside or inside. Both ways migration is not acceptable in this case. That's why we have decided to put a double pictal stent. Particularly in such cases where we do wide papillotomy with balloon sphincteroplasty, the papillary size is really big, and so chances of inward migration of stent are high.
Dr. Mandar, we'll shift to Dr. Advai's theatre. He's about to
Yes,
finish.
sir. Yes, sir.
OT3. Dr. Advai, you are on.
So now see, we have removed the stent from the CBD, which was migrated into the mid CBD with the help of a stone extraction balloon. Okay. So now what we can see is on the cholangiogram that the CBD is still dilated and there are some fragments. So what I am going to do is do this CBD clearance, and because of all these interventions I am going to put in a double pictal stent for a short duration, so that the edema which is caused because of all these interventions, pulling and pushing of the scope and the instrumentation of the ampulla, there would be edema and the patient might land up into again spasmodic pains. What I wanted to tell is, even after laparoscopic CBD exploration, the stent which was put in was very short. So the distal end was not into the duodenum at all.
For this patient, what are the post-procedural medication you give? Anything like buscopan?
Pardon, madam, can you please?
Sir, after this procedure, because you are expecting spasms, do you give buscopan for this patient?
No, ma'am. This spasm means this would be the edema of the ampulla, and for that we will put in a 7 French double pictal stent. So even if there is edema, the stent will work, and maybe in 3 weeks we can just pull out the stent with a simple procedure. So now we are getting ready with the balloon. Yeah. हाँ आता शांत है, थोड़ा टाइट ठेवा सिस्टर. शूट. हाँ बस करा इन्फ्लेट इथे 2.5 हाँ 2.5 or 3 बस. Okay, now we are going to do some balloon sweeps to clear the distal CBD. Still there is some impacted stone here. I am feeling the resistance to the balloon. Deflate. See, there is some muck down here. The anatomy is a bit difficult, the scope position and the angle. Wire tight theva thodi. 2.5 करा. ठीक है, कर 2.5. Here there is some narrowing in the CBD because of the stent. Now see, the swipe is clear, so deflect. थांबा, पुश नका करू वायर, पुल ठेवा वायरवर. शूट करा, इन्फ्लेट येते. 2.5. Deflect, stent. So now I am going to put in a stent, and we will call it a day. 7 French double pigtail, 5 centimeter. नहीं, 7 centimeter. खूप मोठा होता तो 10 centimeter. हाँ ठीक है सर. So if you want, you can shift to some other theatre. Here I am just going to put in a stent if some other theatre is ready. Otherwise I am ready for any questions to be answered.
Sir, very well done, sir. Thank you very much for the procedure. I think patience is the key for this.
Pardon?
Patience is the key.
Yeah. You have to be very gentle and do the movements. Fluoro, please. बस स्टेंट टाको.
नहीं है ना.
बघू मला मार्किंग आहे ना त्याच्यावरती. हां ठीक आहे, चल घ्या.
Shifting to OT2.
Huh?
Shifting to OT2, procedure by Dr. Mandar sir. 60 years old male came with complaints of pain in abdomen and epigastric region since 3 months. Dyspepsia since 3 months. Plan is upper GI scopy.
We are done. We have next 5 minutes.
Hello.
Over to you, Mandar.
Yes, sir. So this patient has dysphagia, and the plan is to evaluate the cause of dysphagia. And if it is treatable endoscopically, then we will treat it.
Strength नहीं मिले तो.
Like if there is stricture, then we will show dilatation. So now I have gone in the oropharynx. I could see the vocal cord movements, and then I'll ask the patient to swallow. Gira, gira. As he is swallowing, I'll put the scope in the esophagus. I can see dilated esophagus with some residue. Normally, esophagus is just a conduit. So in a normal course, you are not supposed to see anything in the esophagus. If you find anything, then that is always pathological. Whether you find saliva, food, blood. So there is a lot of froth in the esophagus. The esophageal lumen also looks dilated. Dilated esophagus with thickened mucosa. So are we looking at a case of achalasia? So we are at the G junction. No. So there is no classical achalasia. The scope could be passed easily without much resistance. So can you see, sir, the Z line is seen nicely?
Yes.
And my scope is also going without much resistance. So probably not a case of achalasia. Now I have gone into the stomach. Stomach mucosa definitely looks inflamed. I want the pylorus. Nako. Now the pylorus is seen clearly. Now you see the peristaltic activity. So the surgeons who are starting with their endoscopy learning, though it is a good idea to give injection buscopan before you start the procedure, so that the smooth muscles are relaxed. The pylorus will not show this peristaltic activity, and you will find open pylorus. So going across the pylorus in the duodenum becomes easy. Okay, now I am in the D1. From D1 we go in D2. So there is no obvious mechanical obstruction in this case. But looking at the dilated esophagus, I feel there could be some other motility disorder. We have to do timed barium swallow and manometry in this patient. Let's see. In fact, the hiatus looks more lax.
Yes.
I'm going to take do rapid urine test for this patient. Biopsy bhai. So this gastric mucosa definitely looks inflamed. So nowadays, as per the latest guidelines, even if your patient doesn't have symptoms of dyspepsia or hyperacidity, and on endoscopy, if you find some inflammation in the stomach or in the antrum, you should take biopsies. And if you find positive rapid urease test, then you should treat that patient. You should do H. pylori eradication.
Yeah.
Even if the patient doesn't have symptoms of dyspepsia. Those are the latest guidelines.
For how many days it should be given?
2 weeks, sir. 14 days.
And maintenance?
No, maintenance that way is not required.
Okay.
RUT.
What type of combination is preferred for H. pylori eradication?
So nowadays you get a lot of ready-made combinations.
Yes.
So
clarithromycin or that amoxicillin?
Clarithromycin, amoxicillin with pantoprazole.
Yes.
Pantoprazole, esomeprazole. And nowadays for resistant cases of H. pylori, they have suggested to give double dose.
Okay.
But not generally I don't prefer, because see, at that high dose of antibiotics, patients complain of a lot of nausea. Some people get loose motions.
Yes.
So generally I don't prefer to give double dose of H. pylori. And I have found that in India people don't get those resistant H. pylori infections. Yeah.
Yes.
So I don't know. So the esophagus is definitely dilated.
Yeah. Lot of froth is there.
Yeah. And
This
even the
is motility
mucosal
disorder.
Yes, sir, definitely.
Manometry will explain.
Manometry, and we also do time barium swallow.
Yes. Okay.
See, the definite dilatation is there. Okay, I am through. I am just taking out the scope. You can shift to the next OT, sir. Any questions? Can you appreciate the change in the pattern of this aridinoid cartilages?
Yes. Can you put on NBI?
I can.
I think this is pigmentation of melanin.
Yeah.
Early melanin pigmentation.
Sometimes even the people who are chronic tobacco users, you find this pigmentation.
Early melanosis.
Yeah. But the cord movements are normal. Okay. Chalo, thank you.
Yes.
Thank you, sir. Thank you, sir. Now we'll be shifting to OT1. Case will be performed by, procedure will be performed by Dr. Praveen Survanji, sir. 35 years old female
dilated
patient came with septic shock with obstructive jaundice,
lot of
cholangitis with
salivary residue.
multiple organ failure, secondary to large CBD stone, emergency
No tertiary
CBD
peristalsis.
decompression with
No tertiary
ERC
peristalsis.
stenting done.
Hiatus was
No fresh complaints
normal.
are present.
No resistance to the
LFT
passage
is
of
within
scope.
normal limits. USG abdo-pelvis size
No
of 33 mm
resistance to
calculi
the
at
passage
CBD
of scope.
and
Otherwise,
cystic duct
manometry.
junction. Size of cholecystectomy with GB sludge, CBD stent incentive. MRCP size of filling defect of 27 mm in proximal CBD. CBD diameter is 7.7 mm and CBD stent noted incentive. Central and peripheral IHBR dilatation with GB subs present. ERCP size of very large stone 30 mm in mid CBD with dilated IHBR size of cholecystectomy. This is the previous ERCP video in which we can see the removal of the previous stent and impacted stone. Guide wire was again passed and CBD stenting was done. Plan is for ERCP with electrohydraulic lithotripsy with colonoscopy. Over to Dr. Suryavanshi sir.
Hello.
Yes, Praveen.
Yes. So again, another interesting case. This female, she presented to us almost 1.5 months before with severe septic shock and with multiple organ failure. Second to the impacted stone at the mid CBD and the severe cholangitis. And her even PT INR was deranged. INR was 2.1. And so in emergency, we just did ERC and the biliary stenting just to decompress the biliary tree and the control sepsis. So now everything is settled down, and now she is planned for the definitive management in the form of stone clearance by the advanced stone management system like that EHL. So as mentioned in the presentation, and also that video was shared with you all about the previous ERCP. There is a huge stone about 3 centimeter size. Okay, so this is the really difficult stone. So option is that like impacted stone, if a large stone, if your stone is not impacted, then you can pass the basket beyond the stone, catch the stone and break it, fragment it and take it out. Or second, if the stone is very tightly impacted and no instrument can pass beyond the stone, then we need to break this stone before you really catch them for the extraction. So for that, this EHL is very good device. So with the colonoscope, we have again 2 options. Either use laser lithotripsy, that is holmium laser you can use for the breaking the stone, or you can use this electrohydraulic lithotripsy. Okay. So these are the situation where scope position is not very stable with so now I will shorten the scope. ಅದು ಹೇಗೆ ಸ್ಪಿನ್ ಟು ಡೌನ್ಗೆ ಟಿಕೆಟ್ लाव सर. So I will explain this device in some time. Initially we will have cholangiogram. So every time whenever you are doing intervention, you must study the biliary anatomy and everything again. Just based on previous finding, we should not take any decision. Inject. Good. Inject. Inject. Got it. Okay. Inject. खाली देखो स्क्रीन नीचे Can you appreciate stone size here? Hello? Screen. Inject.
Hello?
Yes. Yes, sir.
Yeah. Inject. See now, this is the stone here. A huge stone.
Yes.
And the distal CBD is smaller, sir.
Smaller,
I think there is a
that's right.
stricture.
That's right. We cannot say stricture, but definitely it is a distal most part of the common bile duct is normal in size. So it's very difficult to take out such size stone from this large size from the normal CBD. So these are the actual real indication for the laparoscopic CBD exploration, and the stone extraction. Open. So we'll do a little bit extended sphincterotomy here. ठीक है बस गया था फुटेल ना रे So in our routine practice, if the gallbladder is intact and such a large stone which cannot be taken out with simple extraction technique,
Yes.
we prefer to do laparoscopic CBD exploration with cholecystectomy.
Yes.
But just because now these everything is available for the demonstration purpose, so there is no extra cost. So we can try with this EHL.
Yes.
But otherwise, for the poor patient, really it is not very affordable option.
Yes. In laparoscopic CBD exploration, what are the methods to visualize the internal part of the CBD?
See that you can use any scope that you have in your armamentarium.
Yes.
You can use in a nephroscope, you can use a ureteroscope or your bronchoscope flexible you can use.
Yes.
Okay. Screen. Image. Screen.
What are the tricks to put the stent laparoscopically?
Stent.
Yes. After CBD exploration.
Again, see, since we have all guide wires here, we prefer to pass guide wire into the duodenum.
Yes.
So if you want to pass in the same way again, see, never one of the important thing more than trick, it is advice, is never put double pigtail catheter into the crown bile duct.
Yes.
Always put single pigtail and keep the pigtail inside the duodenum, not in the crown bile duct. Okay? And always make sure that the free end of the stent is in the IHBR, not in the crown bile duct.
Yes.
Sometimes this free end keep poking the suture line, and it makes the things worse, in fact.
Persistent leak will be there.
So now you can you see this colonoscopy image?
Yes, yes. Is there a separate channel for passing spyglass?
Yes. No, it's same. It is this spyglass is 3M, 3.50, and this working channel of the is this 4.2 ERCP. So through the same working channel you can pass this. And 1.7 mm it has got working channel for the spyglass, through which I am passing this probe.
Yes, yes. But I think it will take a lot of time for crushing the stone.
Yes, yes, yes.
Last year Dr. Subhash Khanna has demonstrated, and he has taken 2 hours, I think.
Okay.
In ENDOSURG.
Yes, that's right. That's why it's a very time consuming, huge cost. So as compared to that, CBD exploration is more cost effective.
Yes, yes.
Okay. That's why, since we can offer everything, we can select best possible option for our patient. We will not stretch any technology or any, way of treatment. We will be flexible in selecting right technique. That's why we must master all these things. Just बाहर नहीं आ रहा था. एक मिनट. एक मिनट बाहेर येत नाही. मला आता बाहेर घ्यावं लागेल. The probe is not coming out because the colonoscope. Can you see this probe in the colonoscope now?
Yes.
Yes. Now I will put it again. Change kar. So this probe should be very just close to the stone. It should not touch the stone. It should be just okay maximum 2. Maximum 4. So I am delivering energy now.
Yes.
Can you appreciate it's fragmenting?
Yes.
Wash. See, huh? Chips are coming out. Can you appreciate?
Yes, yes.
Okay. Oh.
Hello, Dr. Makran.
Yes, sir.
Makran, I'm just shifting the camera for just a minute to OT number 2.
Yes.
The same patient where we did polypectomy and it was bleeding.
Yes, yes.
We are doing a chexoscopy.
Yes, yes.
And we'll get back to Dr. Praveen sir again.
Yes, yes. Okay, okay.
Over to Dr. Mandar.
Mandar sir, we are with you.
Hello?
Mandar sir, we are with
Yeah.
you.
So we are just doing chexoscopy of this patient. The patient was kept in the recovery and we were continuously monitoring her pulse and BP. So hemodynamically she remains stable. So now we are just doing a quick chexoscopy without any anesthesia. That's why we can hear her continuous wailing. So stomach looks clean.
Yes, yes.
There is no blood.
It has stopped.
Yeah. So let's see now. This is the pylorus. Zhala ji.
Yes.
Okay, I think it's clear.
Yes, yes, clear.
So
patience is the key.
yes. So it's like we treat, he cures. Okay. So we are good. I'll just take out the scope. You can shift to the other OT. Thank you.
One question, sir, from
yes,
side.
Yes,
if the biopsy comes out as periampullary, you will treat it as a periampullary?
No, it is not. It is not periampullary. It is in D1.
It's in the D1.
It is in D1. See here. This is the base. So we are nowhere close to D2.
Okay, okay.
The only issue is if this turns out to be high-grade dysplasia, then what? In that case also, if the base is clear, then still in that case we don't have to do anything. We just keep the patient on surveillance.
How frequently will you
So first chexoscopy will be done after a period of 6 months. If that shows no recurrence, then further scopies can be done once a year.
Okay.
With suspicion of dysplasia, we should have gone for submucosal resection.
No. I am saying if the histopath.
That's what I think.
If preoperatively, if it had shown dysplasia, then definitely yes.
Yes. It was not biopsied, I think.
No.
Okay.
It was biopsied, it showed hyperplastic polyp. That's why we decided to
then
go.
this was the correct.
Yes, sir.
Yes,
Thank you, Dr. Mandar.
Thank you.
Dr. Makran, we are shifting to Dr. Praveen sir's code.
Yes.
Yes, sir. एक मिनट स्क्रीन स्क्रीन क्लियर करो मिनट हाँ क्लियर करो can you appreciate now the multiple fragments
Yes, yes.
huh?
Yes, yes.
So
yes,
we'll clear this fragment first, then we'll see.
You are doing it very fast. Hello?
Yes.
What is the secret behind it? Is it some different laser?
No, same. Everything is same. Just macaroni is there now, this time. Basket. Okay. Basket. So we'll clear this fragment, then we'll see. Open. Inject कर contrast. Close कर. Inject. Open. ठीक है? See.
Yes, yes.
बंद कर. Open. Thumb. Close. Open. Wash. Close कर. Inject. 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 साला इंजेक्ट कर. हाँ नॉर्मल है ना. ठीक है. ओपन. ओपन. हाँ
कप कमी होत नाही इथे.
हाँ नहीं ठीक है ना क्या है. हाँ ठीक है स्टमक तो है. ओपन. हाँ स्क्रीन. हाँ ठीक है. ओपन ओपन. ओके. ओपन. ओपन. हाँ कॉलन देना. हाँ
Dr. Makran,
Yes, yes, sir.
we are shifting to OT3. Dr. Advait is doing a colonoscopy.
Yes,
He
yes.
has already reached cecum, so he'll be showing
Okay.
the withdrawal procedure. It's an old man with history of just a minute.
Yes, yes.
So it's a 52 years old male with complaints of loose stool since 1 year, intermittently. So So it's a 52 years old male patient, complains of loose stool since last 1 year intermittently. Known case of hypertension on medication since 3 to 4 years. Stool occult blood is negative. Patient is posted for diagnostic colonoscopy. Over to Advait sir.
Hello, am I audible, Makran sir? Hello? I am not audible. Am I audible there in the auditorium?
Hello, Advait.
Yes, sir.
Yes, you are audible.
Are you getting the endoscopy picture?
No, no.
Yeah.
Endoscopy picture, please. Yes.
Yeah. So you are getting the endoscopy picture?
Yes, yes.
So I have, for the sake of time, I started the procedure when Suryavanshi sir was doing the EHL.
Yes. I
So
think you are in the terminal ileum.
Yeah. So what I have done is I have crossed the cecum across the IC wall, and now I am into terminal ileum.
Yes.
Because the history was chronic since of 1 year. So in such cases, elderly gentlemen, you should always try to negotiate the IC valve and see if you can find any ulcers in the terminal ileum.
Yes, yes.
So we are quite deep into the terminal ileum. Gradually I am withdrawing. You can see the entire mucosa is normal with normal vascular pattern.
Yes.
Okay. There are no ulcers. Okay.
Yes.
So at least 5 to 6 centimeters of terminal ileum should be seen.
Yes.
So we cannulated almost around 10 centimeters. So now I have fallen back into the cecum.
Yes, that is appendicular.
Yeah. So the landmarks of cecum is this triangular field, triangular fold of mucosa tree. Then this is the appendicular opening, and here we can see the IC valve.
Yes.
Okay. So everything is normal. Nothing. So while coming back in colonoscopy, while withdrawal, the examination has to be thorough.
Yes.
And fold by fold, you should not miss any polyps, specifically in the right colon in elderly population. The preparation is also good. we can see the normal vascular pattern.
Yeah.
So sometimes this kind of things happen, we fall back. So now this is the hepatic flexure. Can you appreciate the bluish tinge
Yes, yes,
over
yes.
the colonic, the impression of the liver
Yes,
over
yes.
the colon? So this is hepatic flexure. So we are come out of the ascending colon. Now I will just decompress a bit so that the patient becomes comfortable post procedure. Intermittently, some segments you should deflate so that patient is comfortable post procedure. So coming back, gradually we are coming back.
Hello, Advait.
Huh?
Have you started underwater colonoscopy?
No, no, no. I prefer to do underwater colonoscopy, but I don't think so. Here we have the water jet available. But what we can do is we can use a 50 cc of syringe
yes.
and irrigate the colon, which opens up the folds also,
Yes,
and the scope also glides over easily.
Yes,
But and specifically if the mucosa is dehydrated and patchy on dry mucosa, I would ask my anesthetist to infuse some IV fluids
Yes.
fast and instill some water and do underwater colonoscopy. But at times it becomes messy if the patient's anal tone is not good.
Yes, sir.
But of course it is quite a good technique, and colonoscopy becomes quite easy in that.
Yes, yes. Particularly flexures negotiation.
Yeah.
So carbon dioxide is used here for insufflation?
No, this is we are doing on air.
Okay.
Yeah. Because it was a diagnostic procedure, I didn't thought it would take so much of time.
Yes.
So, and therefore I am deflating the segment by segment while coming back after inspection, a thorough inspection. If there is no pathology found, I would deflate the segment so that the patient becomes comfortable. I think now this is the splenic impression. How can you appreciate this bluish tinge?
Yes,
The splenic impression. We are at the splenic flexure.
Yes.
So these are the landmarks you should not miss while inspecting, so that you know that you have thoroughly examined. Again, you can see this is the splenic flexure. So we are quite happy with this. The vascular pattern is normal. The mucosa is normal. Intermittently, you should clean your lens. So now we are in the descending colon. You should, for the beginners, they should appreciate this pattern of mucosa, vascular pattern, because in ulcerative colitis, this usually gets distorted. And early cases, only mucosal vascular pattern might also be seen, and some ulcers. So you should not miss that diagnosis. So inspecting the vascular pattern is important. So coming back gradually, fold by fold, and deflating the segments intermittently.
Yes.
Now I am into the rectosigmoid region.
Are you demonstrating retroflexion in rectum?
No need. He doesn't have any symptoms.
Okay.
Yeah. So here we are. Tomorrow we can demonstrate. We have many colonic cases.
Yes.
And retroflexion we can demonstrate for a demonstration, but it is quite a dangerous maneuver.
Yes.
Specifically in a thin individuals where the rectum is not roomy, you can perforate the rectum.
Yes. No problem. No problem.
Yeah. So see, here also we can see there are no hemorrhoids in the anal canal. In the forward viewing also you can inspect the anal canal quite nicely. Small grade 1 hemorrhoids, which is quite common.
Yes.
Thank you. Any questions?
Shift to OT1.
Normal study up to ileum, terminal.
Yes. Hello.
Hello.
See, we have fragmented more parts. Can you appreciate?
Yes. Wonderful.
एक मिनट असं पकड. Screen. Basket. I think I will have to take out these distal fragments. So it's very time consuming procedure.
Yes, yes.
That's why, we surgeons can do better job with CBD exploration, laparoscopically. But if there is no intact gallbladder, then and only CBD stones are there, standard,
yes.
then this is again basket. Close, close, close. Screen. Open. Close. Close. Open. Close. हां तिकडे काय अजून घ्यायचं असतं तर घेऊन टाका ना. This is some fragment. Bug. Scope. बस बस ब्रेक द्या ब्रेक द्या. मेटल स्टेंटिंग उद्या करू. कोण ते श्रीकांत सर विचारा फोन करा. श्रीकांत ते कधी निघतात का फोन बघा चेक करा. ते याला आपल्या याला फोन नंबर दिला होता आपल्या सिक्युरिटीच्या इन्चार्जला. हां त्यातल्या पोलिसला फोन करून विचारा ना कधी निघतात काय. त्यांना सांगाव ना आम्ही रेडी इकडे निघायला सांगा. उद्या करू. कोणते स्क्रीन त्यांना टी ब्रेक घ्यायला सांगा तू. हॅलो
येस
हां यू कॅन हॅव टी ब्रेक मीन व्हाईल ना. मी ते लाकूड तोड्यासारखं दगड फोडायचं काम करत राहतो. So you have to keep doing same and same again and again.
Yes, yes.
Till you achieve complete clearance. Problem is that this scope, colonoscope, once
Yes.
it is inside, we cannot exchange an instrument.
Okay.
To exchange instrument, we have to take it back into the scope.
Yes.
Ah.
So how much is remaining? Can you see on fluoro?
Let's see. We'll have to inject contrast and all that, to really understand.
Yes.
Correct. एक मिनट. एक मिनट. Damn. Hello, Makaran. Hello.
डॉक्टर प्रवीण सूर्यवंशी.
Yes.
सर सत्यजित आहे.
Satit.
Makaran sir has just left.
Okay. Now tell everyone that there is a very interesting lecture by Dr. Prashant Rahate.
जी सर जी.
So everyone should be there. It is a.
प्रशांत राहटे सर आहेत मी
No, but tell everyone that it's going to be a very interesting session.
Sure, sure.
किती आता मॅक्झिमम ठेवलं ना मॅक्झिमम आहे ना हां फाट तुटला का ते हां नाही नाही प्रोब खराब भारी लढवा आहे प्रोब एकदम. पकडे असं पकड. कसं काय काम करतोय? चालू आहे इकडं स्टोनच आहे ना. बदलायचं ना प्रोब. प्रोब बदलायचं. त्यांनी आणले नाही का? का पकड. प्रोब दुसरं घे. काय आता लोकांची पोझिशन चांगली भेटली. इरिगेट. हां ये बास्केट घे. ते यांच्याशी बोलून घ्या ना. आपल्या सिक्युरिटीला गायकवाड आहे ना. हां हां ओपन स्क्रीन. क्लोज कर. हो का? ते सगळ्यांना सांगून ठेवतं का तिथे लायब्ररीत बसायला? कारण ते डायरेक्ट येतील तिकडं. PM च्या दुसरं. हां सगळ्यांना सांगू ना तिकडं जाऊन लायब्ररीत फॅकल्टी रूममध्ये बसवा ना. ओपन
From sir, fluoro picture is, there is no fluoro picture.
Pardon?
Fluoro picture नहीं है.
Floor image नहीं क्या? Okay, okay. See now the fragments are coming out. Huh? Open.
Yes.
Close. Gently, gently कर. Open. नहीं. Saline inject कर. एक बिट था. Saline inject कर. Forcefully. Open. बस बस. Inject. बस 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 बस. Open basket. हाँ. Screen. Close. Open. Close. Screen. Open. Wash कर. तुम्ही सर ते इनॉग्रेशनची तयारी करा. सगळ्यांना पाठवा. हा लोक गोळा करा. ते निघाले असतील ते यांना पाठवा. मी आलोच. हां तयारी करा. मी आलोच. बस. Close. Open. Open. Close. Open. Close. Open. Close. Thumbs up. Open. Ah, yes. Contact indicator. मुक्का खूप मोठा आहे. स्कोप घ्या. स्कोप घ्या. श्रीकांत आले ना, मला आले की सांगा, मी स्टेन टाकून येतो. हां, ते बंद करू आपण. स्टोन येते झाला. स्टोन अडकला. आपला स्कोप आहे ना. प्रोब आहे ना प्रोब घे ना हां काय नसतं काढ काढ बघू चांगलं मिळालं तर करू स्क्रीन दाखव इरिगेशन जाणार नाही त्याला मॅक्झिमम आहे ना बसवा ना, बसवा ना. झालं ऑलमोस्ट. इकडे हां थोडं वर आहे. इकडे आले की सांगा मला. आले का? बस कर. Screen. Open. Good. Open. बस. Good. Close. Screen. इंजेक्ट saline भरपूर. Inject. बलून घे. स्पिंक्टर ठेव आणि बलून घे. बलून घे. काढून घे. Zebra. Balloon. Hello.
We are here, sir.
So you almost crushed the stone. You must have seen on cholangiogram. Now only fragments are there. There is no large segment of the stone. So we'll just, with the balloon, we'll extract those fragments. So now guests will arrive in some time for the inaugural program. Open. 2.3 centimeter. Deflate. Inflate. 3. Deflate. Basket. Basket. हे जाऊन बसले का? जादू सर ते जाऊन बसले का? लास्ट रॅप करतो नसता स्टेंट टाकून बस. ओपन. So can you appreciate this basket is getting opened up nicely?
Yes,
Initially it was not happening.
Yes, sir. Yes, sir.
Yeah. So this stone is fragmented. Otherwise, basket will never open like this. Okay. Contrast. Yes, that fragment has come out. Open. Can you appreciate? Fragments are coming.
Yes,
Huh?
sir. Yes, sir.
May I know who is there? Open.
Dr. Gaikwad.
Okay, okay. Thank you, sir. Close. Open. Injured? Die.
Fragments are very small. They are
Yeah.
getting in the basket.
Yeah. Okay, balloon. Close. And lower CBD is also very narrowed, so that balloon is also we are not able to extract. So we'll give last attempt, or they will put the stent, and in third setting after 1 month, because we had done a lot of intervention, so we'll do final ERCP and take out all the stuff, just fragments. There is no need of lithotripsy now. That much is sure. Are you convinced or not?
Yes, yes.
The stone is completely fragmented.
Completely fragmented.
Balloon.
In this patient, which antibiotic you are preparing, sir? Post-op.
We'll give Magnixford, ceftriaxone, Vilsulbactam. That is good antibiotic for biliary tree. It gets excreted through the biliary.
Patient was already in the septic shock.
Initially it was. She presented with septic shock with multi-organ failure. And then we did first ERCP and we just stented her. We decompressed biliary tree. And now after control of everything, she was posted for the EHL. If there would have not been, like conference, I would have done CBD exploration. Yeah. So you must have realized how laborious this job is, breaking large stones. So definitely we surgeon can do one time better job, than, so much of struggle and the, cost which otherwise patient has to pay. Balloon. Two and a half kar. 2 cc. 2 cc. Deflate. Inflate. 3 cc. 3 cc. 3.
In this lithotripsy, what are the chances of the stricture of the CBD?
No, sir. Now 2 cc. And I contrast, inject contrast. Now we will show occlusion cholangiogram, sir. Inject. Clear?
Yes, yes, sir.
Huh?
Yes, yes.
Deflect. Stent. Yes, stent. Screen. झालं ना? हां, स्टँड घे. घे. स्टँड. ठीक है ना? Later, let's see. Yeah, small. Screen. These are comparatively softer. Euro are very hard. Screen. Stent. ब्लॉक झाले. ब्लॉक झाले.
Very nice, sir.
Thank you so
Nice
much.
one.
Thank you. I hope everyone enjoyed today's session.
Yes, sir.
And tomorrow we have more exciting cases. We have pancreatic cases, pancreaticoscopy, pancreatic stone extraction with cystogastrostomy for pancreatic pseudocyst, and the pancreatic drainage, transpapillary drainage of pancreatic pseudocyst.
Thank you, sir.
Thank you.
The sequence of event for the next few hours is inauguration followed by the lecture and then dinner at Fern.
Check. Check.
Good evening to all. We Department of Surgery from MGM Medical College and Hospital, Sambhajinagar, welcome you all to this event of ENDOSURG 2025, a dedicated event of endoscopy for surgeons. We are very much honored today to have all the respected dignitaries with us, whose presence adds great value to this event of 3rd ENDOSURG 2025, the Brainchild Initiative by Dr. Praveen Suryavanshi sir. So let us all welcome all our dignitaries on the dais. Shri G. Shrikant sir, Municipal Commissioner, Chhatrapati Sambhajinagar. Dr. P.M. Zadav sir, Vice Chairman, MGM University. Dr. A.N. Kadam sir, Secretary, MGM Trust and Chancellor, MGM University, Chhatrapati Sambhajinagar. Dr. R.B. Bora sir, Dr. Praveen Suryavanshi sir, Dr. Musande sir, HOD, Department of Surgery, Dr. Shinde sir, Executive Council Member, ASI, Dr. Satyajit Patrikar sir, President, Aurangabad Surgical Society, Dr. Mangesh Tandade sir, Dr. Naveen Kasliwal sir, Vice President, Aurangabad Surgical Society, I would now request Dr. Praveen Suryavanshi sir to welcome our chief guest, Shri G. Shrikant sir, with floral bouquets. I request Suryavanshi sir to felicitate Dr. P.M. Zadav sir. I request Suryavanshi sir to welcome Dr. A.N. Kadam sir. Thank you, sir. I would now request Dr. Musande sir to welcome Dr. R.B. Bora sir, Dean, MGM Medical College. Dr. Praveen Suryavanshi sir, ASI President, Deputy Dean Medical College, MGM Medical College and Hospital.
I would now request Dr. Sushil Deshpande sir to felicitate Dr. B.V. Musande sir, HOD, Department of Surgery. Deshmukh sir. And Dr. R.M. Shinde, Executive Council Member and Professor, Head of Unit, MGM Medical College and Hospital. I would now request Dr. Vikas Deshmukh sir to come and facilitate. Dr. Satyajit Patrikar sir, ASI President.
Surgical Society President. I request Vikas Deshmukh sir to welcome Dr. Naveen Kasliwal sir, Vice President, Aurangabad Surgical Society. Thank you, sir. Lamp lighting ceremony and garlanding of Gandhiji's portrait holds deep cultural and symbolic meaning in our tradition. Lighting a lamp represents the dispelling of darkness and ignorance, symbolizing the arrival of knowledge and wisdom and uniting communities. So, garlanding Gandhiji's portrait is a mark of respect for his contributions to the freedom struggle and philosophy of non-violence. I request all the dignitaries on the dais to please do the lamp lighting ceremony and garlanding of Gandhiji's portrait. we would now like to welcome the protagonist, the man of the hour, the brain and heart of this event, the ENDOSURG, the person behind this prestigious event, President ASI, CEO and Deputy Dean, MGM Medical College and Hospital, Chhatrapati Sambhajinagar, and Head of Department of HPB, our guide and our mentor, Dr. Praveen Suryavanshi sir, to come and share a few words of wisdom.
Good evening. All respected dignitaries on the dais of the dais. Chief guest for the today's inaugural ceremony, Shri Honorable G. Shrikantji, Municipal Commissioner, Chhatrapati Sambhajinagar, Vice Chairman MGM Trust, Dr. P.M. Jadhav sir, Secretary MGM Trust and the Chancellor MGM University, Shri A.N. Kadam sir, Dean MGM Medical College Dr. Rajendra Bora, Head of the Department of General Surgery MGM Medical College Dr. Bhaskar Musande, President of Aurangabad Surgical Society Dr. Satyajit Patrikar, Vice President Dr. Naveen Kasliwal, all respected senior teachers, all respected faculties who have come from all the way from across the country to share their knowledge and wisdom. Dear friends and dear students, on behalf of MGM Medical College and Hospital, Chhatrapati Sambhajinagar, and from Association of Surgeons of India, I heartily welcome you all for this third edition of ENDOSURG. Since being a both endoscopic and laparoscopic surgeon, it was constant there in my mind that we must train our colleagues for both the skills, which is a future of this technology going to be a future for the surgeons. And unfortunately, the endoscopy, which we surgeons started 30 years back, slowly we give away. Just we thought it's going to be just a diagnostic tool, and we give it to our gastroenterologist colleagues. But with the advancement of technology, more and more therapeutic indications and procedures are included in the basket of therapeutic endoscopy. And then I felt more strong that now we must train our colleague for this therapeutic endoscopy so that these advanced treatment options will be reached to the grassroots level across the country. And we surgeons, I think anything beyond lumen, we understand better. Whether it's a tissue cutting, whether it's a tissue science, whether it's a tissue healing, we understand this better than our colleagues. So that it is high time when the endoscopy has gone beyond the lumens into the peritoneal cavity, we must master this tool. And not just to compete with anyone, but to give best possible treatment options. I tell you, even our colleagues, they are struggling more to master those skills. So why not we then? We can definitely master ourselves at in a better pace and with less struggle. So with that intention, 3 years back we started this ENDOSURG, and I'm very happy that first time this year, initially we used to have only on-site sessions, but the first time we telecasted it across the country in all medical college just to promote and just to boost the enthusiasm in budding surgeons to take endoscopy seriously in their further curriculum. So I'm very happy that it's a new benchmark today, and we could really create an impact across the country. I had a lot of phone calls and messages from across the country appreciating our these small efforts and encouraging us to continue every year. So I'm sure next year also we'll have better gathering than what we had this year, because this telecasting across the country, it was just decided last moment, just 5-6 days back, and in spite of that we had more than almost 120 medical colleges participating in these online sessions. So it's very encouraging. Thank you so much everyone here. A special big thanks to all the delegates and faculties coming physically to witness these efforts. And it's not just, again, what I feel, it's not just to compete with our colleagues. But I feel this is a technology of tomorrow. So we must equip ourselves, we must train ourselves, we must make ourselves future ready so that these advanced technical procedures are reached to the grassroots level, to the poorest of poor and at every corner of the country. That is our whole mission. And ASI is working very hard, not just this workshop, but we have designed many fellowship programs for endoscopy at our ASI head office Chennai. In collaboration with Olympus, we are establishing state-of-the-art skill center where all faculties from the country will be invited to have training, hands-on training on the animal models and the very state-of-the-art mannequins. So we are working in many ways. So we need just your active participation to take it further. And whatever we have done so far is very encouraging, and with everyone's support and cooperation, I am sure we will able to make the very deep impact in coming year. So just a few words for our chief guest today, Shri G. Shikant. He is a very good friend of mine, but I took extra liberty to go to his residence to invite him personally. You must have seen he had this tendo Achilles fracture avulsion, and he has been undergone surgery for that, and he had stopped all these social commitments. His only commitment right now is on his foot for that is the demolition of encroachment in the city, and whole city is with great gratitude and hand folded is very thankful to him for taking this drive. So when I went there to invite him, he said, "ये तो डॉक्टर का प्रोग्राम है, मेरा क्या काम है वहाँ पे?" I just said him, "Sir, I know we are inviting you not just to inaugurate this event, but just to express our gratitude and our just express big thanks to him for whatever he is doing for the city." So this is, I feel it is not just his chief guest. I would like to felicitate him on behalf of our MGM family and all of us for all hard work he is doing for the Aurangabad, Chhatrapati Sambhajinagar. So it's, thank you so much, sir, from bottom of our heart, and we wish you a very healthy and very prosperous life ahead for the betterment of humanity, not just for the Chhatrapati Sambhajinagar, but I am sure wherever he will go, he will create his impact, and that will make big difference for the mankind. Thank you so much, and our best wishes with you for everything, whatever you do. Thank you so much. Again, big thanks to MGM Trust and management for providing this ultra-modern facility. Just you all must have witnessed whatever we did today, everything is in-house. We are doing it day and night for our patients. So Shikant sir, whatever technology we are using is same what is used in American best of base center. Nothing short of or nothing inferior to that. And best part that we are providing this technology to the poorest of poor, which they are not otherwise demanding. But we are committed to give these quality services, and we are happy that we could do that. So thank you so much. And again, another small request, be a part of ASI, not just to share knowledge and skill, but for our own existence, we must join ASI. We must strengthen ASI so that we can deliver best possible treatment option in the interest of our patients. So for that, we must come together. So encourage all your friends and colleagues to become ASI member, and this is how we'll keep growing. Thank you so much.
Thank you so much, sir. Apart by place, united in grace, and through online interface, we would now like to connect with our prestigious ASI family. Inviting first Dr. Prabal Neogi, sir, past president, ASI. Dr. Gaddi Divakar sir, pediatric surgeon from Bellary and secretary ASI.
Yes, sir. Yes.
Yes, sir, you're audible.
Respected chief guests of today's function, Dr. Praveen Suryavanshi, President ASI, dignitaries on the dais, off the dais, esteemed faculty and dear colleagues. I should say it gives me immense pleasure to be here virtually amongst you as a part of this ENDOSURG conference, which is a platform that reflects the losing domain which we should evolve as a scope of surgery in the modern era. As Dr. Praveen Suryavanshi, our president, was mentioning, this is rightfully our domain, which we should reclaim. And as you know, endoscopy has become an essential extension of surgeon's skill set. It enhances, as you know, diagnostic accuracy, enables minimally invasive interventions, and significantly improves patient outcomes. For today's surgeon, I should say, endoscopy is not just an option, but it's a necessity. So I urge all the practicing and the aspiring surgeons to embrace endoscopic techniques with commitment and competence. Let us continue to update, upskill, and uphold the standards of surgical care. And I should specially congratulate our President ASI for leading from the front in organizing this ENDOSURG conference. And I wish all the great success for this conference, the third ENDOSURG. Thank you.
I request Dr. Madhumita ma'am, Professor of Surgery, Kolkata and Treasurer, ASI, to share a few words.
Good evening, everyone. Am I audible?
Yes, ma'am, you're audible.
Good evening, everyone. My respects to the dignitaries on the dais, off the dais. Thanks to our President, Dr. Suryavanshi, for this wonderful endeavor. I congratulate all the organizers, the organizing team, the MGM Medical College, and the Aurangabad Surgical Society for this great, wonderful program. As our President has rightly pointed out, in the last 2 decades, surgeons have been slowly moving out of endoscopy. But when we think about it, endoscopy is actually surgery. It is cardiac surgery. So, unfortunately, most of the young surgeons nowadays have realized it, and everyone is very much interested in endoscopy. I congratulate again each and every one of you who have all come over here physically, and I'm proud to be a part of this virtual program. And I'll try to, I couldn't attend it this time, but I'll try to be there for that fourth August, definitely physically at Aurangabad. Congratulations once again. All the best to this conference. Thank you.
Thank you so much, ma'am, for your kind words. Dr. Shiva Mishra, sir, past president and legal advisor to ASI from Kanpur.
Good evening, and I extend warm greetings from NBEMS, that is National Board of Examination and Medical Sciences, to all the attendees of 3rd ENDOSURG at Chhatrapati Sambhajinagar, Maharashtra. As pointed out by President Dr. Praveen Suryavanshi, the endoscopic skills are becoming increasingly important for surgeons, particularly in the era of minimally invasive surgery. Comprehensive training in GI endoscopy is crucial for surgeons to effectively utilize these techniques. By integrating endoscopy into surgical practice, surgeons can improve patient outcomes, reduce complications, and enhance the overall quality of care. I congratulate Dr. Praveen Suryavanshi and his team at NGM Hospital for taking the lead to train the surgeons in the promising field of diagnostic and therapeutic GI endoscopy. Wishing this ENDOSURG 3rd edition a grand success. Thank you very much.
Thank you, sir. Dr. Probal Neogi sir is in Hong Kong, so he won't be able to join us for the current session. In recognition of exemplary performance and distinguished contribution by our faculties of ENDOSURG, who made this Pan-India Session 1 of ENDOSURG 3 a success. Thank you all, sir. We request our chief guest, G. Shrikant, sir, to come and felicitate enthusiastic force. First, Dr. Joy Abraham, sir, MCH Surgical Gastroenterology and GI-HPV Cancer Specialist, Ahmedabad. Dr. Prashant Rahate, sir, Senior Laparoscopic Surgeon from Nagpur, 7-star Hospital. Dr. Mandar Doifode, sir, dedicated endoscopic surgeon from Pune. Dr. Advay Ahir, dedicated endoscopic surgeon from Nashik. Rajesh Kadam, sir, Deputy Registrar, MGM Medical College and MMC Observer. Thank you so much, sir. With great respect and admiration, I now welcome our esteemed Vice Chairman, Dr. P.M. Jadhav, sir, to kindly grace us with his few words of wisdom.
Honorable Chief Guest, Sri G. Shrikantji, my esteemed colleague and Chancellor of the University, Mr. A.N. Kadam, ESI President, Dr. Praveen Suyonshi, our Dean, Dr. Boha, Dr. Musande, Dr. Sinde, and all dignitaries on the dais and of the dais. Indeed, it is such a happiest occasion for MGM because we are having 45 residents. Am I right? 45 residents who can get the feast of these endoscopic experiences. You all are here since morning. Some sessions has been done in the theatre, and I heard and I gathered that you had a wonderful session of resection of the removal of the stones from the common bile ducts in a new technique. This you cannot get it anywhere. When Dr. Suyonshi took over as a chairman of the ASI, I think he has different ideas in his mind. And about 6 to 7 schemes I think he has planned to execute during his shortest tenure. Why I am saying shortest is now very few, 6-7 months are left, but I hope that that will be executed and that you will get benefit from it. During our time, the endoscopy was unheard of. It had just recently came in 1990s, 80 to 90s it started. When I became a graduate, we didn't hear anything about the endoscopy and the gastroscopy, both together. Neither the ultrasound. Those were the days when we used to do the open cholecystectomy by taking the coccus incision from GP sternum to the right hypochondrium. Stay of the hospital was about 8 to 10 days, if you are lucky that you don't get any infection. But nowadays, it is just a question of couple of minutes, maybe 40, 50 minutes, and then operation is finished. Big stone is removed through the endoscopy, and then patient can go within a day or two. And I think that is something wonderful and astonishing thing that you new generation are going to see it. Time is flying and time is changing. Change is imminent in life. So what we learn, you are not going to see it or heard of. Now the technique is changing. Tomorrow some more technique may come, so you must be ready with the future. So my sincere request to my all residents is, please attend tomorrow as well, and then get all the techniques which is been shown into this conference, which is going to help you. After passing it, when you pass, then you will go everywhere, maybe in the district place or in the taluka place, where you will be boss of your own. Here, if you make any mistakes, even by doing the endoscopy or laparoscopic surgery, boss is there, so that you can get all corrections. But once you go out, then you are boss of your own. So be conscious, be hardworking, and adopt everything whatever is given in 2 days. And I'm sure that few more conference is going to come in future. I think in this hall, every day there is conference. Every day there is something new feast for the students and the doctors as well. So take advantage of it. That is going to make our future career and life very bright. With these few words, I think I can stop it here. Now, Mr. Srikant is here, and I'm also very eager to hear what he says. Thank you very much.
Thank you so much, sir, for your inspiring words. It's indeed a great honor for us to welcome a distinguished personality whose dedication to public service and administrative excellence is truly inspiring for all of us. Our chief guest, G. Srikant, sir. He is IS from batch 2009, presently deputed as Commissioner and Administrator, Municipal Corporation, Chhatrapati Sambhajinagar. His earlier posts were probationary IS officer at Nanded district, assistant collector at district Nanded, municipal commissioner Nanded Waghala, chief executive officer at ZP Satara, district collector at Akola, district collector at Latur, managing director of Maharashtra State Seeds Corporation Limited, Akola, joint commissioner of state tax Aurangabad division, commissioner and presently commissioner and administrator municipal corporation Chhatrapati Sambhajinagar. I request our Vice Chairman, Sir, Dr. P.M. Jadhav, Sir, to felicitate our Chief Guest with a memento. I request our Chief Guest, Sir, to kindly enlighten us with his few words.
First of all, on the eve of third ENDOSURG, endoscopy for the future, the 2-day seminar being held at our city, in fact I can say my city, that is Chhatrapati Sambhajinagar. First of all, I congratulate President of one of the oldest Association of Surgeons of India, Sri Dr. Praveen Suryavamshi. And on this day, Honorable Chancellor of MGM, Sri Ankush Rauji Kadam sir, and Vice Chairman of MGM, Sri Jadhav sir, and all dignitaries on the dais, and all senior most doctors and few friends I could meet today who had come from Latur, and all secretaries, secretary, president, past presidents of ASI. Very happy to see that the place where I come from, the secretary comes from there only, the Bellary. I come from Raichur, so our neighboring district. So when I was asked what I'm doing in the conference and what I will be speaking, what I should speak in the doctors' conference, except Kadam sir and me, I think we might be doctorate, sir. Sir is engineer. We are the only non-doctors. All are doctors only. So what we will be doing here? But when Dr. Praveen Suryavanshi sir said that, sir, you are not less than a doctor, because we do surgery on a man, you do surgery on the city. Because that's very important. Because friends, because when as an administrator, it's a tough task, not supported by any politicians, because I don't have any political body right now. But definitely I have an MLAs, MPs, ministers who check and mate thing like that. But for the first time I'm seeing not even a single politician had come and asked to stop this surgery, which is happening in the city, wherein in the past 7 days we have demolished 5,500 illegal structures which has been adjacent to the road, which was there standing without any permission from the authorities. It's not about with permission or without permission, it's all about that how many people are dying on the road because of this menace. Because of this menace, I can tell you that daily one person is dying in the roads of Chhatrapati Sambhajinagar. Yesterday, exactly like the places where we pray, unfortunately yesterday 5 people had been crushed. I couldn't take the data that how many of those people have died. It happened exactly in the Kala Ganpati Mandir. And when I see these kind of incidents, initially during COVID times, I felt that why I couldn't become a doctor, why I became an IS officer. If I would have been a doctor, I might save lives. When I discussed with my few doctor friends, he said that, sir, we definitely, we as a doctors, we keep on treating the people. But you have more responsibility, you have a bigger responsibility. If you do proper work, if you bureaucrats, politicians, not necessarily be doctors, if you people do good work, if you do the work which is required, we should be left with no work. We should be left with no work. That means that if we should do such a work where the accidents should be prevented, we should avoid the black spots. That's all infrastructure related work which we are supposed to do, but unfortunately we are not doing enough. If we do our proper work, then definitely I can say that you will be relaxed. Today when Dr. Saab was proudly saying, sir, today I conducted 21 surgeries. I said that, sir, I would have been more happy that if you are relaxed on Saturdays and Sundays rather than these conferences. So unfortunately bureaucrats and we part of that community have to work to avoid. We are in the PSM, preventive and social medicine. Maybe I don't have a doctorate or a doctor, but we have to prevent people falling ill. We have to prevent people getting killed, murdered. In fact, I can say that it's a sort of a murder only if I don't do the work, because in murder and killing is two different things. In murder, you just require a guilty mind. If I don't do what I'm supposed to do, then definitely that can be part of murder only. But सब कुछ चलता है और चलते आ रहा है, but someday someone has to take that risk, and we have taken that risk, but very ably supported by the court's judgments, and because of my strong team we could do that. And definitely this city once used to be the capital and today tourism capital of Maharashtra, where we have 2 UNESCO World Heritage Sites. Not a single city will receive more tourists across the countries. This is the one such place. Right from Japan to America, and from Russia to Australia, be it northern hemisphere, southern hemisphere, eastern, western, from every country people travel here. This is such a place. And if you go around, you will see Shendra, Bidkin, Waluj. And very fortunately, we are in the midway of Samruddhi Mahamarg. This city is the future, and we should be future built city with the sustainable solutions where everyone feels safe and secure. And that's what we believe it. And that's why the huge sir was saying, sir, today I conducted 21 surgeries. Yesterday, sir, I said, sir, yesterday I conducted 263 surgeries. And I was asking, sir, how many surgeries you have done in the entire of your career? Sir, I have video record of every surgery right from 1991 when I was just 6 years old. And you might be, sir, 2,000, 3,000 hour surgeries, but in the 7 days we had conducted on 5,500 surgeries and yet more to go. Yeah, but Jadhav sir and Bora sir was saying, sir, in doctor community there is one thing. We always do surgery so that the recurrence should not be there. And what about the recurrence? What will it once you take away the tumor, will it not come again? And it happened many times. Yes, sir, I am very concerned about that recurrence, because already we started the work of road construction along with the greenery, because we are demarcating the boundaries of our roads with poles wherein it is marked with what you should do beyond this pole and what you shouldn't do. Okay. That's what is going to be mentioned in every after every 100 meters, which is written in our pole, so that the recurrence will be there. Recurrence shouldn't be there, and definitely there can be resurgery also, sir. Because this surgery will not be stopping here, and it is going to go even inside the cities. And friends, there were few politicians who had come. We had come and was saying, sir, ye galat ho raha hai. Ye galat ho raha hai. I don't name him. I don't name them. But I know that persons individually, because I keep track of politicians, their health problems also. Very recently, he had been operated angioplasty. I said, sir, what exactly you are stopping to me? Because if the doctor has not conducted angioplasty, he would have suffered to death. And I don't want to see my city dying like you. Because whatever I am doing, this is just what happened with you just 7 days back. 7 days back, he had been operated angioplasty. I wished him speedy recovery. And you should wish me speedy recovery of the city. Because what exactly I am doing is nothing but angiography, because we have done angiography. Now it is the angioplasty thing which we are doing, nothing else. So, and immediately, that person who had come to me with opposing this particular thing has realized, immediately within 5 minutes, he said that, sir, please do it, we are with you. So that's what everybody you have to convince, because most of the time I feel, because I conducted this Achilles tendon surgery in Mumbai, because when I talked with few of the doctors, they were not convincing me कि sir आपको surgery करना है, and the doctor who was in Mumbai, he said that he convinced me so beautifully that why you need to get those things, get this surgery done, and how well you will recover. Within 5 minutes, I said yes, chalo kar lete hain. My wife was very apprehensive for any surgery through whatever latest technologies be. But somehow I was convinced very easily, and I believe, because I have a big health department with many doctors. I always tell people, the more treatment is not with the knives or any equipments, it is more with your sweet voice, how you convince properly. So that's what we are doing. And when sir said that ENDOSURG, we are doing this endoscopy, and he was explaining to me, I listened to sir said what is endoscopy and everything. We said that, sir, though I didn't become a doctor, but we are doing we are using endoscopy in corporation also. I'll show you some of the photographs. Can you please show them some photographs? Because in water supply, the biggest problem which I used to face is that illegal connections, thefts, and clogging. See, this is the endoscopy photo. Can you see this photo? It is on 5th May 2025. It is taken at 1316. On this side, you can see it is 12.40 meters. Earlier, see, you might get poor water mixed with drainage, or sometimes water don't come. So earlier what people used to do, they used to do trial and error method. यहाँ खोदा, यहाँ खोदा, यहाँ खोदा, यहाँ खोदा. इस खोदने में तुम भी परेशान होते हो, साला अभी तो रोड बनाया और कितना खोद रहे हो. फिर खोद के पूरा शहर खोद के रखते हैं. फिर and there is huge finance also involved. The more you dig, the more money it will become. The more money the bill it becomes, the more percentages they get. The contractor benefited, officers benefited, so-called politicians also benefited. With endoscopy, it all stopped. So this is endo board. There is a machine which travels inside the pipeline. Like the endoscopy, very small, minute machines like yours. It travels inside the water supply pipeline. It goes exactly there where it is. See how the water will go the other side of that portion. And you ask me, sir, why it so happened? There are many reasons. Because जादव सर को अगर पानी नहीं जाना है, तो मैं और कदम सर प्लान करते, यहाँ खोद के इधर कुछ तो भी ऐसा डाल देते जब जादव सर गाँव जाएंगे. तो फिर हमने एक लॉक कर दिया. So after this, next photo. So this is another photo. Like pipe. अब फिर आगे पानी ही नहीं जाएगा. Next. See, झाडाचा मुली आल्या. And drainage मिश्रित पाणीच येत नाही, पाणी कमी दाबाने येतं. हे असे problems. Next. It is exactly, and these are the illegal connections. He wants to take the last drop in the pipeline. Like आखिरी बूंद तक पीने वाली जानवर रहते हैं. वैसे actually the connections can be, it is superficial connections रहते हैं ऊपर से. ये illegal connections it go deeper. और कनेक्शन ऐसा नहीं रहता है, उनका कनेक्शन ऐसे जाके ऐसा रहता है अंदर. दिस इज वेरी रिसेंट फोटो. ये तो कल का ही है, 5th 5 आज ही है. हाँ अभी का है 36 ये इलीगल पाइप आया हुआ है और स्टोन है, तो आगे पानी नहीं जाएगा. एंड इमीडिएटली एंड नेक्स्ट एक वीडियो है, एक वीडियो प्ले नहीं हो रहा है. So what this is a diagnosis, and exactly in this diagnosis we take out that particular portion. We dig at exactly 36.66 meters. We dig that much hole only, and the pipeline is operated by using endoscopic technology like you use on us and people. So similarly we use it for drainage pipelines, where, because see, the worst thing I can do is that I'll stop your drainage line, I'll choke your drainage line. You'll not go to your home, because that's the place where you want to go peacefully. Many of the problems, very senior people say that sir drainage choke हो गया, बाकी सर रास्ता नहीं किया तो चलेगा, पानी नहीं आया तो चलेगा. सर ये हमारा पानी लेके जाओ बाहर. ये जो ड्रेनेज का कनेक्शंस है, तो ड्रेनेज में भी हम एंडोस्कोपी यूज़ करते हैं, और सो दैट इट सेव्स मनी, इट सेव्स एनर्जी, it saves manpower resources and many things. So with that, endoscopy is definitely is everyone's thing where which you cannot see openly, which you need to do, which you need to use this technology. We are using it. So that's what I can say. Though it is, I don't know how relevant it is for you, but as far as the since it is related to ENDOSURG, I felt that I should share this. And I sincerely thank Dr. Praveen Suryavanshi ji, who thought that I should be the chief guest for this inaugural ENDOSURG third endoscopy for the future. So I sincerely thank Honorable Kadam sir, Jadhav sir, and all dignitaries and all the doctors who felicitated me, and thank you very much. Jai Hind, Jai Maharashtra. This is the exactly video what I do. Like the surgeon, my surgeon lineman is doing it. So he just digs that much only, and उतना ही खोल के फिर उतना सर्जरी कर देते हैं, तो ताकि people will अभी उसमें क्या क्या निकलता है देखिए. Otherwise earlier you can see everywhere it has been dug up. अभी उतना नहीं होता है शहर में. So wherever, whichever city you come from, you ask your commissioner, because all doctors keep meeting commissioners, or all commissioners keep meeting doctors because of the huge stress which we have. At least डॉक्टर को तो मिलते ही हैं, तो उस टाइम पे आप उनको बताइए कि ये टेक्नोलॉजी अपने शहर में भी करें, ताकि आपकी शहर ज़्यादा खुदाई ना हो. I deliberately not wanted to listen the audio कि वो बहुत ज़ोर ज़ोर से कुछ बोल रहे हो. हमारे बहुत ही ज़्यादा तारीफ करते हैं, इसलिए वो ऑडियो बंद करते हैं. I am sarcastic because they were abusing. महापालिका क्या कर रही थी, सो रही थी क्या, ये कर रही थी. So endoscopy is for the future. Thank you very much.
Thank you so much, sir. I would now like to invite Dr. Mrudu Pandian online for a few words of wisdom. So we can't hear you.
I congratulate Dr. Praveen Suryavanshi, our President, National AIS of MG Medical College, and distinguished Chief Guest, Dr. Mr. Srikanth sir. The endoscopy is much needed for young surgeons as well as for all general surgery people. I am so happy that the year before last, ENDOSURG, wherein I could see the state-of-the-art endoscopic suit, which it is of international standard. Really, it is an amaze to see that endoscopic suit. And ASI is under the presidency of Dr. Suryavanshi. Hello?
Yes, we are listening, sir.
And Dr. Siddesh. Yeah.
Thank you so much, sir, for your kind words. Now we would like to invite our HOD sir, Dr. Bhaskar Musande sir, to give a vote of thanks.
Good evening, everybody. Dignitaries on the dais and off the dais. At the outset, first I would like to congratulate our commissioner. A slight change in the for doing such a wonderful job, and on behalf of everybody sitting here, I would like to congratulate him for doing this wonderful, tedious, and nevertheless quite a stressful job. It's not easy to take such a hard decisions in a city like Aurangabad that way. Thank you so much, sir, for doing your job so sincerely and working for the benefit of the society and Chhatrapati Sambhajinagar. Now at the outset, initially I would like to thank our management, who has been ever supporting for us throughout so many years, whenever we are conducting such workshops or conferences or any lecture series, anything. So I would like to congratulate, I would like to thank Dr. P.M. Jadhav sir, Vice President MGM Trust, Kadam sir, Secretary and Chancellor MGM Technical University, Dr. Bora sir, Dean MGM Medical College. Whenever we enter his cabin, I think we are the first to be supported by all means, without any hindrance. Then, lastly, it would be injustice if I don't mention Dr. Praveen's name, because everybody mentions his name, so I'll also do it, because this was the brainchild of Dr. Praveen to start endoscopy for surgeons last 3 years. And then we backed him and we are supporting him since then. So thank Praveen, Dr. Praveen, for taking this initiative for making surgeons take up endoscopy even now at whatever age you are or whatever part of your career you are. Then I would like to thank the delegates. Without them, no conference or no workshop is successful. Faculties who have come from all over the country. To name them, Dr. Prashant Rahate sir, Dr. Joy from Ahmedabad, Dr. Mandar from Pune, Dr. Advai from Nasik. I thank you all for sparing your time and coming us and making this ENDOSURG a successful, where we conducted 21 procedures today and rest of the procedures we'll be doing tomorrow. Then I will also thank the pharma company who have supported. Without them, no workshop is complete without their support. Then my surgery department, which because everybody has a small or a bigger role in conducting this workshop, because we have to work in at least 15 days or 1 month before to see that the today's work and today's workshop is a successful workshop. So I would like to thank my colleagues. Then I would also like thank my residents who have been working day and night, because without them I think we cannot move a bit ahead, because everything, the basic work of the patient's workup, preparing slides, everything is done by them. Then the team at our endoscopy suits, Anita madam, Trupti madam, Vaishali, then Maruti, Baban, everything, all have their respective roles. Nobody is less important to us whenever we are conducting any workshop. So I thank once again to everybody for coming to this ENDOSURG and making it a grand success. And Surgical Society, which is always in support to us, where we all are basic members, though we are a MGM family, but we are a part of the Surgical Society. So I thank everybody from the bottom of my heart to making this ENDOSURG a grand success. And I hope you enjoyed today's session, and probably you will enjoy more tomorrow's session. Thank you.
Thank you so much, sir, for your kind words. Now I would request all the dignitaries to get off the dais. I would request everyone to stand up for the national anthem. Thank you all the dignitaries. Now we would commence with the lectures for today. I would like to invite Dr. Joy Abraham sir to give a talk on management of GI foreign body.
हाँ चलेगा ये ना आप चेक कर लीजिए जब आप बोलोगे ऊपर दो तो मैं वहाँ से स्विच कर दूँगा अच्छा यहाँ से नहीं स्विच करना है नहीं यहाँ स्विच नहीं होता है ये इस पे जा रहा है
सेटल हो जाने थोड़ा सेटल डाउन नहीं ऑडियो नहीं I'll speak प्ले कहाँ से यहाँ से ही होगा नहीं I'll play it यही है ना Good evening everyone. At the outset I would like to thank Dr. Praveen Suryavanshi, Dr. Musande and the entire Department of Surgery MGM Hospital for organizing this wonderful event. I cannot say anything more than what they all said for endoscopy for surgeons. All these young residents who are here should know that it is a very significant step and a very bold step taken by the Department of Surgery. Not many colleges, like we have been to medical colleges, but not many colleges have these facilities, and neither are they so open. So my topic initially was management of foreign body. I thought you've seen enough. Foreign body is just a very trivial thing in this very hi-fi seminar or workshop. So I thought something innovative technique where I am a strong believer of endoscopy for surgeons. I believe that what surgeons can do with endoscopy, not physicians cannot do. It will be very difficult. So if surgeons take up endoscopy, it will be good for the patients and good for endoscopy. So this is a novel technique where we merge endoscopy and laparoscopy. Laparoscopy you see from the exterior and endoscopy you see from the interior. So when you combine both, you have a 3D image of the disease in your mind. So this is a technique which I presented in one of the conferences in AIG. So I call this killing two birds with a stone, or killing two stones by a single bird. This is the single operator rendezvous ERCP and laparoscopic cholecystectomy. A single procedure for both laparoscopic for gallstones and CBD stones. Pardon me for the lot of names and everything, but this was a presentation which I just downloaded after coming here. So the rendezvous ERCP and laparoscopic cholecystectomy is a hybrid technique. Hybrid technique which it combines endoscopy and laparoscopically very much. I don't know any other procedure which it has merges both these components so well. It manages gallstones and CBD stones in a single setting. Important thing is reduces the hospital stay. The number of days you need for ERCP or laparoscopic cholecystectomy, both are combined, and in a single stay and in a single anesthesia, the procedure is complete. Very importantly, it negates the possibility of post-ERCP pancreatitis, which is to the tune of, I would say, 5 to 15% with antegrade ERCP. So it's not slides. I just thought, yeah. So I pardon me for the shabby videos, but this was. So this is a technique. This is a case of biliary pancreatitis, post-biliary pancreatitis. Patient had sludge in the CBD and gallstones. So in this technique, what you do is dissect. Start with the laparoscopy. In a slight right up position, you dissect the Callet's triangle, tie the cystic artery, and then you nick the cystic duct for the cannula insertion. This is the marking for the port through which the cannula comes, and a port is inserted here. This is one of the first videos we have taken. Yes. This is one of the first videos which. Oh, okay. ये यहाँ पे दिख नहीं रहा है. ये यहाँ पे चल रहा, वहाँ नहीं आ रहा है. So I presume no one understood what I said. So again, laparoscopy and ERCP combined. So मुझे laser दे दीजिए. So here we have made a nick in the cystic duct to pass the cannula through the cystic duct into the CBD, and we have marked the site for the port entry through which the cannula will come. This is a tandem cannula which we regularly use. This is one of the first cases. Over a period of time we have performed around 20 cases and revised every criteria. A lot of details have been changed. You can see the hydrajig wire which is being passed through the cannula, and the zebra guide wire, you can see the yellow and black zebra guide wire which will be crossing the ampulla. And once it crosses the ampulla, we sure a sufficient length of wire has gone through the ampulla. We put in a forward viewing scope and pull out the tip of the zebra wire with the help of a forward viewing scope. Here we are coming out through the esophagus and out. So now you can see the guide wire which is passing through the port on the exterior, and then it crosses through the cystic duct, ampulla, and then pulled out of the through the mouth. So here you would say, what is so special about it? It is special because we as surgeons, as a surgeon I was never trained in endoscopy, and it was very difficult for me to start with endoscopy. Then to proceed with ERCP was another step, because after a certain time you cannot keep on learning. It is very difficult to learn. So you have to spend your time, effort, and shed your responsibilities and go. So this is how I thought this method would make ERCP easier for us. So then over this wire you slide the side viewing scope. Here it passes across, and here it is reaching the ampulla. What is so special about it? The wire is directly coming out of the ampulla. There is no antegrade multiple cannulations. One of the most difficult thing in ERCP, at least what I feel, is one, identification of the ampulla, and the second is perfect cannulation in maybe in a single or two attempts. So this makes the procedure very simple. Once you have cannulated the ampulla, then the procedure is very simple. It is nothing but just passing over the apparatus and then doing the procedures. So here the sphincterotomy is done, and then a stent is placed, and once the stent is placed you confirm the position and then do the rest of the cholecystectomy and extract the gallbladder, and a single time procedure is done. That is all. Thank you very much for
Thank you, sir, for this amazing lecture. I would now like to call Dr. Prashant Rahate, sir, to give a lecture on intraoperative application of endoscopy.
This is my third conference on this endoscopy organized by Praveen sir. Thank you very much for involving me in all the conferences, and I thank the MGM, ASI, Aurangabad ASI for this particular program. This particular presentation will I think really it will stimulate the youngsters. The use of flexible endoscopy in laparoscopy and general surgery. These are the various uses. Intraoperative laparoscopy, which I have been using. Mostly the videos are from Myotomy. The stomach gist, transgastric full thickness resection of the gist. So it is difficult to determine accurate resection line of the gastric intraluminal tumors. We should have a proper margin, and during laparoscopy, we can't see that particular margin because the margin is really from the inside and we can't see through the wall. This, and therefore we end up removing excess stomach. These excessive and inappropriate resection lines may result in gastric stasis and positive resection margins sometimes. Therefore, an accurate cutting line is important for the safe local resection of the tumor. This is the conceptual diagram. And how to select a case. Where is the location of the gist in the stomach? Easy access by the endoscopy such as gastric body, antrum, cardia, but potentially difficult locations are also there such as cardia, prepyloric antrum, lesser curvature, angularis. These are the difficult positions for the removal of the gist laparoscopically. So, and size, if it is less than 3.5 endoscopically it can be removed very well, but if the sizes are the more, then purely endoscopic removal is very difficult. So it should be combined with the laparoscopy and endoscopy both. And if the tumor is more on the outside of the stomach, that is exophytic or endophytic, depending on that also we have to take the decision. So this is the beautiful diagram which you will be knowing. Here pointer. So normally that gist should have a proper circular margin, but endoscopy we end up removing most of the extra stomach there. Extra stomach, extra margin here, but very less margin here. So that drawback is out with the help of the laparoscopy. Then colonic polyps. Colonic polyps, endoscopy and laparoscopically, this is how the surgeons they stand, and this is the endoscopy they standing. Scrub nurse, the anesthetist, monitor for the endoscopies and monitor for the surgeons. So simultaneously both the procedures can be done. I will be showing some videos also. So if this is the polyp, and if this polyp is pushed towards the light, otherwise the vision by the endoscopy is tangential. So if we make it a front vision to the endoscope, the polyp can be removed very well. Then pericolic adenolysis. We know that endoscopy, colonoscopy is really difficult to learn, difficult than the upper GI endoscopy because of the various curvatures. So during this particular procedure of the removal of the polyps or some endoscopic procedure in the colon, we need to remove these adhesions so as to make a simple procedure. So this is how laparoscopically we remove the adhesions, and then simultaneously we do the endoscopic procedure. The only problem is that laparoscopic light and the endoscopic light, they clash. So we have to keep very minimum light during endoscopy. The laparoscopic light is to be kept very low. Colon stretching and retracting. This is how the tumor is made prominent by pulling that in particular direction and then doing this snare. Enhanced visibility of the polyps is done by proper positioning of the colon from outside and then doing snaring, or even submucous dissection, but the colon is very thin, so SMD of the polyps can give rise to through and through perforation, but those perforation can also be very well tackled by laparoscopy. And after that, the proper hemostasis is done by argon plasma coagulation, and then seromuscular stitching is done in this way. So complete removal of the polyp is ensured, and you can very well do. We don't need the help of the gastroenterologist. Your colleague can do help in this particular this type of surgeries. And lastly, tattooing is very much important because this is for the future reference. This tattooing is done by India ink. So that will remain there like tattoo or your hand or your shoulder. It will remain there lifelong. That tattoo in future, if you do colonoscopy, you will come to know that yes, this was the site of the previous polyp there. So that India ink is to be injected. So in summary, these cells with CO2 colonoscopy, CO2 is to be used always. Laparoscopy, mobilization, tenting, invagination, and endoscopic mucosal resection, argon beam coagulation, tattooing, and then seromuscular repair. In obstructed appendix with lump formation, we know that we try to avoid laparoscopic surgery. So this is ERCP treatment, endoscopic retrograde appendicitis treatment. Here endoscopically we reach the cecum, and then stenting is done of the appendix. All the debris and the obstructed fecal matter is removed, and let the time, it will take some time to heal. The lump is regress at a faster level, at a faster pace, and the surgery, subsequent surgery is without any complications. So this is how in colonoscopic, if there is an obstruction at that and because of that mucocele is developed, so that mucocele we know if it leaks, then it can lead to pseudomyxoma peritoni. So do colonoscopy without any much of the insufflation. CO2 is to be used. Put a stent. All the mucocele will be drained in the lumen, and you can do a effortless surgery for the mucocele of the appendix. This is not my video or not my finding. This is from some Chinese paper. Complete resection. This was the villous adenoma at the opening of the appendix in the cecum. So complete this particular area was full thickness resection was done. Full thickness resection was done, and then it was the rent was closed with the help of the clips, and the loop was applied over it. This is the specimen, and this is the histopathology. So this type of pathology can also be done. This particular video was seen in Sages, USA. दादा हे पहा ना काय होतं आता इथे रन होत आहे तिकडे नाही होत आहे मी थांबवला आहे व्हिडिओ This particular video was seen when Praveen sir was also there. Yeah. थोडं अवॉइड कर यार या गोष्टी कारण तसाच वेळ कमी आहे. So colonoscopically appendicectomy, how that is to be done, that aperture was reached, balloon dilatation was done, complete debris was removed. A standard balloon 12 millimeter size with pressure of around 6 to 8 was done. And the post dilatation, then a strong foreign body forceps was used to retract it. We did some modification and we did apply, we had a patent about that particular forceps also. We applied vacuum to the cover of that forceps, and that vacuum helped a lot. We have devised one more forceps with multiple prongs coming out inside. That is also patented now. We have completed 11 procedures now of colonoscopic appendix. And this strong pull at the tip of the appendix will pull back the whole of the appendix into the cecum. The pull is such a grade that I was going towards the hepatic flexure when traction was given over the loop. So the whole of the appendix was coming into the lumen of the cecum. You can see the pus also coming there. So these are the various reasons the younger generation should take up the endoscopy training properly. So I am at the level of the hepatic flexure now, and whole of the appendix is there. Now the trick is how to insert a loop there with a single channel. So double channel colonoscope is very handy here, and it can put the loop at the base and it will slough out. With the pre-cut knife we used for ERCP, we can cut the appendix also if you are suspecting some histopathology there. So that double channel will help. And then we know that if hepaticojejunostomy is done and if it develops some stricture or stones, how that is to be tackled. Again, laparoscopy and endoscopy combination is needed here. The osteal stones. Dada, ha video run kar. तुझ्या इथे रन होत होता काढल्यावर
व्हिडिओ आहे का?
हाँ वीडियो है
नाही सर फोटो आहे
नहीं फोटो नहीं है वीडियो है okay I will come back to this Peutz-Jeghers syndrome. This was again awarded best video for in SAGES. We did this by open surgery. We inserted endoscope and 2 ports here, did pneumointestine and the multiple polyps. We used 45 centimeter long instruments, and over that all the polyps were removed from small intestine and large intestine both ways. More than 56 polyps were removed. So this can be done with the endoscopy also, but it takes lot of time and it takes multiple sittings also. All this thing is done in single sitting and with proper hemostasis, because I am using harmonic scalpel there. So all the this vision is of the endoscope, and 2 ports are there for CO2 insufflation, and the hand instruments 45 centimeter long. The small bowel was threaded over the telescope, endoscope and the instruments, and the complete small bowel from DJ flexure to the ileocecal junction. I had to do enterotomy at 2 places. So that is how in Peutz-Jeghers syndrome we did 2 cases like this. So bit by bit and proper hemostasis done. No need for any endoscopic procedure. Each polyp takes lot of time in endoscopy. This is very fast procedure. We completed the second procedure in 130 minutes only. So after that, all the polyps were milked out from the enterotomy and sent for histopathology. This is how all the polyps were brought out at one place and removed from a small opening, and that enterotomy was closed. So the morbidity of the procedure was negligible. Patient went home on 3rd or 4th day, I think. Bleeding Meckel's diverticulum. There was small bowel was bleeding like anything. CT angio was inconclusive. So laparoendoscopy helped us. We did open surgery at the end when we identified the cause and examined that really the bleeding was from the Meckel's diverticulum and did the resection there. In stump appendicitis, the incidence of the stump appendicitis is increasing definitely because of the surgeons who are doing in their initial stages laparoscopic appendicectomy. So searching for the stump appendix is a difficult job because of the previous surgery adhesions. So what we are doing, we are instilling the dye, radiological dye, as well as ICG inside the lumen from the cecum side. And if it is, and then laparoscopy is done. It glows and with the ICG in near infrared imaging like this. So it becomes very easy to search for the stump appendicitis. In fistula in ano, endoscopic tropies, everybody now knows what is this tropies. It is transanal opening up, transrectal opening up of the intersphincteric space. The dilatation of the internal opening is done. There is no external opening in this such type of fistulae. And then the flexible endoscope is inserted there and the complete tract is ablated. This is the endoscopic view of the fistula. So there are n number of applications of the endoscopy in general surgery. So everything is ablated, curated, again ablated 2-3 times, curated thing is sent for the histopathology and gene expert, and the fistula recovers like anything without any damage to the anal sphincter. Here the patient was having a big fistula. हा पण व्हिडिओ नाही रन करत आहे तुझ्या याच्यात. This patient was having a popliteal abscess here running to the anus, and then the flexible endoscope was introduced from here, and argon plasma coagulation was done. ना वीडियो है वो. हाँ वीडियो है. बाहर चल रही हो. बाहर चल रही हो. प्ले कर. कांट प्ले मीडिया म्हणतात. हा लावतो का? So argon plasma is a very good tool for ablating the hello. मगाशी त्यांनी डाउनलोड केला, मी पुन्हा रन पण केला होता हे काढल्यावरती. ठीक आहे. Okay. So anorectal pathologies, anorectal fistulas, we have a very good application of endoscopy. So in around 3 months, 1 year. So this is the diagram which will tell you about how this was done. The flexible endoscope went in and did a complete ablation by the argon plasma. Because this video is very beautiful to see how this argon plasma works. याच्या आधीची स्लाइड आहे. Yeah, you can see here the flexible endoscope is going up to here, the air bubbles are coming here, and flexible endoscope is going in either direction, and then the complete fistula tract with abscess cavity is ablated in this way by the argon plasma. This is one of the very cheap source, far less cheaper than the conventional laser, which is the fad now. The complete fistula tract is beautifully ablated ablation curating is to be done 2 to 3 times in sequence. So this is how the patient responded. In 1 year, there was no fistula there. Small bowel strictures. This particular patient presented with 2 to 3 times admission was there because of the small bowel obstruction. CT suggested there were strictures in the ileum, but endoscopically there were very faint signs that there is stricture. Only creeping of little bit of fat was there. So what we did, we entered the small bowel by flexible endoscopy. We converted one of the port to 15 millimeter of port, and through that the flexible endoscope was inserted. See, this is the small stricture. Last 3-4 slides. तुम्हीच वेळ घेतला जास्ती. And ठीक आहे. So you can see from exterior there was not much of the evidence. We would have passed off that these are possible strictures, and it was not possible to take biopsy also. So we did enterotomy, dilated it, and then we entered through that particular wound by flexible endoscope. And you will be surprised to see the type of strictures. They were very tight. See, that was the reason why there were 2-3 admissions. This turned out to be on histopathology Crohn's disease. This particular stricture was not even passable, but from exterior it was not seen very well. We would never expected that this is the type of stricture inside. So from outside also the passage of the flexible endoscope can be facilitated with the help of the instruments of the laparoscopy. So the flexible endoscope is getting stuck there, so we can make the intestine straighten there, and this is how the cooperative endoscopic and laparoscopy surgery done. This was done for a patient. Patient had cholecystitis. Multiple laparotomies were done, and that particular patient had chronic pain. She did a suicidal attempt, burn over all over abdomen. So we did a transgastric cholecystectomy. We inserted the flexible endoscope, doing a gastrotomy from inside, and then a broken needle knife was used for the dissection, and multiple clips were applied at the calots for the cystic duct and the cystic artery. So this is the cystic duct, this is the broken needle knife. Here we get a challenge that we get an inverted image in flexible endoscopy. So in Strasbourg there was a lot of research going on how that image to be made straight. We did a simple thing, we kept the monitor upside down. And when I told them in Strasbourg that I did this and my problem was solved, they were so this is how very beautifully flexible endoscopic cholecystectomy can be done. And it is very heartening to see the gallbladder coming out through the mouth. We did transvaginal cholecystectomy, 72 transvaginal cholecystectomy in Bangkok. I am emeritus professor in Bangkok hospital there for notes. So we did transvaginal cholecystectomies. So this is how the gallbladder is coming out through the mouth there. But there the endoscope is anubis scope. Anubis is having 2 flanges, they open up at the tip of the endoscope, and through that the two instruments they go in. In median arcuate ligament, we know that the ligament is compressing the cystic trunk, celiac trunk. So we see endoscopically the flow, very small connection because of the compression, and then we do median arcuate ligament release. So this is the ligament release which we are doing. We did cut that complete ligament. We removed the complete ligament, made the celiac trunk free. This is the aorta in the right crus of the diaphragm. Right crus of the diaphragm muscles, they are opened up and aorta is exposed. The opening of the connection of the, then again we see the Doppler study, intraoperative, and now you can see a very large flow there. Cystic duct with stump stones. Many times this is the dilemma whether you are removing the complete cystic duct stones or not. So we do flexible endoscopy Doppler study, and we can see the stones there in the remnant of the cystic duct. So this is one of the reason of the post-cholecystectomy syndrome. And then we do conventional cholangiography, and we can see the length of the cystic duct which is remaining and the stones there. So we can remove those cystic duct stump and stones there and there itself on the table. So there should be high suspicion that your cholecystectomy, though looking simple, but whether you are done a complete justice or not. So this is how the stones were there in the long cystic duct which was remaining there. So we removed it then completely. Approach to laparoscopic CBDE. What is this CBDE? It is the CBD exploration, laparoscopic CBD exploration. I had a formal training in USA, SAGES. There was a course which ran through for complete 1 year. This is the special cannula which is needed, through which the complete cholangiogram is obtained. Very small stones, if there are less than 3.5 size of stones are there in the CBD, then there is no need of doing ERCP and removing those stones. They can be extracted out through the, this is the Olsen clamp which is needed, and this is how the transcystic balloon is going in and it is extracting out. This is the scope which is needed. Here the whole of the CBD was studied with the hundreds of stones. So we opened up that particular CBD. Multiple stones were there and put a flexible endoscope. And all these stones were snared out. We counted, they were 32. So we are routinely doing CBD exploration if the size of the CBD is around 9 millimeter or more. Less than that, it becomes difficult for doing this procedure. So you can see the interior of the cystic duct completely. You can do the balloon dilatation of the lower CBD so that there will be no stagnation of the bile. We put a stent, and after putting a stent, this is the balloon dilatation of the sphincter of Oddi. And after doing balloon dilatation, we put a stent, and we just confirm that that stent has really gone into the duodenum. Otherwise, the removal of the stent will be difficult. We need again an ERCP. So all the stones are removed, and this thing. So this thing can be done from the hepatic side also. If hepatolithiasis is there in second or third generation of the biliary tree, then they can also be removed by endoscopically very well. That is not possible by doing ERCP. These particular stones, they are very difficult to be removed by ERCP. So these stones are never faceted stones. This is called as oriental disease, and this has different reasons to develop these stones. It is the nutritional based problems. It is not cholesterol, and the things are not there. So all these stones can be removed from by flexible endoscopy from the hepatic side also. So take home message: use of endoscopy during open. So all surgeons should adopt 3 scalpel concept: the harmonic scalpel, the conventional scalpel, and the endoscopic scalpel blades. Thank you very much for this. Thank you. Sorry, I have taken a bit of time. Thank you. Thank you.
Thank you, sir, for this wonderful lecture. I would now like to invite on stage Dr. Mandar Doifode for management of Barrett's esophagus.
So actually after sir's lecture, I'm not feeling worthy of giving any lecture. Sir's lecture was so nice, I was enjoying it so much. I don't mind giving my time to him. He can show us more videos. Anyway, so before I begin with the lecture, I would like to congratulate Dr. Praveen sir and his entire team for successfully conducting this third ENDOSURG. And also I would like to thank him for inviting me and making me a part of this wonderful workshop. Now my topic is management of Barrett's esophagus. I know after sir's lecture this is going to be a little boring. This is more of a theoretical topic, but as every speaker before me has reiterated, we as a surgeon, we should be able to do a proper diagnosis of endoscopy, of GI elements which we can diagnose on endoscopy. So it is very important that we should understand the pathophysiology and management protocol of Barrett's esophagitis. We know because of the change in our lifestyle and change in our diet pattern, the incidence of Barrett's esophagitis is going up. And as a clinician, we must make every effort to understand the nuances of management of Barrett's esophagitis. So, what is Barrett's esophagitis? It is nothing but the replacement of normal esophageal, normal squamous epithelium of lower esophagus by metastatic columnar epithelium. And normally you suspect Barrett's esophagitis when this gastric mucosa, gastric epithelium extends beyond 1 centimeter beyond the normal G junction. So, these are the folds which make the upper part of the stomach, and if the gastric mucosa extends beyond 1 centimeter beyond this, then we can call it a Barrett's esophagitis. Generally, it is seen as a complication of chronic GERD. And why we should learn about this? Because if it is left untreated, it can progress to esophageal adenocarcinoma. So, in the pathophysiology, as we know, most of the patients of Barrett's esophagitis, they have a known history of chronic GERD because of reflux of gastric acid and bile through the lower esophageal sphincter. We know that stomach is lined by a mucinous columnar epithelium which can withstand the acidic environment, but esophagus is lined by a squamous epithelium which is not supposed to get exposed to the acid. And when, because of chronic reflux, when the acid gets reflux into the esophagus, this mucosa gets exposed to the acid, and because of that acid irritation, the esophageal mucosa will undergo inflammation. Continued exposure to the acid leads to persistent inflammation, and there will be change in the mucosal pattern, and it will show columnar metaplastic reaction, and sometimes it can show eventual development of intestine like goblet cells, and that is classically called as Barrett's esophagitis.
And in some patient, there will be some genetic mutations, and this metaplasia will progress to dysplasia and sometimes can lead to adenocarcinoma. So in epidemiology, generally the patients who have chronic history of GERD, they will develop Barrett's, but about 0.8% of the people who develop Barrett's, they show no history of GERD. There are certain risk factors. It is more commonly seen in males compared to females. It is seen more in older age group. Above 50 they show more chances of development of Barrett's. There is a strong association with central obesity, and smokers have higher chances of developing Barrett's esophagitis. I couldn't find any references which was linking Barrett's with alcohol consumption, but we can say that if you are a chronic alcohol drinker, then the chances of gastric acid secretion will be high, and that can lead to increased incidence of Barrett's esophagitis. That's why if a patient is having Barrett's, it is a better idea that he should reduce his alcohol consumption and he should stop his smoking also. The incidence, as I said, is about 0.8% of normal population can also show Barrett's, but the incidence will go up to 3 to 5% if there is history of GERD. And the risk will go up by 12% if patient has GERD with any of these risk factors. And the incidence will go up to 25% if there is family history of Barrett's esophagitis. That's why if the patient has chronic GERD and 2 or 3 of these high risk factors, then that patient is considered to be high risk of developing Barrett's, and she should undergo surveillance endoscopy. So why surveillance? That because the journey from non-dysplastic Barrett's to adenocarcinoma will not happen overnight. It has to go through series of changes from low-grade dysplasia to high-grade dysplasia, and sometimes high-grade dysplasia can progress to intramucosal carcinoma. And all those stages can be diagnosed by endoscopy. That's why doing surveillance endoscopy is very important in these patients. So most of the patients with Barrett's will show the symptoms will be similar to GERD. There are no specific symptoms of Barrett's. The GERD symptoms like retrosternal burning, regurgitation of acid will be shown by these patients also. Some patients may have dysphagia, sore throat, hoarseness of voice, etc. And some patients will be completely asymptomatic. So the best diagnostic test is upper GI scopy. If you see this, this patient had a chronic history of GERD. When I did his scopy, I could see tongue-like extension of the gastric mucosa above the Z line, and this is a classical picture of Barrett's esophagitis. Now this is a picture of white light. When you add NBI, suddenly the things become more prominent. So NBI will make even the subtle changes more prominent. That's why you should have a NBI with you, so that these changes can be easily picked up by you and you will not miss these changes. Another advantage of using NBI is it will show us whether the patient has hyperplasia or not, dysplasia or not. Like this patient had Barrett's esophagitis. You can see regular pits with regular vasculature. So these are the signs of no dysplasia. So this patient definitely has Barrett's, but there are no signs of dysplasia. As against that, this patient, if you see, you can see there is complete absence or irregular pits and irregular vasculature, and these are the signs of dysplasia. So this patient is having dysplastic changes, and if you take biopsy of this patient, then you will detect dysplasia in this patient. So we are surgeons, so my sincere request to all of you is, please invest in the instrument. Your your reporting quality should not be inferior to gastroenterologists. So when you start your practice, start with these better scopes. They are little costlier than normal scopes, but the cost is not prohibitive. So when you start practice, please go for higher end of scopes. This is a video. I'll skip that video. Now, when you see Barrett's on endoscopy, you should do proper reporting. And for reporting, we use what is called as Prague classification. It is a standardized system used to measure and describe the extent of Barrett's during endoscopy. And it uses two measures. First is C. C is for the circumferential extent of the Barrett's. This measurement indicates the length of Barrett's segment that forms a complete ring or circumferential involvement around the esophagus, and it is measured from the GE junction to the highest point on the circumference of the Barrett's. Like here, this is the GE junction and this is the uppermost part of the circumferential part of the Barrett's. So this is one, and the other component is called M. M value is for maximum. It is the maximum extent. This measurement represents the total length of the Barrett segment, including any tongue-like projection like this. So it is also measured in centimeters. So now with this patient, he had C, the G junction at 40 centimeter, C at 39, and M at 36. So reporting will be made as Barrett's esophagitis with C1, M4. This is how you should report. So this classification helps in assessing the risk of esophageal cancer also, because the longer the length of the Barrett's, higher are the chances of malignancy. And another advantage is the reporting will be standardized. If the patient goes to another endoscopist and if he sees your report, then he will be able to compare his findings with your findings. And another important thing is taking biopsy. Even if you find Barrett's and on NBI you feel there is no dysplasia, you have to take biopsies. And for biopsy also there is a proper protocol that is called a Seattle protocol, where we take 4 quadrant biopsies every 1 or 2 centimeters. In addition to that, on NBI, if you find any dysplastic element, then you have to take biopsy from there. Now, once you diagnose this case, then the most important part is of the management. So the management will depend on the stage of the illness. If you find no dysplasia but there is Barrett's, then you should advise the patient some lifestyle modification and start him on some medical management. And the patient should undergo surveillance endoscopy every 3 to 5 years, depending on his other risk factors. As against that, if you find there is low-grade dysplasia, again the medical management is important, but here the endoscopy repeated at least every 6 monthly or at least every yearly. You can also give option of endoscopic ablation to that patient. Now, if the patient has high-grade dysplasia, then you have to resect that Barrett's segment. You can either go for endoscopic resection therapies, which I'll describe in a minute, or the patient can undergo surgery also. And if the patient has invasive adenocarcinoma, then the patient has to undergo surgical management. So, what is the medical management part? First and most important part is the lifestyle changes. Patient has to lose weight if he is overweight. Patient should avoid late night meals so that the acidity will go down. He should have head end of the bed elevated while sleeping. If he is a smoker, he should completely stop smoking and he should reduce his alcohol intake. Now in pharmacotherapy, proton pump inhibitors form the major part of the treatment. They are mainstay of the treatment. They will give symptomatic control to the patient and they will also reduce the progression of the disease to dysplasia. You can choose amongst the various available PPIs like rabeprazole, pantoprazole, or esomeprazole. Almost all of them have equal efficacy, and you can choose depending on your availability at your center and your choice. The newer PPIs like vonoprazone or fexuprazone, they are also effective, but they are more effective in symptom control. How much they are effective in cessation of the dysplasia progression is yet to be studied, but you can definitely use them because they have a better symptomatic relief to the patient. Now, as I told you, if the patient has low-grade or high-grade dysplasia, that Barrett's segment has to come out. So there are various techniques with which you can resect that, and the commonest which we use nowadays is called EMR, or endoscopic mucosal resection. This is a principle where the lesion is here. You have to inject methylene blue with normal saline and elevate that off the submucosa, and using a snare which we use today, you can resect the entire thing. Once you resect everything, you will see something like this, and slowly this will heal with fibrosis and the entire Barrett's segment will come out. Even if here you see only one tongue of the Barrett's, but even if the patient has circumferential Barrett's, you can resect that entire segment using this technique. The advantage of this technique is you can resect the part so that that part is available for histopathological examination. There are other endoscopic techniques like radiofrequency ablation or cryotherapy, APC. All these three things are easier to do compared to EMR, and the chances of perforation are also minimal if you use this technique. But the disadvantage of all these three techniques is you don't get the tissues for histopathological diagnosis. That's why my personal choice is to go for EMR. Lastly, the role of surgery. If there is invasive adenocarcinoma or high-grade dysplasia, you can always give the option of esophagectomy to the patient. But you will all agree that this procedure has a high morbidity. So this technique should be reserved only for those cases which are not amenable to endoscopic therapy. Now, what is the role of anti-reflux procedures? There are various anti-reflux procedures which we can do. If the patient has a small hiatus hernia, we can do what is called as endoscopic procedure known as arms. Here, this patient had a moderate size hiatus hernia. So, I'll just let the video run on the background. So here we if you see in this diagram, we resect a portion of the gastric mucosa very close to the GE junction. About 4/5 of the circumference of the mucosa is resected using EMR technique. And once you resect that segment eventually will heal with fibrosis. And because of the fibrosis, the tone of this LES will improve, and that will give symptomatic relief to the patient, as well as it will reduce the chances of reflux, and that will help in reduction of the progression from metaplasia to dysplasia. So this is called ARMS procedure, anti-reflux mucosectomy. Same thing we can achieve by using a laser or APC, that is called ARMA, anti-reflux mucosal ablation. Same, you can ablate this entire mucosa. This after ablation, this mucosa will heal with fibrosis, and the patient's reflux will be reduced. Or if the patient has a large hiatus hernia, you can of course go for proper fundoplication. But mind you, with all these procedures, they will definitely control the reflux, but they may not reverse the Barrett's esophagitis, and at the same time, that will not eliminate the cancer risk. And this patient definitely will require lifelong survival even after successful ablation or successful anti-reflux therapy. So in summary, I would just like to say that Barrett's esophagitis is generally seen as a complication of chronic GERD. It is a pre-malignant condition, that's why you have to treat those patients. Risk stratification and surveillance are essential, and endoscopic therapy is definitely effective if the patient has only low-grade or high-grade dysplasia. But if it goes beyond that, then multidisciplinary approach is definitely important for optimal care of the patient. Thank you. So, if there are any questions, I would be happy to answer those questions.
Development of stricture after arms?
Stricture, because we don't resect the entire circumference, we leave behind almost 1/5 of the circumference of the at the GE junction. So stricture will not form.
Okay.
So one of my patient, she developed little bit of dysphagia, but there was no recurrence. So I did her manometry also, barium, everything was done. There was no mechanical block, but still patient has a little bit of symptoms of dysphagia. But those I think more are functional symptoms. Thank you.
Thank you so much, sir, for this wonderful lecture. I would now like to invite Dr. Unmesh Takalkar, sir, to present a PPT on assessment and management of esophageal varices.
Assessment. Good evening to all. First of all, I'm thankful to Bhaskar and Praveen Suryavanshi for giving this opportunity in this wonderful evening. So we are surgeons, and this common topic, which is esophageal varices and the gastric varices. So we are here to discuss. So we will not go in details about the liver part of it or some pathophysiology and all. So quickly we will see that what are the esophageal varices are dilated tortuous veins in the esophageal walls, which are secondary to increased venous pressure of splanchnic venous blood, which is or superior or inferior vena cava, or pre-hepatic, post-hepatic and post-hepatic. So they are prone to rupture and likely to cause massive hemorrhage in the intestinal tract. Normal pressure of portal vein is 5 to 8. Then it is, when it is 7 to 8 mm of Hg, it is called as hypertension. When the symptoms of this pressure goes below 12, then they are likely to rupture. But if you see the pressure is more than 12, then they will rupture, and more than 20, there is a poor prognosis which is associated with esophageal varices. So they present in 30% of patient in compensated cirrhosis and 60% of patient with decompensated one. First bleeding episode is mortality rate of 10 to 30%, recurrent bleeding risk of almost 70%. And etiologies, we all know portal hypertension, pre-hepatic, hepatic and post-hepatic, and liver cirrhosis and compensation of liver issues. Decompensation is a main problem for esophageal varices. Risk factors: significant portal hypertension, large varices, red marks on the esophageal varices, severe cirrhosis and liver failure, and continue to use alcohol, which will result into, these are the clinical manifestation: hematemesis, melena, then signs of hypovolemic shock, history of alcohol abuse and deterioration of mental health, and complication into you can say hepatic encephalopathy and other complications of cirrhosis. So when we grade these varices, grade 1 is which is inflated by insufflation and flattened by insufflation is grade 1. Not inflated by our gastroscopic insufflation, and the separated areas of healthy mucosa is grade 2. Varices are confluent and not flattened by inflation, and they are just touching each other. This is grade 3, and one of the grade we can add it to is when they are on a red-on sign, when there is a spot on the red spot, then they are prone to rupture. This is gastric varices are divided into two parts, whether you can see GOV, GO2 and IGV and IG2. When the gastric varices are in continuation with esophageal varices down here, they are called a GOV1. GOV2 is on a fundic side. This is on this side of the stent, and GOV is independent of esophageal varices. They are on either on the fundus or on the pyloric region. So what you should have when we manage the esophageal varices, top 10 we must have is ICU, close monitoring systems, ABC of the volume repletion and all basic intubations, IV somatostatin. These are the analogs of octreotide which are useful for stopping, reducing the blood, splanchnic blood flow and reducing the portal pressure, which will eventually lead into some of the blood which is stoppage or reduction in the portal pressure, and ultimately it is giving to less bleeding. So antibiotics, ceftriaxone is the most preferred choice. Prokinetic agent, blood transfusion, endoscopic therapy, band or glue, possibility of esophageal stent. This you must know when there is a recurrent bleeding, when the esophageal varices are not getting under control. So we put in a fully covered stent. Eventually I will show you the video, and tips which is in an early position. And initial management, IV access, vasoactive therapy, IV antibiotic, blood transfusion. The most important thing is excessive volume in the varices are known to cause, means not beneficial. So you have to keep the hemoglobin is around 7 to 8, and when the hemoglobin is 6, 5, 4, 3, then you reach up to 8 and then band the patient. You don't allow it to go to 9, 10 or 11. That is not showing beneficial, and the studies have shown that. Then avoid shock, which will prevent ribbon failure. IV erythromycin we usually not give because not easily available with us, but lizoride or these agents are useful. Intubation if it is required. Then strategy of the patient, we have to consider high risk patients, which are the high risk patients, and tips candidate we have to identify as early as possible. Then these are the things which are octreotide, how it is to be given. 50 microgram bolus followed by hour infusion. Then terlipressin, this is to be given in IV, as well as terlipressin, many of the things sometimes we can give subcutaneous also. So terlipressin 1 ml subcutaneously 8 hourly is also an effective way of controlling it. Then contraindication is coronary artery disease. Side effect of vasopressin is same, myocardial and extremity ischemia, cardiac dysarrhythmias. We have to keep in touch with that. Beta blockers, so cardiolol and propranolol as we always use for prophylaxis, so everybody gives. Nitrates hardly we use. So initial resuscitation, these are the pros and cons. Protect airways, administer the deep sedation, and this is basically to control the bleeding. And endoscopy, when is to be done? So it is to be done at least in the first 12 hours of admission, and it has to be done with the sedation, anesthetic standby, with full volume access in our hand, and then diagnosis of esophageal varices is to be done, and complete assessment of varices by the most important thing is when you put in a patient on a sedation, and the adequate sedation and pulling up the just passing the post-cricoid, you have to have adequate sedation, or intubation is there, then there is no issue, and see the varices go down, and assessment for the pylorus, and come back again, see the gastric thing, whether patient is having gastric varices, and then esophageal varices is to be managed. So initially we used to have a sclerotherapy treatment for esophageal varices, but endoscopy nowadays we all use endoscopic band ligation. Sclerotherapy, as you know, the thrombosis, inflammation causes scarring over that. Injection ethylamine oleate and sodium morate these are the injection used for sclerotherapy. This is usually used post recurrent bleeding, which after the, suppose there is a bleeding after the band ligation, and then sometimes this is very helpful by putting a ethylamine oleate in that region. So band ligation is a permanent placing of an elastic band which occludes the varix and causes thrombosis, lead to necrosis of the mucosa, and after some days the band will fall off, and the ulceration of the mucosa heal with the eventually scarring or fibrosis. This is the mechanism where it works, and 85 to 90% of the cases this we follow. This is the band. Now we have various types of band, Wilson Cook, Boston, and the bands which come with the various prices, low, high, but many good quality of band which will not slip is a recommendation of the band. They have come with the they come with the set also, they have come with the individual also. So this is the thing which is we do. We put in a scope inside, which is band is loaded with that. Go inside the stomach first, go to the GE junction, then leave some part of the GE junction that will obliterate, then suck the varix. This is called as red sign. And after this sucking the varix, can you see the band there? So band is put on the varix there. This is the second one. And this is the third one. So we can go on putting this band. The maximum band which can put is around 6, 7. Up to 10 also they are described, but the 6, 7 bands we put it, because this comes in a loaded with the band, and there is a one set of a band which is different color, so that when you finish 4 or 5 bands, then afterwards you come to know that we have fired 4 bands and there's only 1 or 2 remaining. So what are the precautions to be taken is gentle on intubation. Episode we must means flushing and apply the suction, and band should be fired when the red on sign is there. There are many incidences when we fired the band, the varix is not caught inside and it slips off, and there is some trauma to the varix and it goes on bleeding. Torrential bleeding, then once bleeding occurs, we cannot see anything. So this goes on bleeding, and then you have to suck, and then you have to see again, and then sometimes you have to use a blind technique and fire the band, so that sometimes it works. So how many bands? At least 6 to 7 bands. So sometimes there is a treatment failure of variceal bleeding. After 24 hours, patient rebleeds again. And sometimes control of bleeding after 24 to 48 hours, after say 1 or 2 days also. So what are these things? What are refractory bleeding? How to deal with the cases? So you must be ready for this refractory bleeding. Again, first choice is endoscopic therapy. You see that whether we can left some varices or we can rebland it again. Then again, then several different approaches are described. One is endoscopic therapy. Second is we have used in our general surgery practices sense taken Blackmore tube, gastric varices and all this, the tube which is there, you put in inside, then inflate the gastric balloon, then put the esophageal balloon and put the pressure. These are the temporary measures so that it will press over the varices and the varices bleeding will stop. The most important thing is esophageal stent, which I am going to show you the video, and tips and liver transplantation. So tips is intervention radiologist job, from where the internal jugular vein, the vein is accessed, and there is a shunt between the internal IVC and the hepatic vein, so that the pressure in the hepatic vein is transferred to the IVC and the pressure in the system is reduced, so that, but the chances of being transferred the venous blood, there is a chances of increased hepatic encephalopathy also. So repeat endoscopy, these are the reports where we can use very rarely. If bleeding is mild after the esophageal varices, we can use hemospray. Sometimes this works because there is some partial scarring after 3 to 4 days, the band is slipped off, and we use for the gastric or bleeding things when large volume is there, the spray is also used. Sometimes the reports are not so encouraging, but sometimes we also use cyanoacrylate glue also. So this is the hemospray after the endoscopic band ligation, and sometimes they show very good results. So cyanoacrylate glue also been described in a recurrent bleeding of esophageal varices and can be used as an alternative method. So sometimes this tamponade which is there, which I have shown sense taken tube, you can see the esophageal gastric balloon followed by esophageal balloon, which has got three irrigating channels. One is a suction, one is irrigation, and this is a temporary bridge. So you have to be aware that if you inflate this in a very high pressure, then there is a rupture of esophagus, tear of the esophagus, and perforation of the esophagus stomach also can occur with this. So these are the X-ray images of this, and this is the esophageal stent, which is a completely covered stent, which causes a balloon tamponade in the esophagus and direct compression of the varices, and we have to lock that stent with this thread and remove the stent also. It is a special method which we described. Now this is a stent which is this is the measurement of the stent which is being given here. This is almost 26 mm of diameter, or whatever, 186 mm, which is there in the length and diameter, and highly effective and safe. But this has to be there for 7 to 10 days, and this is a bridge for the alternative therapy. So this is the expandable stent. Pilot studies has shown a very encouraging results. So this is the ELA stent, Danish ELA stent. So when you put this stent, this is a bleeding which is occurring from the varices, and the stent is fully covered, which is sitting over the varices, and it is covering all this. And when we give a conservative line of treatment, this will work very effectively. Now this, when you remove this stent, because the varices are already there, if you directly pull it, that stent is likely to cause a rupture of some of the minor varices in the esophagus. So we have to use a overtube. Overtube which is used to, so when we remove the foreign body, it is like then the stent has to be removed with the overtube, so that the trauma to the varices is not there and no bleeding is there. So these are the UK guidelines for endoscopic management of bleeding. So over-transfusion, as I told you, these are studies which have shown that over-transfusion leads to higher mortality. Then by cyanoacrylate glue, so we are going to the gastric varices now. This is a very interesting thing. So cyanoacrylate glue is the most important thing in gastric GOV1 and GOV2. So these are the, you can see the gastric variceal bleeding, and this bleeds very torrentially. So there is a special technique which is not described in the book, but the cyanoacrylate glue is likely to damage our scope, likely to be there in the scope channel, and that if that remains in the scope channel, your scope is gone. Almost you lose, because it is very difficult to repair that scope. So what we do is, when the cyanoacrylate glue is injected, we inject the cyanoacrylate glue. Once it is pricked, you have to just push it, and after pushing you have to give saline or lipodol, whichever is the agent, again after that needle, and don't suck it, because if you suck it, everything will go in a suction channel and it will damage the scope. So you have to remove the scope and everything assembly in one go. So when we inject it, we asked our assistant to remove the suction tubing from the system. So he's there and he just removed the suction tubing. Undoubtedly also we push the suction button, then the scope is gone. So this is the trick we which use. So what is the problem of this gastric varices is size. When it is large, then risk factors is very high, medium, large, child class, and endoscopic presence of red spots. So these are the things which have been shown. So again, I have shown you the classification of this. So what you do in fundal varices, same thing as resuscitated we do in the esophageal varices, and we use cyanoacrylate glue for the injection, which is a very standard one. Sometimes you can use band also, and the new technique which has come, which I will show you, this is the intervention radiologist which for gastric varices, transjugular transhepatic portosystemic shunts, this is called as TIPS, and this is very commonly done but very costly for the patients, and it has to be done in a very competitive setup where you can identify all these things, intervention radiology, then the ultrasonologist, and this combination of the techniques which we put into the liver as well as in IGV. Now this is the called as BRTO. This sometimes we have used 3 to 4 cases here when we cannot go from the esophagus, or we have a shunt which is from renal vein to upstairs in the you can say in a gastric varices. What we do is the wire goes from here it will go to renal vein, from renal vein it will go up, and from the gastric epiploic veins are accessed from renal vein. So from renal vein they go up and they inject or they obliterate embolization or sclerosant inside, and this is a very effective technique. Sometimes there is a stricture or we cannot go in the esophagus. Sometimes there is a associated cirrhosis with cancer esophagus. Then you cannot go and band, or you cannot go inside the stomach. So this is the technique where we used. This is again a GI bleed. So what we use is cyanoacrylate glue. What are the banding, then sclerosant, and this. So this is Dr. Sareen, which you must be knowing from Delhi. He has got the largest series on this. So this is a cyanoacrylate glue plug, you know. When you use cyanoacrylate, this is shown like this on the X-ray. So this becomes a solidified, and this is the thing which is there inside. Now this is the thing which we inject, and sometimes you will see the bleeding after the injection also. So you don't have to worry about this. Sometimes after bleeding also it bleeds, and don't have to panic about this. Eventually when we did a scopy after this, it stops. So this is the again cyanoacrylate glue study. Now new development in a glue injection is a combination of endoscopic ultrasound along with the coils and along with the glue. So this has been firstly done. One of the first was, he was there for our conference last year, Kenneth Binmoller, he's from San Francisco. So he has introduced this system that you can go with endoscopic ultrasound here, put in a coil, and along with the coil you inject the glue. So that becomes a solidified structure in the stomach, and then the bleeding stops. So after 6 months after post glue injection, this is the thing which is completely obliteration of the you can say gastric varices. Now this is the thing which you can see. This is a coil. You can see this is a coil from the endoscopic ultrasound accessories, and this coil is coming up, and this coiling is getting deployed. Next का नहीं play होता है. Next, you have to play this video. No, this one.
Automatic play.
No, it's not getting played. This is very interesting. Whenever there is a cyanoacrylate glue which comes in a contact with blood or water,
त्याच व्हिडिओमध्ये कंप्लीट झाली की खालचा व्हिडिओ प्ले होईल
Anyhow, this is the thing which is showing like what I've shown you, like a coil with glue. They will form like a rock inside. So this is again EUS guided thing which has been there along with the coiling and cyanoacrylate glue. Can you see the name of this? Kenneth Binmoller from San Francisco. So the needle has come inside and the coil has been deployed here. And then glue again, the injection has come inside, and this becomes a solidified structure inside the stomach. So as algorithm, acute variceal bleeding in cirrhotic patient, resuscitation, followed by gastroscopy, find out whether it is esophageal varices, then it is gastric variceal bleeding. Then esophageal variceal, band ligation, control the bleeding, secondary prophylaxis, failure to control the bleeding, again balloon tamponade or whatever methods we have seen. Then gastric variceal bleeding, cyanoacrylate glue, secondary prophylaxis is again cyanoacrylate only. And then if it is a rebleeding, then assess the other method. And if it is a rebleeding, then TIPS or a liver transplant. So this is the algorithm for this one. And this is the management of gastric fundal varices, take-home messages. The problem is 10 to 20% of variceal bleeding. Incidence is bleeding is 25%. Cyanoacrylate glue is a common standard method of treatment, and interventional radiologist TIPS and Brito is available whenever it is required. And US guided coils and glue are now not a future. This one it is recently it has been practiced. Thank you so much, and we are organizing this GI Vision 2026 on 25th and 26th of April. So we are requested to join this conference. Thank you.
I would request Dr. Rajendra Shinde sir to come and felicitate sir with a floral bouquet.
Thank you, sir. Thank you, Shinde sir.
Thank you, sir, for this wonderful lecture. I would now like to invite Dr. Advay Aher, sir, to present control of non-variceal bleed.
So, good evening. I know this is the last lecture, and most of you must be feeling it ha azun bakiच आहे का. So this is my talk is control of non-variceal bleeding. So I would be not going into the theory, but non-variceal bleeding is upper GI bleeding without in a patient without any portal hypertension. It is one of the most common cause of medical emergency, and the incidence is around 50 plus per 50 to 150 cases per. So defining non-variceal origin bleed, whether the prevalence accounts for approximately 80% of the all upper GI bleeds, and common sources include peptic ulcers, erosions, malarious tears, and others. So this is again the risk factors include NSAIDs use, H. pylori infection, alcohol use, smoking, and anticoagulant therapy. This is a very busy slide. I will not go into this, but it is usually either the NSAIDs which erode the mucosa and cause ulcers, or the H. pylori. So we will skip it. Clinical presentations, hematomasis, coffee ground bright vomitus or coffee ground colored vomitus, melena, and hematochezia in severe cases. Already Dr. Takalkar have talked about this. Initial assessment is ABC, we need to protect, and administer IV fluids. Here there is no role of any terlipressin or sort of things or octreotide. We just have to inject high dose PPIs. Basic laboratory investigations like CBC, coagulation profile and liver function test and blood transfusion. Resuscitation, again I will not go into this. So the gold standard is diagnostic and therapeutic endoscopy. The purpose is to pinpoint the bleeding source, classify and manage the bleeding. Success rate is almost around 90 to 95% with effective treatment. So what about the timing of endoscopy? Early endoscopy is what is recommended because it gives time for stabilization of the patient. Of course, urgent endoscopy less than within 12 hours for very high risk patients or those who are bleeding very torrentially. The endoscopic modalities are injection therapy, thermal coagulation, mechanical clips, but usually combination therapy has a success rate of more than 50%. Combination is either we have to either combine one of them, two of them or three of them. So we will primarily go with through some videos. So this is a case, first case, 74 years elderly gentleman post PTCA with double anticoagulants presented in ER with coffee ground vomiters, initial resuscitation done, drop in HB by 2 grams, planned for an upper GI SOS intervention. So this was a case of Mallory Weiss tear. So initial upper GI endoscopy we did it under mild sedation because we didn't wanted the patient to retch. So you can see this is clearly Mallory Weiss tear, but which is very cold and silent. So we were reluctant. We were almost about to abort the procedure. But what I thought, we will just inspect the duodenum once. But once we did some manipulation of the scope, this notorious thing started bleeding. And since the patient had to be started on anticoagulation therapy early, we decided to clip it off. Here we can try injection adrenaline diluted, but since he was some coronary artery problems, so we decided to mechanically clip this. Though this was a very cold case. Cursor. Hey, cursor can you? Okay, these are short videos, not more than 1 or 2 minutes. We will finish it off early. So this is how we can clip it. This is an interesting case. An elderly gentleman post PTCA, again DM, hypertensive, diabetes mellitus, hypertensive on regular treatment, swallowed an anti-diabetic tablet with the wrapper accidentally. He approached his regular physician for the same and advised to have banana and continue with regular treatment and diet. Okay, 24 hours later, this gentleman presented with dark colored vomitus. After initial assessment, which was normal, he was subjected to a diagnostic gastroscopy. So this was the video. So here we can see that wrapper, which was very sharply cut, and he swallowed that tablet anti-diabetic medicine with the wrapper, and it had caused erosions. And then we sedated this patient again. We removed this with a foreign body rat tooth forceps. See, it was very sharp. It was cut into single tablet by his wife so that he doesn't skip any medicines, but he swallowed it directly without opening it. So we removed it. So checkscopy, we were really afraid. It was a scary situation. The esophageal mucosa was badly injured. So we went into the stomach, and then while coming back, see, you can see that there is almost a full thickness perforation caused by the wrapper, and there was a lot of bleeding which was causing. So again, what we did is we thought of closing these defects with multiple clips. So mucosal clips. So can you appreciate that? I have a pointer. So this was the defect. So we used these larger clips to close the defect. Unfortunately, the setup where I was doing this, I didn't had a cap, so I was struggling for space. So these larger clips, they have a benefit that once we close it, see the other edge was slipping. So again we open. This can be closed and opened before firing. So these are very good clips which are we should always keep in our armamentarium. And then we applied the first clip here. And then serially we applied 3 more clips, put in a guide wire by the side of the clips and inserted a rice tube for his feeding, kept him NBM for 8 days, did a CT scan of course post-operatively, and after 8 to 10 days we did a dye study. We showed no leak. We removed the rice tube and the patient is on full diet now. Third case is a 53-year-old lady presented with hypotensive shock and melena. Hypertension, diabetes mellitus, anticoagulants. She initial resuscitation, we were subject for gastroscopy. This was a gastric polyp. You see there is a large G junction polyp which was bleeding. So we decided to do a polypectomy. We injected the base with diluted adrenaline 1:20,000. See, after injection there was some ischemia which happened to the tip of the polyp. It was a pedunculated, but the pedicle was quite large. So this was the polyp and this was the pedicle. Fortunately, we didn't had any immediately bleeding like today we saw. And we clipped the base. The base was secured, and this was around 5 centimeters polyp in the stomach. So this is another case, a young male 30 years of age presented with anemia, hemoglobin was 7, lethargy and abdominal discomforts, stool local blood was 2+, no addictions. Diagnostic colonoscopy done at a peripheral center was normal. Gastroscopy done at our center suggestive of a small neuroendocrine tumor in the body of the stomach. So what we did, this was a small lesion in the body of the stomach. This is how we applied a band here to get the deeper area. And then this video I am trying to show purposefully so that we can doing this band EMR technique is not very hard, and it can be easily, our regular bands can be applied using a regular band barrel. You just suck in that lesion, apply a band below over it, and below that band you start cutting. Unfortunately, I am not getting a cursor here so that we could have fast forwarded it. So this is how we go below the band and start cutting with an endo cut. See, we get good deep resection margins, and the specimen was out. Now this was another interesting case. 55 years old surgeon had underwent a laparoscopic gastrojejunostomy. He was okay. Day 2 early in the morning he called me up, rice tube aspirate was frank blood. He had episode of giddiness, no episode of frank hematomesis. He was taken up for urgent gastroscopy under GA. I am sorry, but this video was 65 GBs and I couldn't edit it in any editor. Let us see whether it plays. So this there was a very large blood clot of around 1.5 liter in the stomach. This is the gastrojejunostomy site edge. This was bleeding. Can you appreciate this is this entire area? This was bleeding. Only one edge of the GJ was bleeding. Other circular, it was very much healthy and patent. But this edge was bleeding. It was a stapler anastomosis, gastrojejunostomy. What we call that? There is another stapler now which you use, means there is a spring or something, controlled stapler that was used to prevent this only. But then also this happened. So we clipped it. When I was doing this procedure, 20 other surgeons were standing behind my back and saying, "For ikadna blood bleeding hota hai, tikadna bleeding hota hai." But then after first clip application, the things become easier because the bleeding had stopped. Then again serially we clipped the entire bleeding edge of this corner. So now the things were getting cleared and everybody was, so this is how we clipped it and nothing, the patient did well. He didn't require any other intervention. So clipping, we should learn, we applied around 5 to 6 clips around that edge and he was okay. 55 years old male, diagnosed case of CA pancreas, post-EOS, ERCP, metal stenting, PET scan suggestive of metastatic disease, received chemotherapy and radiation therapy, presented in ER after 15 to 20 days of radiation and with hematomesis. So this was the picture. This is very rare. I have seen it for the first time. Post-radiation gastric telangiectasia, which were bleeding very heavily. So as sir said, argon plasma coagulation becomes very handy here. We did argon plasma coagulation and the patient survived, was stable. Another patient, 35 years old female, presented with abdominal pain and anemia, pain radiating to back, stool occult blood 3 positive, gastroscopy and colonoscopy done outside was within normal limits. We did a gastroscopy and with narrowband imaging and high intention white light, we can see a small duodenal ulcer, but when with NBI, we could see that it was a bleeding duodenal ulcer. So we just clipped it and after 15 days, the stool occult blood was negative. So this was the most common source and this was missed on a normal endoscope. So as Mandar said, we surgeons should invest in some good equipments. So this is all theory. I will just, coming to rebleeding occurs in 10 to 20%, repeat endoscopy may be needed and consider angiographic embolization or surgery. I am done. Those prevention is eradication of H. pylori, avoid NSAIDs, PPIs in high-risk patient and treat the underlying condition. Summary, non-variceal bleed is a serious condition. Endoscopy is key for diagnosis and treatment and early intervention improves the outcome. Thank you.
Thank you so much, sir, for this wonderful presentation. I request everyone to join us for the gala dinner at Fern Hotel at the earliest. Tomorrow's session will be commencing at 9 a.m.
Hello. We'll go directly for a gala dinner without much delay. And tomorrow we have a series of pancreatic cases. Pancreatic cystogastrostomy, pancreatic stenting, pancreatic EUS, pancreatoscopy. So all pancreatic and the colonic cases will be there. So stay tuned, don't go anywhere. Thank you.